Thank you. Good afternoon, everyone. I am Dr. Mayur Agrawal. I welcome you all for this academic session. And as an organizing secretary for the Hormone India Conference 2022, I welcome you all and I declare this conference as open. And before beginning, at the start, we'll have the Saraswati Vandana tech team.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदा नाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदा।
Thank you very much. May the goddess Saraswati bless us with the power of knowledge. And now I welcome my dear colleague, my very well-wisher, Dr. Ajay Shukla, for his welcome speech. He is the organizing chairperson for this conference, Hormone India Conference 2022. He is MBBS, MD Medicine from Allahabad, DM Endocrinology, along with me from SGPGI. And he has also done as MRCP UK Special Certificate Examination, Endocrinology and Diabetes. So over to you, Dr. Ajay. Welcome to the dais.
Thank you, Dr. Mayur. Good afternoon, ladies and gentlemen. I, Dr. Ajay Shukla, on behalf of entire Hormone India team, welcome all our chairpersons, speakers, professors, teachers, delegates, medical students, and all the participants from all over India and abroad. In these 3 days, we will negotiate and renegotiate the nuances of hormone-related diseases from the best subject experts in the country. Hormone system is the body's wireless communication network, with the help of which even the remotest cells stay in contact and learn from each other. Similarly, Hormone India Conference is also connecting us wirelessly in this learning event. For this event, I like to share one of my poems. दूरी में संपर्क का माध्यम है हार्मोन, अधिक और कम में मध्यम है हार्मोन, राग में द्वेष में लोभ मोह रोष में, आनंद में मुक्ति में, काल के प्रभाव में छुपा है हार्मोन। जन्म के पूर्व भी, जन्म की क्रिया में भी, अंकुरण में अवतरण में हम जो बने विराट, सब प्रक्रिया में भी छुपा है हार्मोन। ग्रंथि में, गर्भ में, बाल्य में, किशोर में, रात्रि में, भोर में, लिंग वर्णावली में भी छुपा है हार्मोन। मेद मांस अस्थि में, मज्जा और शुक्र में तेज है हार्मोन। शरीर के तंत्र में मंत्र है हार्मोन, अंग के बंध में स्वतंत्र है हार्मोन, समझ आकर भी जो शेष है वो हार्मोन। तो हार्मोन ही वो है जो समझ आकर भी शेष है, और इसे समझने के लिए ये कॉन्फ्रेंस 3 दिन चलेगी और विल बी लर्निंग फ्रॉम दैट. नाउ आई इनवाइट Hormone India Conference Organizing Secretary Dr. Mayur Agrawal again to enlighten all of us about the concept of Hormone India.
So thank you very much, Dr. Ajay. That was really good. And I also acknowledge that this is actually written by Dr. Ajay. It's not something copy pasted. So really very nice. And after this conference, actually, I got many calls for what is Hormone India. So this concept I want to tell everybody here. that Hormone India Foundation, basically it's a non-profitable organization, and this can be, we can discuss this under 5 heads, I would say. Why actually we build this ecosystem? That was for the group practice, because what we found that during our training, each case was deliberately discussed between the different consultants and all the residents, but that is actually not possible in practice. So that is why we have decided to create an ecosystem where the patient would be benefited, where the guidelines actually don't follow. The guidelines are dicey. The algorithm, actually you cannot fit all the algorithms. Also, different institutes have different protocols, so we took people from different institutes so that we get their knowledge, their protocol, and we can see the patient from different angle. Maybe I miss some diagnosis, maybe the other endocrinologist misses some diagnosis, but as a whole, when we see the patient, then obviously we can create more, we'll have more possibilities of differentials, and whatever diagnosis would be made after so much discussion, that would almost be unchallengeable wherever the patient goes. So that was our first and the primary aim of creating this Hormone India. Other than that, we want to create a system of endocrine institute. You must have heard about this cardiac institute, then all those cardiology and oncology, hematology, but nothing is there for endocrinology. So it's a very big field. If you see here, almost everything is controlled by hormone. So that hormone and endocrine institute, that is something we want to create, the quality check of the lab and all those things we want. Along with that, the third heading, the third main thing was data collection. From India, actually not much research is published, and the data, though collected, it's not uniform, and maybe sometimes false data, and all those things are there. So the quality of the data is also a big problem. So that also we want to cover in this Hormone India Foundation. So research quality data driven decision-making algorithm, that is what we want to build. Along with that, the patient awareness and the educational activities for doctor. That two things also are very important to create overall a ecosystem. So this is like a revamping of overall healthcare structure in India. That is why we have created this Hormone India Foundation, and we will also bring such many conferences in future for the educational activities of doctor, which will include everything right from the beginning, where the MBBS students learn that what are the exercises in the diabetes or how to examine a food, to right at the topmost post-DM endocrinologists or the post-DMs also feel difficult to treat, like the resistant prolactinoma or something, the newest thing. All those things we want to include in those conference. So that is the idea for this Hormone India Foundation. After this, I welcome Dr. Tony. He is the scientific secretary for our conference. He is MBBS, MD Medicine, DNB Medicine, DM Endocrinology, along with me at SGPGI and MRCP UK SC. So I welcome him to discuss the conference briefing. Over to you, Dr. Tony.
Thank you, Dr. Mayur, and thank you, Dr. Ajay, for that wonderful poem. It was excellent and wonderful. So once again, I would like to invite everyone on Hormone India team's behalf and my behalf for this first virtual meeting conducted by Hormone India. So this meeting will span 3 days. We have various sessions from endocrinology and diabetes. The first day we'll be talking on the speakers will be talking on pediatric endocrinology. The major topics include growth disorders, disorders of sex and development, pubertal disorders, etc. Second day, we have dedicated wholly for diabetes alone, where we'll be covering the common problems that we encounter in diabetes, newer advancements in diabetes, how digital technology is revolutionizing diabetes, especially the CGMs and insulin pumps. And in the end, we'll be covering on various infrequently discussed but very common clinical scenarios that are often missed in our clinical practice. So for covering these topics, we have eminent faculties from across the country. We have HODs, ex-HODs, and professors from various national institutes and medical colleges. We have eminent faculty from consultants from across the country, from various hospitals. And this talk is intended for all treating clinicians, because I don't think anyone in India or abroad anywhere will be seeing people without diabetes or without thyroid disorders. So this talk is intended for endocrinologists, general practitioners, treating physicians, and everyone, I would say. So I hope and pray that this topics that have been scheduled will be useful for you and will be helpful in improving your clinical practice. So thank you once again on my behalf and Hormone India team behalf. So next we'll go over to lighting the lamp ceremony. Thank you.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Yeah. So thank you very much. After this, I welcome our own teacher, our professor, Professor Dr. Sushil Gupta sir, who has made us sit here and actually treat patients and learn. So all of us have been trained under him, and he has excellent academic. He is MBBS, MD Medicine, DM Endocrinology, DNB Endocrinology, and presently working as professor at SGPGI Lucknow, where most of us are actually trained. And he has a special interest in bone. So whenever we got the tough case, we actually discuss with the sir. So welcome you, sir. Please be on the dice and enlighten us.
Thank you. Congratulations to whole team of Hormone India with the leadership of all the people, actually. Of course, Ajay, Mayur, and Tony have been spearheading. Is a wonderful attempt, I would call it, in today's scenario of education. As I'm told, Hormone India is really doing a wonderful job in integrating endocrinologists across the country, setting up a platform for cross consultations, setting a platform for doing extremely great quality research by data collection and reanalyzing them across the country. It's a wonderful feat, actually. You are basically overcoming the lot of shortcomings we had with the advantage of technology, advantage of integrating the whole system. So far, the academic sector was confined more to the academics than to the corporate, but integrating all the practitioners of endocrinology under one umbrella is a wonderful feat. I congratulate you all of you to achieve this kind of endeavor. And actually, it is a pretty courageous thing to do that, actually. And I'm seeing that you have reaching a pinnacle of the success with this kind of attempt. And the kind of academic program you have designed by inviting more than 100 best of the faculty across the country, and actually everybody developed some expertise in some area, and everybody is really contributing to a lot. And I'm sure that all the delegates and even the faculty is going to benefit by these wonderful sessions. And the need of the hour is now virtual conferences, of course, where you can spare the travel time, you can spare the nitty-gritty of the hardships of travel, and still you can have the same kind of academic advantage with this kind of medium, actually. I know that I'm getting integrated with Hormone India, with Ajay and Mayur and Priyamda and Tony, all these people. And And of course, this is a virtual one, and shortly, I'm told that we are going to have a physical conference in next few months' time. And of course, in Lucknow, that's going to be a great event. I'm sure about it. And again, congratulations to everybody, the whole team, and I look forward for the great academic feast coming from different corners of the country with different specialized people. Endocrinology is not a single specialty now. It has blossomed to multiple subspecialties actually, and so we are going to have a great academic feast. My best wishes with you, and all the best to all the people. Thank you very much. Thanks a lot.
Thank you, sir. Thank you for your kind words, and thank you for your encouragement. And before our vote of thanks, I'll just introduce the whole Hormone India team. So we have Dr. Adarsh. He is at Hormone India, Bangalore. We have Dr. Ajay from Hormone India, Lucknow. We have Dr. Basavraj from Hormone India, Bangalore. Then we have Harsha Dunna from Hormone India, Vishakhapatnam. Dr. Kanaiya Agrawal from Hormone India, Gorakhpur. Dr. Mayur Agrawal, me from Hormone India, Bhopal. Dr. Pankaj Gupta from Hormone India, Gwalior. Dr. Priyamada Tyagi from Hormone India, Noida. Dr. Shekhar Reddy from Hormone India, Rajmundry. Dr. Shiven Verma from Hormone India, Kanpur. Dr. Tony Joseph from Hormone India, Trivandrum. So for the vote of thanks, again called Dr. Ajay.
So I thank you, my entire team, which made this event possible, and not without the support of all of you, it was possible thing. And I also thank all my seniors, teachers, and elders in this field, that they showed this their humbleness to support us in our this endeavor. We know we are very beginner in this field, and we are really thankful that we got such an overwhelming support, that everyone agreed with us. And with that, I thank every one of you, and I think we can go ahead with the next session.
We still have 2 minutes more left. Dr. Priyamada, would you like to say something? Dr. Harsha, Dr. Tony?
Good evening, everybody. I'm Dr. Priyamada Tyagi. So I remember we were in 3rd year of DM at SDPGI when we started talking about Hormone India. It has taken us about 1.5 years to organize a conference at such a national level, such a big level. And as Dr. Ajay said, that we are beginners in this field, but with the proper guidance and blessings from our seniors like Dr. Sushil Gupta sir, I hope we are moving forward in the right direction. And I think you can expect better results from us, even much better results from us in the next coming years.
Dr. Harsha, Dr. Shiven, Dr. Basavraj, Dr. Pankaj.
Hello.
Yeah.
First of all, good evening to all the senior faculties and my friends. So first of all, I would like to thank Dr. Ajay Shukla, Dr. Mayur, and Tony to organize such a big conference in a short time, and Dr. Priyamada also. So this is like we as a team member doing the things, and hopefully this will go for the long, and we'll organize physical conferences under the guidance of our seniors. I literally thanks Dr. Gupta sir, because he's definitely good mentor to us, and he will guide us in all the direction in the future also. And lastly, also thank to the media persons, and also thank to all the faculties who will be about to talk the area of interest in the next couple of days. So this will be a wonderful session and a wonderful program for all of us. Thank you so much.
Yeah, so thank you everyone for who has joined in, who will be delivering the talk, who has accepted invitation from us as a team Hormone India. I really thank you that you have given us the opportunity, being so junior, being right at the beginning of our career, trough of our career, you have given that opportunity to organize and bring something good. So we'll try to innovate the newer minds, the budding minds. Let's see how we do it. And with that, it's already time 4:20. So I hand over the session to Hormone India Repertoire for the first session. Dr. Pankaj Gupta, you can take over from here.
Am I audible?
Yes, you're audible.
Okay. Hello, everyone. I welcome all the esteemed speakers, chairperson, and audience for this mega event. As we know, we are packed with wonderful presentations. So we will move according to time. We will try to finish all our presentation on time. And this is the first session, and today is the pediatric endocrinology day. So I would like to introduce about the presentation for session 1. So there are 3 presentations. One is approach to short stature. It will be given by Dr. Ganesh Javlikar from Gurgaon. Second would be Dr. Shaila Bhattacharya, enlightening us on growth hormone therapy and indication and counseling technique. And the third one is Syndromic tall stature by Nalini Kopali from Hyderabad. So these were the highlight of the session. So, and I would like to introduce our chairperson, Dr. Mona Sood, and Dr. Shiva Madan, and Dr. Saqib Ahmed Khan. So, as we have to finish topic on time, each presenter have been given 20 minutes to finish the talk. So, without taking much time, I will proceed to start the session. And I will request Dr. Mona Sood to take over this opportunity and to start the session. Dr. Mona Sood.
Do we have you? Yes. Yes. Dr. Saki, Dr. Mona Sood, Dr. Shiva Madan. I can see Dr. Shiva, you can take over. Just introduce the speaker for this first session.
Yes. Welcome to all. This is, we started, the topic is the approach to short statures. As Dr. Ganesh Jabilkar is MBBS, MD Pediatrics and DNB Pediatrics and postdoctorate certificate from pediatric endocrinology. He is a principal consultant, pediatric endocrinology, Max Super Specialty Hospital, Delhi, NCR. He has published more than 20 publications and review for Indian Pediatrics and Indian Journal of Pediatrics on editorial boards of news, letter of global pediatric endocrinology and diabetes. Current area of research in classification of both young onset diabetes and vitamin D in COVID. So now hand over to Dr. Ganesh Jabilkar, sir.
Good evening to all the organizers and all the delegates. And thank you to Hormone India and Dr. Mayur for inviting me here. And my very best wishes for this young and energetic group. And I'm so proud to see so many of SGPGI alumni here. It feels really nice and at home. Thank you so much. As I've been instructed, I have kept the talk pretty much basic, oriented towards general physicians and practitioners. We will be talking over the next 20 minutes, largely with respect to approach or diagnostic approach to short stature. We will not be covering treatment of short stature, growth hormone therapy, etc., which would be discussed in subsequent sessions. I will be sharing my screen, and I hope it is now visible.
Yes, sir. It's visible. Just on the slideshow mode.
Yeah, just a minute.
Just while sir is doing that, sir is also an alumni of SGPJ, so we are really happy to have you.
Thank you so much. So basically, we know that short stature is one of the most common problem that presents to pediatric endocrine clinic. And the etiology of short stature can range from very benign conditions like physiological conditions to extremely serious or critical conditions like a brain tumor. So short stature for us medical practitioners should also be seen as a symptom of a disease, not just a disease per se. So whenever we are evaluating, the questions that come to my mind when I'm seeing a child with short stature is that, first of all, is the child really short? Has it simply been brought to you out of concern of parents, out of comparison with someone else? Is the child really short or not? Second is there growth failure? And as we go along the talk, we will discuss difference between the short stature and growth failure. And what is the etiology of short stature? Now here, you will be largely guided or helped by clinical pointers and growth chart. These are the essential tools in management of or evaluating children with short stature. And these two would guide us to appropriate laboratory evaluation. And then after you make a diagnosis, obviously, you would proceed with the treatment. That will not be covered as a part of this talk. So coming to the first question, that is the child short. Now, how do we decide this? By firstly, accurately measuring height. Although it sounds very simple and stupid to kind of say that the short stature assessment starts with a measurement of height. But even now we get referrals or calls where the pediatricians say that such and such child is short. These are the investigations. These are the results. Tell us, what do we do? Nowadays with the WhatsApp groups, you get all these kind of summaries. And when we ask them, have you plotted a growth chart? Have you taken the height, weight? They have no clue. They haven't really plotted the growth chart. So, and so many of the pediatric clinics that I see still do not have adequate facility of accurate measurement of height. So you need a device which is accurate, not necessarily costly device, but accurate, correctly installed device. And for children below 2 years of age or children who are not able to stand straight, you would measure length. It is important to remember that length cannot be assessed by a single person. You need two people to make sure that the head of the child is stable and firmly stuck to the head plate of the infantometer, and the legs are in the correct position. So you cannot measure, one single person cannot measure length. You need two observers for that. As the child is standing, we make sure that the frame of the stadiometer is exactly perpendicular to the ground. Often the walls have a kind of curve, and that kind of can cause minor errors, and these minor errors can be significant with respect to evaluation of short stature. In even an error of 4 or 5 millimeters can change the diagnosis or can change the assessment of response to therapy. We make sure that the footwear is removed and the heels, buttocks, shoulders, and occiput are touching the wall or touching the vertical surface. And the skull is in the Frankfurt plane. For this, we have to make sure by putting a hand under the chin so that the child is not looking down or not looking up like this. That can cause measurement errors in height. These are the common sources of errors. And then not just measuring, but plotting height is also important. You cannot just look at tables, or you cannot just use some sort of a formula that is given in Nelson to say that this should be the height, and because it is not that much, the child is short. You have to plot growth chart. You can do it manually, you can do it digitally, you can use a IAP app, you can do whatever way you want it. I still prefer good old paper and pencil to plot growth chart. And you plot the height and weight as a tiny dot, not as a big target mark or something overlapping few months on the growth chart. You just plot it as a tiny dot. On the extreme right side, that is the adult or 18 or 20, whatever line the growth chart is ending at, you plot the target mid-parental height. We will come across the formula for mid-parental height in the subsequent slide. And you above and below that, you plot the mid-parental target range. Then from the weight and height, you can kind of correlate the weight and height or direct the weight and height to the 50th centile to see what is the height age, which means the current height of the child corresponds to average of what age with respect to the Indian standards. Similarly, you can calculate weight age. You can plot bone ages as triangles on cross on the growth chart also. And this gives nice differential diagnosis for evaluation of short stature. It is not necessary, as I said, that the equipment has to be a Harpenden stadiometer, which is available to very few institutes in India. I have been lucky to have it in my training as well as in my practice. But it is fair enough. I mean, but what we commonly see is what must not be used is these papers which are installed on the walls. They are notoriously inaccurate. I have never seen a reading which has come from these as accurate reading. Also, the device is correct, but the installation has not been taken care of. So, for example, in this, you can see that the installation is not correct. So you can use these cheaper country-made devices also, but make sure that the installation is correct. So these typically have 0 to 200 centimeter range of height. And when you draw the stadiometer completely to the ground, the marker of the stadiometer should correspond to 0. So this we have to make sure that the installation is correct. Now, which children need workup? Typically height which is below 2 standard deviation, that is roughly corresponding to 3rd centile for the age, sex, and ethnicity, which means that we should plot the growth on Indian growth charts, not Indian children on international growth charts. Or if the height is significantly below mid-parental target range, which is calculated by this formula, it is available in all standard textbooks, you could refer to that. The 13 refers to the adult male-female height difference. That's why for a boy, we add 13 to mother's height, and for a girl, we subtract 13s from father's height. And in Indian growth charts, the standard deviation of height, like the heights comes to about 6.5 centimeters. I prefer to use 1 standard deviation above and below the mid-parental range, because for somebody who is on the lower side, the 2 standard deviation, that is 12 centimeters, may come 2 below the normal, and you may actually miss out on the pathological conditions. The purpose of evaluation is to pick up pathological conditions of causing short stature. Or if you have height which is in the normal range, but there is evidence of growth deceleration across 2 major centiles, these children must have a good workup done. If you have disproportion or dysmorphism, which is suggestive of syndromic short stature, or in some cases, the evaluation may even be anticipatory. For example, nowadays, a lot of brain tumor survivors receiving significant amount of cranial irradiation, or children with leukemia who have had cranial irradiation, they need anticipatory evaluation. And sometimes they could have combination of problems like growth hormone deficiency along with precocious puberty, which can make the evaluation a bit complex. Coming to the second question of, is there a growth failure? To address this question, all of us should be aware about growth velocity, which basically means the difference in height measured over 2 time points divided by the number of months between those 2 time points. For example, if I measure the height in January and July over a period of 6 months, the height that the child has gained, let us say that the child has gained 3 centimeters of height in 6 months. So 3 divided by 6, that is 0.5, into 12, that is 6 centimeter per year will be the growth velocity of this particular child. So there are normal values in textbooks as well as in several publications. We can refer to the normal values of growth velocity. But it is important to remember that children do not grow uniformly. So it is not necessary that in every 3 months the child has to gain 1 or 2 centimeters. So, I mean, for correct interpretation of growth velocity, you need to observe the child for 6 to 12 months. For younger children, I would prefer to see them for nearly 6 to 12, at least like a year before I comment about what is the growth velocity. Sometimes children coming late or those who are in puberty, the window of opportunity or window of observation may need to be tailored towards a little shorter side. Still, a 6-month observation is required for most cases. What is the importance of growth velocity? So, for example, in this particular growth chart, you can see that this child is short, but the child has normal growth velocity. So this is an example of short child with normal growth velocity, which goes with physiological conditions like familial short stature or constitutional delay of growth and puberty. Whereas in this growth chart, if you see a single reading, the child appears to be in the normal range. But if you plot previous readings, you can see that there has been a growth deceleration. So this is growth failure. And the child with growth failure has to be evaluated because growth failure is invariably likely to be pathological. Short stature may or may not be pathological, particularly if the child is just below the normal. In most of the situations, the diagnosis is physiological conditions like familial short stature or constitutional delay of growth and puberty. There are some situations where there can be a so-called physiological growth faltering, typically in the first 2 years, the child at birth, the size depends on maternal nutrition and several other factors, and the child tends to track towards the genetic potential in the first 2 years. Or if we are changing from length measurement to height measurement, there can be a small difference because because of the effect of gravity, the height will be a little small amount less than the length measurement. So therefore, there can be a apparent lack of adequate growth velocity when we are changing from length growth charts to height growth charts. Also, in this growth chart, you can see that there is this slight so apparent growth failure followed by a normal growth. This is a pre-pubertal dip. So just like starting slow and then running fast, just a step back before you run fast. Pre-pubertal dip of growth velocity is common, and that also needs to be kept in mind. What is the cause of short stature? To think about causes of short stature, you need to know what all things we need for growing normally. So we need genes. We need largely about 80% of our height is determined by our genes. So the parent's height, parent's pubertal pattern, etc., is very important. And several genes affecting the growth hormone axis, where also the other genes which are involved in cartilage function or bone formation, etc., are also important in terms of stature development. You need healthy bones. You need adequate food, and the food needs to be absorbed properly. And this lack of adequate food, actually, even in utero, can cause long-term consequences like adulthood short stature for children who are born SGA. You need to be healthy, which means you need to be disease-free. So systemic diseases can cause short stature. And you need to have hormones at various stages. Different hormones are important. Thyroid hormone throughout your childhood, growth hormone also, but predominantly growth hormone affects the childhood growth. And during puberty, the sex steroid and augmentation of growth hormone secretion by the sex steroid results into the pubertal growth spurt. And you need loving and caring atmosphere. So if you have significant family discord or several psychosocial problems in the family, that could also lead to short stature. Typically, many systemic diseases would have their own symptoms and signs, but there are certain conditions which can just present as short stature. This includes celiac disease, renal tubular acidosis, chronic kidney disease, or inflammatory bowel disease, and very rarely even poorly controlled asthma without any so-called obvious history of being asthmatic. Common endocrine conditions, not just growth hormone deficiency, but also other conditions like hypothyroidism, more common than growth hormone deficiency. Cushing syndrome, rare but important condition to be kept in mind, and poorly controlled diabetes can cause short stature. And after we have ruled out all these conditions and we have still not been able to figure out what is the cause of short stature, then we label them as idiopathic short stature. Workup, like any other condition, history and clinical examination is most important. Many of you are all aware about the detailed history that we must take, but there are some things which we often tend to forget, which are important with respect to history of short stature. We must ask about what was the birth rate. Many of the children are born SGA, and about 10 to 15% of them may end up as adult short stature. They may not catch up. Also, the pattern of pubertal growth in family, that is very important and often missed in history taking. You will obviously be inquiring for several systemic diseases, nutrition, etc. In terms of examination, accurate anthropometry, plotting the growth chart, looking from head to toe for signs or clues which are suggestive of causes of short stature. We'll go through some details. All pediatricians should now be, as they deal with adolescents now, should have an orchidometer in their clinic and should be having a chart which is teaching them about Tanner staging so that they can assess the Tanner staging of adolescents. So as I said, that plotting the growth chart is extremely important. In this growth chart on your left side, you can see that this girl is significantly short and her weight is not that much affected. So her height age is actually just 3.5, and her weight age is about 7 or so. In this sort of a situation, endocrine cause or a syndromic cause is more likely. So this particular girl had hypothyroidism, which has severe amount of growth delay and bone age delay also. Whereas on the chart, in the chart on the right side, you can see that this child has come with short stature. But if we look at the sorry. If we look at the weight readings, you can see that there has been significant faltering of weight gain from many, many years. This child was being managed as chronic malaria or Kala Azar because he belonged to that particular belt of India. However, after initial presentation as short stature, nearly 2.5 years later, he developed significant joint symptoms, and he had actually juvenile idiopathic arthritis. So where weight is affected before the height, the chance that it is malabsorption or a systemic condition or a psychological cause like anorexia nervosa in girls, etc., that is more likely if weight is more affected or more severely affected than the height. So in this particular case, it was juvenile idiopathic arthritis. So this slide also tells us the importance of measurement of weight and assessment of weight in the differential diagnosis of short stature. So it's not just the height. I mean, there can be several clues on clinical examination. Just to give example of a few examples, this is a girl which is after asking her to make a fist and seeing the knuckles, you can see this dimple at the fourth metacarpal, which is suggestive of a short fourth metacarpal, which is most commonly seen in Turner syndrome. This girl with short fourth and fifth metacarpal had pseudo-hypoparathyroidism, another condition which can have brachymetacarpia. This boy, this was my patient in SGPJ actually. He's 3-year-old, but looking like a small infant with frontal bossing, with bluish tinge of sclera, depressed nasal bridge, and midfacial hypoplasia, has growth hormone deficiency. Whereas this boy has puffy cheeks and weight gain with poor height gain, suggestive of Cushing syndrome. It is important to strip the child completely. And some of the clues are apparent, like for example, in this case, the lordosis, that exaggerated lordosis that you see, is apparent only after you kind of strip and observe the child properly. So this child had spondyloepiphyseal dysplasia, whereas the child on this side had severe rickets, type 1 vitamin D dependent rickets causing short stature. How do we decide on the tests required? If you have a child which is totally normal on growth and on history and examination, and height is normal for population, the child can be reassured and followed up after 6 months to document the growth velocity. If the child is short and the cause is obvious on history and examination, you do only that specific test to confirm the cause. Whereas for most of our children who come to us, short child with no obvious cause on history and examination, we do a set of tests called as screening investigations. As I have said earlier, all children with growth failure or growth deceleration need to be investigated right at their first visit. A common mistake in ordering bone age is just to write for wrist X-ray. We should write for the entire hand or hand plus wrist X-ray and interpret the X-ray with the help of bone age atlas, not going by vague radiological reports of 9 to 12 years or 5 to 13 years, etc. This is the list of tests that we commonly do. In terms of deciding on IGF-1 or IGF-BP3, you can take individual case-to-case based decisions. They are costly tests, so please think carefully before ordering these tests. Celiac screening can be done as a screening test in northern or central India, but for western or southern India, it can be reserved as a second-line test. So you can kind of modify it based on your scenario. And if we don't identify any cause of on these tests, and if the child is just borderline short, the child can be observed for 6 to 12 months for documenting growth velocity. And if the child is significantly short or has had a significantly low growth velocity, then there are several second-line tests. But please remember that not everything is to be done for everyone. We have to take our clinical parameters to decide which all tests are important. Particularly, karyotype is important in girls with unexplained short stature.
testing for renal tubular acidosis. And in today's day, before children with severe short stature, particularly height below 3 standard deviation, even we need to consider genetic testing. Just last couple of slides, I'll finish. Just few case scenarios to address common problems that we face in OPD. So this is an 11-year-old boy with mother worried about short stature, and the boy feels very bad that the girls of his class are taller than him, and clinical examination history, otherwise everything is unremarkable. This child is, if you plot the chart and you see as per the mid-parental height, the child is totally normal. So all this child needs is maybe some reassurance. If I have some previous readings, which also shows that the child was always on that line, that helps. Otherwise, we could observe for 6 months. But all this child needs is just talking in terms of the difference of puberty of girls and boys, and why the girls are taller than the boys of his class. And doesn't need a lot of tests or a lot of vitamins or hanging or stretching or all sorts of maneuvers that people do to make their children tall. Another common scenario and very important one, a 12-and-a-half-year-old girl was referred or came rather with short stature and has had menses nearly 2.5 years ago, and now the height is not increasing. Now, at this stage, it is very unlikely that any of the intervention of growth hormone, etc., is going to help. So these kind of delayed referrals are very common. And it is important to recognize that SGA or any condition which can cause short stature is best managed if it is diagnosed early. As I said about familial short stature, that the child is appropriate for family, but if one or both parents are very short, then we need to think of pathological conditions and we need to evaluate these children. And this is a growth chart where the child shows evidence of growth failure, a significant bone age delay, a low IGF-1. And this is the scenario where a growth hormone deficiency would be suspected and confirmed with the help of a growth hormone stimulation test. We do growth hormone stimulation test for most of these children, except for few where there is overwhelming evidence clinically as well as neuroimaging wise, and a low IGF-1. In those, as per the 2016 guidelines or consensus guidelines, sometimes we may skip, but for most children, we do continue to do stimulation tests. These are specialized tests. They cannot be done by anybody. So they have to be done at reliable centers, and they have to be done by people who are experienced and used to doing these tests. Some of these tests, like insulin test, can even be dangerous. So therefore, do not do these tests just as a general practitioner or pediatrician. These have to be done at specialized centers. So I would just end up by saying that measure height, not just weight. This is the problem for most children that we see in our OPDs. And plot the height longitudinally on the same growth chart. Not that the child is coming with 5 growth charts with 111 height plotted on each of them. Weight measurement is important for differential diagnosis of short stature. Get used to assessing puberty by Tanner staging. Keep an orchidometer with you for estimation of testicular volume. And the workup has to be guided by clinical findings. Don't just order a battery of tests for anybody who walks in your OPD with short stature. And before ordering specialized tests like karyotype or these growth hormone tests or IGF-1, etc., keep endocrinologist or pediatric endocrinologist in loop. Thank you so much, and I'm sorry for overshooting a bit.
Thank you,
Dr. Ganesh. Very large topic, nicely summarized. And quickly, we will move to our second presentation. So I will hand over mic to Dr. Shaila Bhattacharya for the next presentation. Over to you, madam.
Yeah, and Dr. Saqib, I just welcome you. He has joined. He is a consultant endocrinologist at Chandan Hospital, Lucknow. Please, Chairperson Dr. Saqib Khan, introduce our next speaker, Dr. Shaila Bhattacharya.
So, good evening, everyone. So, the second topic will be delivered by Dr. Shaila Bhattacharya ji. She has done her DM from PGMR and she has done MRCP. She is a pediatric and adolescent diabetologist and endocrinologist at Bangalore. She's also a visiting professor at Bapuji Child Health Institute, Devanagari. She is also a president in ISPA, in 2021-22. She has been an author in endocrine and pediatric textbook. So without wasting any further time, she will be discussing about growth hormone therapy, the indication and counseling technique. So we know that growth hormone deficiency is a less common cause as compared to other commoner reasons, and we will have to confirm that if the patient is having growth hormone is having a growth hormone failure or short stature, and then followed by an evaluation, and then followed by the its biochemical evidence should be there, and after the words, then we will have to confirm that what is the reason, and then we will have to decide that how it should be replaced. So she will be telling more about this, and I would hand over the mic to her. So, welcome, Dr. Shala.
Yeah, thank you very much, Dr. Sadiq, for the kind introduction. Good evening, everybody. I thank Dr. Mayur and his team for this really big academic event where there are more than 100 speakers and 1,000 delegates, or more than 1,000 delegates. I would like to congratulate you for this mammoth task. Ganesh has already given the gist and how to do a lot of things in a child who is coming with short stature. So today, Dr. Mayur has asked me to talk about growth hormone therapy, indications. So I'll touch upon indications, and he's more interested in counseling technique, how to get more patients and how to convince the patients. So let me see if I can do that in next 15-20 minutes. I will start off with my case, whom I saw. This boy was seen about 20 years back. So chart is also one of the old ones. And you can see here, he was short and he's 8 years and he's only 95. So on an average, if you think he's only 4 years old and he's had normal body proportion. So we have ruled out the achondroplasias or hypochondroplasias or any other disproportionate short stature. He was intelligent and active. So hypothyroidism is a little bit ruled out, but not completely. But if you see here, he has got very immature face with a small mid face and frontal bossing and chubby face. He had delayed dentition and micropenis. So putting everything together, delayed bone age, normal thyroid functions, MRI was done, it was normal. We went ahead and did clonidine stimulation test, and the maximum growth hormone response was only 1 nanogram per ml. So we made a diagnosis of growth hormone deficiency. And you can see this boy, after 4 years of treatment, he has just gone above, like climbing a ladder. So this is what is the response. If you're really diagnosing the condition correctly, giving the correct dose, and doing proper follow-up. And every visit has to be with good counseling. And you can see what is the change in this boy after 4 years. So if you see the effects of growth hormone, why are we talking so much about growth hormone? Growth hormone, hypothalamic growth hormone, IGF-1 axis, you can see that we have both the stimulatory and the inhibitory from the hypothalamus, and then we have the release of growth hormone, which has effect on all these things. Has a fat breakdown, skeletal muscles, it takes glucose uptake. Then there is glucose release, has the liver acts, combines with the receptors, and along with the IGF-1 has got all these effects, including protein synthesis and bone elongation. But more than this, as a practitioner, I think you need to know these three graphs. You need to know that this growth hormone is secreted in pulses, at least 8 to 10 in a day. And you can see here, it is the during or just about to sleep, there is a nocturnal surge. That is one thing. Two other things are, you can see here, it is in the nocturnal and during the puberty. So maximum growth happens during the puberty and in the night, and it is pulsatile. So doing random growth hormone is completely banned. That is the reason I have put these graphs. So what are the FDA approvals? We don't have any Indian approvals as of now. So we always follow the FDA approvals. It was as early as 1985, the pediatric GHP was approved first. Then was the chronic renal failure. Then came the Turner syndrome and adult GHD, HIV wasting syndrome. Then in 97 was achondroplasia. You can see that dysmorphic child. And then in 2000, Prader-Willi syndrome, where you can diagnose short stature, hypogonadism, and obesity, either by methylation or by fish technique. You can diagnose Prader-Willi syndrome. And then 2001 was SGA. We are still lacking in that. We are not picking SGAs, and that was one of the indications in 2001. And 2003 was the idiopathic short stature. Dr. Ganesh has already told, when you have done all the tests and all the reports are normal, then you call as idiopathic short stature. So 2003, short bowel and idiopathic short stature were the indications. And then it came the transitional of the growth hormone deficient children to the adulthood, where all my friends sitting here would be taking care. And then 2006 is the shocks, and then was the Neonatal syndrome. So this is how all these indications came till 2010. After that, we don't have many indications. But if you see, the growth promoting indications of growth hormone are only for these conditions. That is pure GHD, Turner, shocks, ISS, chronic renal failure, Neonatal, skeletal dysplasia. But for the metabolic conditions, we are using growth hormone for Prader-Willi, HIV, adult GHD, and short bowel. So after the bones are fused, there is no point in using growth hormone. You want to make the child tall. So you have to make sure that there is still the open epiphysis before you think of giving growth hormone. There are other indications, lot of trials going on where GH is given, but these are not FDA approved, like Precautious puberty, very severe short stature along with familial short stature, who have attained or who have had precocious puberty. Then you can give GH with GnRH, glucocorticoid induced short stature, CAH, thalassemia major, XLH, Rickets, skeletal dysplasias, syndromic short stature, and cystic fibrosis. But none of these are approved, and even after a lot of trials, there is no good growth velocity in this team. So what are the etiologies of growth hormone deficiency per se? So if you see here, when we investigate, 40% of them are idiopathic. Then we have the acquired, which is because of the tumor or radiation or any autoimmune response or because of the CNS infection. Then is the congenital GHD because of the mutations or structural defects, and the syndromic syndromes associated with growth hormone deficiency. Going back to basics again, who needs to be investigated? All children who come to you should be investigated for any of the FDA approved indications, or are there any particular conditions? So first thing what you need to know basic is your growth charts. You have to be thorough with your growth charts. So you can see here, this is below third centile, but it is quite severe. So maybe -5 SD or so. So severe short stature below third centile needs to be investigated. You can see here height SDS, SD below the mean for the age and sex. And here you can see the height is less than 1.5 SDS. You can see that the mid-parental height is there, but the height of the child is well below. So this child definitely needs investigation, even though the child is more than the third centile. Next is if the growth velocity, you can see here, there is a growth velocity is less than 25th centile, then you need to do investigations. Growth deceleration, if you are properly monitoring, or if the child has not been growing, then you need to check if there is any problem, and you need to investigate for either growth hormone deficiency or any other conditions. They are coming with short stature. The predisposing conditions, we know that if the child is being operated for any other CNS conditions, or child has had any meningitis, encephalitis, or had a PMT done. So all those conditions have to think and have a proper growth chart and monitor this. Some other indications where you need to monitor growth and be aware is neonatal hypoglycemia, midnight effects, any intracranial lesions, signs of multiple hormone deficiency. So some of the clinical manifestations of growth hormone deficiency I have already told. Maybe only short stature. Like in girls, it may be only short stature where they can be Turner syndrome, she is short. So you have to do the investigation appropriate for the sex, age, and condition depending on the clinical examination. So in the neonatal period, you can have hypoglycemia, microcephalus, hypothermia, jaundice, or dysmorphic features. Whereas there are so many other things, but the most important thing is the growth retardation, which you need to be aware of, make a diagnosis of growth hormone deficiency. And you can see here there's a cleft lip central effects, cleft lip, cleft palate, central incisor, micropubis. These are the things. If a short child comes to you and you get a good history, so you can make a diagnosis of provisional diagnosis of GHD. Once you think clinically as GHD, what are the imaging studies? Dr. Ganesh has again told about the bone age. Don't cut off the phalanges or the fingers. So you need a good bone age and a proper interpreter. Then you require an MRI if you are thinking that it is GHD. You need to do biochemical investigations like growth hormone and IGF axis. You need to do random GH, as I already told, is not considered. You need to do GH stimulation test, and there is again very pivotal or pivotal age group, whether you need to set steroid priming required or not. There are two different schools of thought, but I believe in priming, and I prime the child before doing growth hormone stimulation test. Very pivotal age group, about 10 years, and we can also do genetic evaluation, and you can find some mutations which can help you in the further planning of the condition. So what are the GH stimulation tests? So any stimulation test, whenever you are planning to do, you should never do it in an OPD without a backup support, because you never know what can happen while you are doing these tests. So they have to be monitored whenever you are doing growth hormone stimulation test. Any textbook will give all the values and the doses for these things. There are physiological, pharmacological, but what we do in India is most commonly is clonidine, then is arginine and glucagon. And GHRP2 and mesimorelin are used in adult GHD for doing a GH stimulation. But as I believe, I have been trained till now, I still believe it is the ITT or GHRH, which is the gold standard if you want the accurate GH values when you are doing a stimulation. And the prerequisites before you do a GH stimulation test is child should be in thyroid and in cortisol. So you have to do these thyroid functions and cortisol levels before even thinking of doing a stimulation test. Child should not have intercurrent illness and sex hormone priming in peri-adolescent age group, which I already told. And at least 2 tests are required, and child should come fasting. And when you do a GH stimulation and the values are less than 7 nanogram per ml, or is called GH deficiency, if it is less than 3 nanogram, then it is severe growth hormone deficiency. When you examine the child and you see that there is a syndromic, like any of these syndromes, then you don't have to do a stimulation test and you can straight away go on and start growth hormone piece. Again, talking about IGF-1 and IGF-3, we do not do IGF-1 below 3 years because a lot of things are dependent on, IGF is dependent on nutrition, illness, and liver diseases, but not below 3 years. IGF is better below 3 years. We do have some norms. Whenever you do any test in endocrinology, you want to do, you should know why you are doing, how you are doing, and how you will interpret. If you don't know these 3 things, never do the test. That is what I would tell. So you do test and then you please interpret them along with the standard values. MRI brain and is to see if there is any size of the pituitary, see for the posterior pituitary, see if there is any other abnormalities associated or if there is a mass lesion. You can see here small pituitary. You can see here septo-optic dysplasia and absent stalk interruption syndrome. You can have a mass lesion and you can have septum pellucidum. So MRI gives a clue for the etiology of growth hormone deficiency. So once you have made a diagnosis by clinical, biochemical imaging and stimulation test, then what growth hormone you would give. Before telling what growth hormone, what is the dose of growth hormone? When we were postgraduates, we used to use IU per kg per day. It was very, very simple. If I had a child of 10 kg, then it would be 10 into 0.1. So it would be 1 unit. So it was very easy. 20 kg child, 2 units. But now all companies have made milligram. So this is the conversion. So 1 mg is 3 IU or 1 IU is 0.3 mg. So if you want to give 2 IU, then you have to make it 0.6 mg. So you need to know how much to give and what dose you have to give and when to give. See here, there are so many things. Don't get confused because all the references will give. But I still follow this IU and then convert it. Or else I use this whenever the child is overweight or obese. Any of our conditions like growth hormone deficiency, Turner, PWSs, all these are obese children. So in them, it is always better you calculate by body surface area. So meter square, mg per meter square per day would be the better way of calculating, and this would be the dose. So what are the growth hormone available in India? We have these biosimilars, head-on and bupropion. The disadvantage is we have to draw from the syringe, and each vial will have 4 units. So have every 10 marking will have one IU, and this comes as IU. So you can, if you want to give 2 IU, you have to take the number of 20. So if something is remaining, then you can take it for the next day. But the bioavailability is not there for more than 48 or 72 hours. So you need to be careful when you are telling them. If you are giving 1 unit for 4 days, then it may not be very suitable to give for these children. Next is we have Noditropin from Novo Nordisk. Get these beautiful looking pens with the different mgs, 5 mg, 10 mg. Yellow is for 5, blue is for 10, and green is 15 mg. And if I tell you the cost of this one, on an average, it's about 180 to 200 rupees for 1 IU. And the next, both these Genotropin from Pfizer and Noditropin, they are around 300 plus for 1 IU. The method of doing this is, one more advantage is it's very easy to give in this Noditropin pens because it is a ready liquid. Whereas here, there is a liquid and a powder. Once you mix it, it is very easy. And another advantage in this Genotropin is, in this one, you can just fix the dose. If you want to give 0.6 mg, you can fix it till your next visit for 3 months. And it is this one only, you'll dial this and click it. And while you are giving it, give it and then count up to 10 or 20. So the other available ones are Season, and when and how you give is, there is no shortcut. It has to be daily, like how you eat every day, how you sleep every day. It has to be given daily, and it is given at night before sleep. Cannot give it at 5 o'clock or 6 o'clock and tell them you will grow well. It has to be, because it has to mimic the circadian rhythm of the growth hormone. Next is, it has to be given subcutaneously. This is how you pinch it. It is similar to insulin. So you need to tell them and teach them. Next is how to store. Never store in the deep freezer or in the door. You have to keep in this compartment. These things have to be really, every visit have to be asked and taught and again and again enforced. Otherwise, your results will be bad. Monitoring, main thing is your height velocity, and if the child is GHP, there will be doubling of height velocity. And the next thing what you do is the IGF-1 values. You need to do IGF-1 once in 6 months, preferably once in 6 months or once in a year. And you have to make sure and compare it and check it where the child is falling. The IGF-1 is falling, whether it is in the +1 or +3. If it it is going more than +2, then you have to reduce the dose. And if the child is not growing and it is, then you have to check if there is any other problem, whether the child has developed hypothyroidism or hypocortisolism. And next would be, you have to check for the adherence and adverse effects also. The adherence you can check by checking how many vials they are using, how much you have prescribed, and monthly how much they are buying. That is the way how you can check. Because of the cost, they may not be really taking regularly like what you have advised. The response to the growth hormone treatment depends on the age. Earlier the age, earlier the diagnosis, better is the outcome. Severity is the GST, very good results. Frequency, which I have already told, daily, not twice daily, only once in the night. The dose, exact dose has to be given, and other than GST, most of the other conditions will require a slightly higher dose. And then the bone age delay is more, then the response is much good. And the genetic potential, if you have tall parents, then again your genes will be playing and you can always get better results in this. You can have suboptimal growth response because of poor adherence, because of the high cost and late initiation, subtherapeutic dose, or if there are any antibodies, which are very, very, very rarely, and the comorbid conditions, hypothyroidism. And lastly, but I wouldn't tell that, incorrect diagnosis. That is because if you are giving after the growth hormone, after the bones are fused. The potential side effects, every visit, every 3 months, you should call them and check by both history and examination. Edema or headaches, check for scoliosis, and then see for limb pain. These are less common, acute pancreatitis, but hyperinsulinism, if you are giving large dose, you can develop glucose intolerance and high hemoglobin A1C. And we do get gynecomastia in the pubertal age groups, but once you reduce or stop the medication, it disappears. Obstructive sleep apnea, and then malignancy, I'm not going to touch, but just to tell, no need to worry. If there is a family history, known case of malignancy, or if radiation, especially high dose, is used, then the risk is there, but otherwise you can safely. To finish off, I want to just share a couple of my cases. She is the girl who came to me, and you can see here at 9 months of age, and she was only around 64 centimeter. I did try to convince her, but she was not convinced. They said they don't have financial support, and they left. And then again promptly came back at 15, where she was exactly in the same height, and then was able to convince her and then put her on growth hormone. And you can see by 3.5 years, my last visit when I saw her, beautifully she has grown, and you can see the difference here. And also from 65, she has come to 95. So once you have made a proper diagnosis, the response is excellent, but counseling is what is very much required. And also convinced them to do a genetic test, and we found a GH1 mutation in this little girl. So going on to the next case, this is a sad story of 2 siblings. They again came to me. She came at 18 years, 16 years, and again financial problem, and came again at 18 years. She had not grown, and you can see the difference, and she was only about 105 at this stage. Second visit, father got the brother also, who is 12 years, and he's also short. He got some money and did the genetic testing. Both of them were Prop1, and they both come from Calcutta. So we have referred them back to PGI because they get free growth hormone. I need to follow them up in their next visit. So it is always very good if you are doing a complete workup, complete diagnosis, and you reassure them. And my last case is again this girl. You can see her GH stimulation was subnormal, but once you start treatment, started around 6-7 years, and you can see she's already reached the normal centile, but they still want to give because the mid-parental height is here, so we would continue. And even her genetic report came as GHRHR. So lastly, the role of GnRH analog and GH, because there is a trend in a lot of doctors using GnRH analog to postpone their puberty. It is not usually recommended unless there is a severe short stature. For example, I had a child who was 12 and a half years, but her height is 130, but she started years. So what will I do? I think that is the only indication here I can go. Not much use, and no trials have not helped. There are few newer growth promoting agents who are on trial. Long-acting GH, weekly GH has been used. Eutropin from Cipla has been used, but now again it has gone out of the market because of some side effects. Oral ghrelin analogs and CNP analogs have been in phase 3 trials. We need to watch for the results. So to complete my talk, the take-home message, I think Ganesh and me both tell that growth charts are a must in your office practice. Otherwise, please don't practice endocrinology. Short stature is more of a clinical diagnosis. Never do a random growth hormone levels. Accurate diagnosis, early diagnosis, early treatment, better outcome. We are only a phone call away. Please reach to us from any corner of India. We are here to help. Our children have very short time to grow and a lifetime to live the results. So please help them out right time. Thank you very much.
Thank you, ma'am.
Thank you, ma'am. Nice presentation. Well explained growth hormone therapy. Now we'll move to our next presentation. I will hand over to Dr. Mona. Dr. Mona Sood, are you there?
Yeah, hi.
Yeah, ma'am.
Hi, everyone.
Ma'am, please introduce our next speaker, Dr. Lakshmi Nalini Kopale, and please start the presentation.
So, hi, everybody. I congratulate Hormone India for organizing this conference and enlightening us, all of us here. So not wasting much time, I think Dr. Lakshmi doesn't need an intro. She's known to all of us profile endocrinologist. She's MD and DM endocrinology and presently working as associate professor at Shadan Institute of Medical Sciences. She also had been a consultant endocrinologist at Fernandez Magna Clinic, Hyderabad. She has been a research guide for a number of students, including the pharmacy students, and a member of institutional review boards at SIMS and Fernandez Hospital. Along with this, she is also a reviewer of Indian Journal of Endocrinology and Metabolism and sub-editor of newsletter of Endocrine Society of India. So she has a lot of achievements and in her career, and not wasting much time, I would welcome Dr. Lakshmi to enlighten us with her lecture. Thank you, ma'am.
Thank you so much for the kind words of introduction, Dr. Mona. At the outset, I'd like to congratulate Hormone India for having such a spectacular meeting and gathering today. And thank you so much for having me here today. In the growth segment, the first two speakers have elaborated about short stature. I would be speaking today about something different, tall stature, but not the usual tall stature and all that. We'll be speaking about the syndromic tall stature today. Let me share my screen. Is my screen visible?
No, I'm not yet.
Now?
Yeah.
Yes. Just give me a moment. Right. So I would be dealing this in the following 4 headings. The background of tall stature, growth patterns in children with tall stature, syndromic tall stature in specific, evaluation and management to some extent. So background, coming to the phases of human growth, it's very important to understand that 30% of the adult height is achieved within the span of 9 months of intrauterine life. So intrauterine factors play a major role in this phase. Followed by the next rapid growth phase is in the infantile phase, wherein within the first 1 year, the infant gains about 15% of adult height. And childhood, the period from around 1 to 2 years onwards, till the prepubertal phase of about 6 to 8 years, the child grows about 40%. And then the pubertal growth spurt contributes to the next 15%. You see here the various factors which can impact the growth during these phases. And these can also lead to diseases, both short stature and tall stature. So what is tall stature? Tall stature is defined as a height which is more than 2 standard deviations above the mean height for a given age and sex for the population. We see about 2.3% of our population being the tall stature, but how many do we see in our clinics and hospitals? Not much. Why? Because there's a lot of social acceptability. People almost always want to gain height, and then they don't want to be short. And it is most of the times a family trait. Whenever a person suddenly is very tall, taller than the parents, they say that the grandparents, some uncle is very tall. So that familial trait is very important in making somebody tall. And this being very acceptable, the referral rate is very less and happens only when the height is beyond 2.5 to 3 standard deviation score. So referral is more likely only then, and problem usually is identified a little later only. So why do we think there is a problem here? Why should we look at tall stature as a problem? We need to understand two things. Most of the tall stature people are very healthy and they're non-syndromic, but it is important and essential to identify the pathological causes. Though the numbers may be small, the impact of the other problems, systemic conditions, which accompany the tall stature can jeopardize the life and increase the morbidity and mortality. So what do we look at it? So we take a few handles and we look at certain features while evaluating tall stature. First one is the tempo of the growth. The second is height in relation to target height. And third is pubertal and skeletal maturation. How is the puberty? What is the bone age? That's very important. And the last but the most important thing is identifying the syndromic features. So these are the handles. So taking this background with us, let us understand the 4 basic patterns of growth in patients with tall stature. In the first graph, you can see that very clearly. The child has been tall since birth, always on the higher side. See, that is familial tall stature. We'll come back to what these patterns mean to us. In the second pattern, you see that the child has been more or less okay for almost mid-childhood. And then suddenly there's an increase in growth, and which is continuing without stopping. And the final adult height is very high. This is pattern B. And in pattern B, you see 2 lines here. There is an increased growth, and the growth is always on the higher side, but after a certain time, the growth slows down and the ultimate height is normal in graph C that we're talking about. And then the dotted line in graph C, you see, when you find a child around 7 to 8 years of the age, the child is taller than the peers. And then gradually the height velocity slows down and the ultimate height is short stature. We all know what it is. We'll come back to that. So this is pattern C that we see. And this is the usual 4th pattern, pattern D that we're talking about, wherein there is a continued growth in the mid centile, and then suddenly it starts increasing after about 12 to 13 years of the age, and it continues going on with an upward slope. So let us see which conditions we are here. First one is familial tall stature, very common. So the child has always been tall. So large for gestational age, no dysmorphisms, no intellectual disabilities. The adult stature is also tall. Everyone is tall. The child is also tall. So the growth pattern is the pattern A that you can see here. And then the next one is CAG. So in this, there is no LGA. There is no dysmorphism, no intellectual disability, and ultimate adult stature is normal. What is happening here? There is a sudden growth spurt that is happening a little faster than the peers, and then again it is normalizing. So that is the reason there is a growth pattern C here. Can we go back here? We see growth pattern C, the main line, the bold line, not the dotted line here. That's what we see here in CAG. And then we have obesity. Obesity, we all know that there's no LGA, there's no dysmorphism. There is a huge role of environment which is there, and intellectual disability is not there. Adult stature is usually normal because you cannot beat your genetic potential. So growth pattern is again C. So there is rapid growth velocity that happens at a certain phase because of the excess nutrients that are available. So next is precocious puberty. Remember the graph C, we go back here and then we see that in comparison to the peers at around 7 to 8 years of the age, the height is pretty fast. And then ultimate height is lesser because the epiphyseal fusion is happening here, right? And the last, and another one is growth hormone excess. Growth hormone excess, there is no LGA, there is no dysmorphism, may be present, mild in earlier phases, And then intellectual disability is not there, and the adult stature is tall. Definitely growth hormone during the growth phase is high. So growth pattern may be a combined pattern of B plus D. If you can see here, this is the growth pattern, B plus D. So it depends on when it starts. The growth hormone excess, when it starts, it either goes on B pattern or in D pattern. So coming to the last one, we see that in hypogonadism, what is happening? There is no LGA. There is no dysmorphism also, may be present sometimes, which is very subtle. And then intellectual disability can be variable. If you're talking about Klinefelter syndrome, yes, there's certain intellectual disability out there. And then adult stature is definitely tall because the epiphysis is not fused. There is no sex steroids out there to fuse the epiphysis. So growth pattern continues to go on. There is no fusion, there is no slowing or faltering of the growth, which should normally happen. But then that the child continues to grow, and the ultimate height is tall stature. So the tall stature related to chromosomal aneuploidies. We all know that the clinical features of hypogonadism are usually present, especially in Klinefelter syndrome. They manifest as tall stature since the childhood. The child is usually always taller than the peers, and we see that. And then in the situation where there's a SHOX gene involved, then there can be tall stature. There are 2 functional copies in each cell in either sex. And then Klinefelter syndrome, what exactly happens? There's an extra copy of SHOX gene. So there is extra growth, and then there is also hypogonadism that we see. XXX syndrome and redundant Y syndromes also, there is normal gonadal function and tall stature in these conditions. But the growth is non-linear. In fact, the more number of X's increase in females, there is short stature. More number of Y's increase, there is a short stature that we can see. And then now moving on to the third segment of our topic, the syndromic tall stature. The syndromic tall stature, we have to look for dysmorphic features. It's very essential because each syndrome, we deal with about 8 to 10 syndromes here. And then each syndrome comes with a set of clues, the handles that we need to take, and then move forward. So first thing, how we divide, the child is tall. Yes, we've decided. Is it proportionate tall stature or disproportionate tall stature? Proportionate tall stature. We understand, we ask the history, birth history. The child was bigger from the birth in almost all the proportionate tall stature syndromes except Fragile X syndrome. So that birth history of there, it becomes important. How was the baby at birth? And then we move to the main features. So Soto syndrome, the first one, dolichocephaly is the most important one, and other prominent forehead. Can you see this picture here? You can see dolichocephaly and then prominent forehead. And the moment you see this kind of face, you identify that this is syndromic, and you categorize the patient and you deal with it. They have a broad range of learning disabilities, and putting such a child in a normal school would be very, very unfair to the child and the learning disabilities that the child has. So that is very important here to understand. Next we have in line is Weaver syndrome. What is important here and hallmark here? There's hypotonia, loose skin, and deep set nails with camptodactyly. That should give us a clue about Weaver syndrome. Next we have Fragile X syndrome. The child is normal when the child was born, but you see that typical scrawny, thin, long face, but with protruding ears. A thin face with protruding ears is what defines Fragile X syndrome with the face. And then you see macroorchidism in boys. So you see this here. You can typically see that prominent ears in Fragile X syndrome. And then we have the last syndrome in proportionate tall stature, that is Simpson-Gulabi Behnel syndrome. The child was large when the child was born. And there are coarse facial features. There's cutaneous and dactyly various bony abnormalities, talipes equinovarus, and then pes pectus excavatum is there. And then there are supernumerary nipples. This should give you an idea that you are dealing with SGB syndrome. So these are the 4 important things when we see proportionate tall stature. So then the next segment is a disproportionate tall stature. We have around 6 to 7 syndromes here. The first one is Marfan syndrome. We'll deal with it slightly a little later, all the features. So we have hyperextensible joints, long limbs, narrow hands. The most important thing why we need to know about it, because untreated, it can lead to catastrophic cardiac abnormalities. And diagnostic feature also has ophthalmologic abnormalities, vision abnormalities. Doing that slit lamp examination, seeing the lens is very important because subluxation and the direction of subluxation gives us an idea and differentiates Marfan's from other syndromes. The next in line, we have homocystinuria. Almost the patient looks like Marfan's only, but then in the lens, when we look at it, the subluxation of the lens is infranasally in homocystinuria. In Marfan's, it is superiorly. So that is what differentiates. And homocystinuria, why is it important? Because there's a high risk of thromboembolic phenomenon that occurs in homocystinuria, and cardiovascular events and cerebrovascular events occur as early as second and third decade. So we need to understand and identify homocystinuria. The third is Klinefelter syndrome. Disproportionate short stature, learning disabilities, difficulty in calculation skills and English language skills, which is present. Other than that, there'll be only very subtle features in Klinefelter syndrome that we need to understand. And the next one is Beckwith-Wiedemann and hypogonadism in Klinefelter syndrome, not to mention that, right? So next is Beckwith-Wiedemann syndrome. This Beckwith-Wiedemann syndrome and Precautious syndrome are the only two syndromes which, when the baby is large when the baby was born, and the child now has a disproportionate short stature. So Beckwith-Wiedemann syndrome, you have macrosomia, hemihypertrophy, macroglossia, macroglossia, abdominal wall defects, and neonatal hypoglycemias. Big babies with neonatal hypoglycemias, with the increased risk of neoplasms, all this should point in favor of Beckwith-Wiedemann syndrome. We'll deal with it in a couple of pictures also about Marfan's and Beckwith in a short while. And then we have triple X syndrome. Most important one is clinodactyly and epicanthal folds. Nothing else will be present. Intelligence will be normal. Everything will be okay. The patient will just be tall and will have these features. Next is Precautious. Precautious syndrome is very subtle, and you will identify it with macrocephaly and epidermal nevi and vascular malformations. That is a typical feature of Precautious syndrome. So coming back to important syndromes, Marfan syndrome, you all know that it's autosomal dominant inheritance, and a mutation is in fibrillin 1 gene. And there are ocular malformations. There is a skeletal abnormality and definitely a cardiac defect. You all know that we use revised Gent's criteria for diagnosis. I'm not going into detail of this. The next is homocystinuria. You can see that it has autosomal recessive inheritance. It is very, very rare, but then it has a lot of features common with Marfan's, similar to body habitus, the spider-like the fingers which are there, right? But these people are prone to thromboembolic phenomena. So it's very important to understand homocystinuria. Even if it is rare, it's important to be identified and prevent a catastrophic event. And then, as we have said, there is a subluxation of the lens. Ectopia lentis, especially infranasal migration of the lens, would be present. And a diagnosis is by identifying elevated homocysteine and methionine levels. So next in line is Beckwith-Wiedemann syndrome. You see the baby is very large. 11p overgrowth spectrum is present. It's an imprinting disorder, as we all know that. There's overexpression of IGF-2 and underexpression of CDKN1C. So this is because of uniparental disomy. And you can see the large ears, the ear defects, and the face which is present, large head. And almost the baby is a very big baby at birth. So another important syndrome that I haven't mentioned here is Kallmann syndrome. This is again associated with hypogonadism. Apparently, there would be no other distinguishing feature. The patient comes with around 16, 17-year-old child is brought with delayed puberty and tall stature. The child is continuously growing. I have to buy a new set of genes almost every 1 year or 2 years is what the parents often complain. And then say that the child has delayed puberty. And when you test the sense of smell, it is missing. Kallmann syndrome, tall stature, delayed puberty, and sense of smell being lost. And on MRI, you can find optic bulb atrophy or absence. So diagnostic approach. So how do you approach these people? We have to look at the height, and if the height is more than 2.5 standard deviation score, we need to evaluate. And there are other height parameters also. And now, because we are dealing with syndromic features, it's important to understand the syndromic features we have just seen a while ago. So it's important to know, to document all these, because a major proportion can be divided easily with respect to the upper segment, lower segment ratio and arm span. And it's very important to identify syndromic features, especially with regards to the dysmorphic features in the face, intellect, and developmental delay. And pubertal status is very important subsequently to identify whether there is normal puberty or delayed puberty or advanced puberty that we're dealing with. And then bone age, serum IGF-1 and other testings are also essential in this particular patient. Slit lamp examination, especially to differentiate between Marfan's homocystinuria, echocardiography, and karyotyping, especially if there is a disproportionate short stature, subtle dysmorphic features, and learning disabilities that are present, then go in with a karyotype. Klinefelter's is of what we often see. Special investigations involve serum and urine homocysteine levels, and genetic testing for fibrillin-1 and FMR1 is what we're looking at. So, in a nutshell, a patient presents with tall stature, height is more than 2 standard deviation score. So look at dysmorphic features, intellectual disabilities, and developmental delay. Is the child having a proportionate tall stature or a disproportionate tall stature? In proportionate, we have to revise SOTOS, Weaver's, BWS, Fragile X, and Behmel syndrome. And in disproportionate to revise, we have Marfan syndrome, Klinefelter syndrome, homocystinuria, XXX syndrome. That is how we differentiate. And then how do we manage them? Many of them, regarding height, you have to give them reassurance. Not much can be done now. Treatment of the underlying condition is very important, and associated problems is very important to prevent morbidity and mortality. And then, especially when it is Marfan's and homocystinuria. And then you have sex steroid therapy. In delayed puberty cases, in Klinefelter syndrome, and in other situations wherein there is no sex steroid, so there is no epiphyseal fusion, give the sex steroid therapy gradually. And then bilateral, this is another approach which can be done, bilateral percutaneous epiphysiodesis. You're fusing the epiphysis because the child is not stopping to grow. And then we can also use somatostatin analogs. So the often question that is raised at this point is, what is the predicted adult height? How long will my child grow? Especially when it comes to girls in India, parents are very worried. How much taller will my girl grow? I have to find a suitable groom for the girl child is a question that is often raised. It's somehow we have to let them know that we can calculate the predicted height. You have Bailey-Pinot methods. You have so many methods of estimation of adult height. We need to tell them that predicted adult height needs to be calculated, and you have to reassure the patients and the parents again and again. And then what is the future directions? Where are we? Are we just to do with sex steroids and then other things? No. We have some promising therapies which are still in the research line. We have growth plate specific SERMs, FGFR3 agonists, NPBR type antagonists, which can be used. So to conclude my talk today, most children with tall stature are healthy, but it is important to exclude pathological causes. Careful history and examination, relevant investigations are important, especially finding out the dysmorphic features and classifying them. Finding out about puberty and delayed puberty and assessing is important, and it will clinch our diagnosis, and we would be able to offer some solace to our patients. Thank you so much.
Thank you, ma'am. Nice presentation and a wonderful and elaborate description of tall stature with a special emphasis on syndromic tall stature. So I thank all the speakers, and as we are running late, so we will quickly move to our second session. I will hand over to you, Dr. Mayur. Please carry on.
Yeah, thank you all the speakers for accepting our invitation and delivering so nicely all the lectures and making us write, especially the practical points which may not be able to get through textbooks. So thank you very much. We will have the next repertoire, Dr. Priyamvada Tyagi. She is at Hormone India, Noida, and she has done DM endocrinology from SGPGI. Over to you, Dr. Priyamvada. And as we are running late, Dr. Anurag Vajpayee had a recorded session, so we'll play it later on. We can directly go to the congenital hypothyroidism. Over to Dr. Priyamvada.
Hi, good evening, everybody, and welcome to the day one of the Hormone India conference. So I would like to introduce the chairpersons for this session. We have Dr. Anuj. He is DM endocrinology and is currently assistant professor at KGMC Lucknow. We have Dr. Shivendra Verma with us. He is DM endocrinology and is vice chairperson at Chandan Hospital in Lucknow. Please skip over this slide. The first session will be congenital hypothyroidism by Dr. Sidnath Sudhanshu. I would like to request Dr. Shivendra to introduce the speaker.
Thank you, Premvada. And it's been a very nice talk so far we have from all the three speakers. Because we are exceeding time, I will not waste time. Just in brief, I will introduce Dr. Sudhanshu sir. And I've already been part with him. I have met him and learned so much of pediatric endocrinology from him. He is MD Pediatrics and he has done his further PDCC Pediatric Endocrinology from SGPGI. Presently, he is a faculty at SGPGI Lucknow and he has so many publications, more than 25. He has a special interest in diabetes, newborn screening, adrenal disorders, and he had a commendable job in working with the congenital hypothyroidism guidelines. And so it is very nice to hear from him. Now I would like to I would like to hand over this talk to Sudhanshu sir. Over to you, sir, to just guide us through congenital hypothyroidism.
Yeah, thank you, Shivendra, and thank you, organizers. Let me share my slides. Is it visible?
Yeah.
Yeah. Okay. So, good evening to everyone. So, I will be talking on congenital hypothyroidism with
Please on slide mode.
Sorry?
Slide mode, sir. Full screen.
Slides are needed, sir.
Presentation mode, sir.
Yeah. Is it okay?
Still not.
Still, the slides, the full screen mode is not on.
Yeah, but,
maybe in the bottom of or your screen, sir, there is a option of full screen.
Yeah, that I am doing.
He needs to stop sharing. If I may help,
he
needs to stop sharing the screen, put it in full screen mode, and then share.
Okay. Is this fine now?
It will take few minutes, I think, to come in slide mode. Wait for a few seconds. I think it will come.
Okay, sir. I think we can start.
Meanwhile, we can continue, sir.
Yeah.
Yeah. So, so I will be talking on congenital hypothyroidism with special emphasis on newborn screening. Is it moving?
No, not moving.
No.
Moving, not moving. Yeah. It's moving now.
It's moving. Then I. Is it moving now?
We are seeing only second slide, sir.
Yeah, so that's newborn screening guidelines, no?
Yeah. Third, can you switch to third? It's not moving, I think.
I think, sir, you can click from the left side in the slides where it is there. Then you could change it.
Is it moving now? No.
Sir, it is stuck on the second slide. It is not moving forward.
Tech team, can you help it out? Can you take the screen control?
Sir,
no.
Can you send me the PPT? I'll share.
No, but this should not happen. Why it's happening now? SPAY on the newborn screening guidelines for congenital hypothyroidism. So let's start with the case scenario. So the diagnosis, so it's a pretty much a straight diagnosis. Most likely this child is having congenital hypothyroidism. But
sir, we are still looking at the second slide.
So click on the slide on the left panel.
Hello.
Yeah.
Yeah, so sorry to interrupt, but can you share the remote control with me?
Yes, sir. Yeah. Okay. Most likely a case of congenital hypothyroidism, but we can't congratulate ourselves on this diagnosis because for this case, just the diagnosis is not important. What's more important is making the diagnosis in the right time. And for this child, the time has been lost. Now it has become too late. Now, how much ever well you treat this child is never going to be never going to have a normal intelligence for his entire life. So essentially, we have added a mentally retarded child or a child with intellectual disability to our society. So for this situation, let's face some facts, opportunities, and the challenges. So the facts are that the congenital hypothyroidism, it's the most common cause of preventable mental retardation, and it has got a high incidence rate. And when coupled with the high birth rate in India, it poses a potential risk of adding a significantly high number of mentally compromised infants and children to our society every year if we don't screen them at the neonatal age. So here comes the opportunity that newborn screening is the most effective way to detect and treat an infant with CH before it becomes too late, like for our previous case. But the challenge is that we do not have a national NBS program in India at present. So on this background, we all must be aware about a few more things, that this screening method by TSH, it's really cheap and is easily available in a routine chemistry labs nearby, almost everywhere. And this screening and treatment is extremely cost effective, and very less than 10% of the newborns or infants, they become symptomatic in the first month of life. So unless we detect them, we screen them at birth, we can't detect them in time, and we can't start the treatment in time. But if we do this, if we screen and we detect this case and we start treatment in time, that is before 2 weeks of age, a near normal outcome can be expected. So here we can see that more the delay in the initiation of treatment, worse is the intellectual outcome. Now talking about some basic thyroid physiology, we all know that there is a TSH surge within 30 minutes after birth, and which is due to a stress of the labor or the birth process, and it's followed by a rise in T4. This surge settles between 2 to 5 days of postnatal age. So we have to avoid this surge for taking the sample to avoid the false positivity. So to avoid this, we have two options. Either we take a cord blood sample, which is not affected by the surge, or we take a postnatal sample, that too collected 48 hours after birth. So just for the clarity, I just want to emphasize that the samples for a newborn screening for CH are of just two types, a cord blood sample or a postnatal sample. How you send it, where you send it, that's another matter that we will be coming in the next slide. So talking about some practical aspects. Now, first thing is that which test to do, TSH versus T4. So after too much of deliberations and data and research, now the TSH-based screen is adopted worldwide. And we also in our country and to our guidelines, we have adopted the same TSH-based screen. Now, which sample to send and how and where to send? So if you have a central NBS facility available, then you have to send the sample on a filter paper as a dried blood spot. This sample you can collect postnatally, as a postnatal sample you can collect on filter paper by simple heel plate. Or if you want to take a cord blood sample, then that sample can also be sent on the filter paper by laying down upon these areas and making it a dry blood spot. So either a cord blood sample or a postnatal heel prick sample, both could be sent as a dry blood spot to a central NBS facility. But if you do not have a central NBS facility, and if you have to send the sample to a nearby routine chemistry lab, then you have to send this serum sample. Sample is a serum sample. So if you are sending a postnatal sample, then it simply means that you have to venipuncture the child. But if you want to avoid venipuncturing a neonate, then simply a cord blood can be collected at the time of birth and can be sent as a serum sample to the nearby lab. Okay. So now, next practical aspect is about the reporting units. So for a serum sample, it can be reported only in the serum units. But if you are sending a filter paper sample as a dried blood spot, then this can be reported both in a whole blood unit or as well as in the serum units. For that, you have to preset the machine that in which unit you want the report. But in whichever unit it gives the report, you can manually calculate it as the serum unit is 2.2 times of the whole blood unit. It's just a correction for the hematocrit. Okay. And to avoid this confusion versus whole blood versus serum units, to our guidelines and this talk also, all the TSH values, all the cutoffs will be described in terms of serum units for the sake of uniformity. Now, timing of the sample. So we just discussed either we take a cord blood sample or a postnatal sample after 48 hours of birth. But in certain specific situations, like some centers may be having an early discharge policy. So for them, we may take an early sample, but never before 24 hours of birth. At most, between 24 to 48 hours of birth. The only thing is that when we will be analyzing the report, then the cutoff value for these early samples will be slightly different. That we will come to that later. Essentially, no infant should be sent home without CH screening. So, in some other specific situations like preterm, IUGR, sick neonate, or Down syndromes, initial screen may miss CH. So then, for these conditions, we have to take a second sample after 2 weeks of age, between 2 to 4 weeks. So we have to remember these special situations in which we have to take a second sample in addition to the first sample. Now coming to the interpretation part. So whatever sample we have taken, either a heel peak sample or a cord blood TSH. So the report, if it's more than 20 or more, it's abnormal. 30, that for early sample, we just talked about. So that is 34. If sample was taken between 24 to 48 hours, 34 or more is abnormal. Next, if it's more than 40, then these cases are more likely to have a confirmed CH, primary CH. So for them, we take a confirmatory venous sample, means sample taken by a venipuncture and to be analyzed for both T4 and TSH. If you are likely to get the report within next 1 day, then wait for the report. But if you are not likely to get the report within next 1 day, or TSH is really high, like to the tunes of more than 80, then you start the treatment and then let the report come. Do not wait for the report to start the treatment. Another category between 20 to 40 TSH, it's a borderline. It could be or it may not be a confirmed case of CH. So for these cases, we do a repeat testing, repeat screening in the second week of life, as early as possible in the second week of life, between 7 to 10 days preferably. So if that TSH comes more than 20 for less than 2 weeks of age, or more than 10 for more than 2 weeks of age, which should not happen because we intend to start the treatment by 2 weeks of age, but still practically everything may not be so ideal. So that's abnormal. And then we have to take the confirmatory venous sample. Here, one thing I want to emphasize and stress upon that if this repeat screening sample you are sending to a nearby lab, this means you will be sending a serum sample by doing a venipuncture. So then to avoid one more venipuncture, in case the report comes abnormal, take it as a confirmatory venous sample itself and send this sample, this venous sample, serum sample, both for T4 and TSH, and then see the reports. Again, for the uniformity, all the values have been mentioned in the serum units. Now coming to the results. So if TSH is normal and T4 is normal, well and good. If TSH is high and T4 is low, high TSH we just talked about, and the low T4 means total T4 less than 10 microgram per dl and free T4 less than 1.17 nanogram per dl. It's considered low. So it's a confirmed case of primary congenital hypothyroidism. Start the treatment as soon as possible. For the two borderline situations like normal T4, normal TSH and low T4, and high TSH and normal T4, we will be discussing those situations in the next slide. Again, a diagnosis should be made on the confirmatory venous sample analysis only. So now for some borderline conditions like borderline high TSH with normal T4. This can happen in a transient or a milder variety of primary CH or in Down syndrome and in some other cases as well. So for these cases, we repeat the test after 2 weeks. And if this TSH remains elevated more than 10 beyond 3 weeks of life, even with normal T4, start the treatment. Another situation where T4 is low but TSH is normal. This condition may be seen in a case of hypothyroxanemia of prematurity or TBG deficiency, or even in the central hypothyroidism, which is much less common than the primary hypothyroidism. So if you think that it's a central hypothyroidism, then rule out the other pituitary hormone deficiency and treat accordingly. And if you think that it's some transient condition, then again we may retest after 2 to 4 weeks, and we see that if we see any abnormal reports due to any delayed rise. So again, any time referral can be sought if needed. So now, after making the diagnosis, now evaluation, etiological evaluation. Etiological evaluation is important because some entities cause permanent conditions, permanent hypothyroidism, and some entities cause transient hypothyroidism. So it's very important for the prognosis and for explaining to the parents the course of illness and the course of the disease. And some other rare, less common conditions are there, which can also be picked upon by simple etiological evaluation. They are rare, but they can be seen. So now, like we talked, it's important for the counseling and for explaining the prognosis and the course of the disease to the parents. And we do thyroid ultrasound and as well as technetium 99 thyroid scan. One thing I would like all you to note that if this USG can be done at any time, but this scan, it should be done preferably when TSH is elevated. So, but the most paramount thing is treatment. If you are able to get the scan in time, it's well and good. If not, then do not wait to start the treatment for getting the imaging done. Treatment should be started. So now a combination of thyroid scan and ultrasound, it leads to almost like all the common conditions causing primary hypothyroidism. So, just to explain that. So suppose on a thyroid scan, we got the uptake at the base of the tongue. So it simply means it's a lingual ectopic thyroid. If there was no uptake, either in the neck or elsewhere in the body, so then we do USG thyroid. If gland is not visualized, this means there is a thyroid agenesis, or visualized but very small, so could be a dyskinesis as well. Or if the gland is seen, then it could be a case of a maternal blocking thyroid antibodies, which was probably inhibiting the thyroid uptake. If uptake was high, increased uptake, then again do the USG. It mostly shows enlarged gland, and then it's suggestive of dysharmonogenesis. For that, we do perchlorate discharge test. Genetic studies can be done anytime. It confirms the final diagnosis. If uptake is normal and gland is normal on the USG, still the biochemically it was hypothyroid, then it could be a transient condition, a very mild variety of primary hypothyroidism, or even secondary hypothyroidism. Now coming to the treatment. So this treatment must start before 2 weeks of age to prevent the permanent neurocognitive damage. Levothyroxine is given the rate of 10 to 15 microgram per kg per day, mixed with breast milk till 6 months of age, and then with water. It should be soaked and crushed very well before giving it to the child. Hearing screening should be done at the onset, at the diagnosis, and then periodically. Follow-up, initially we do follow with both T4 and TSH at 2 to 4 weeks. And when T4 normalizes, then we can monitor and we can follow with TSH a bit more frequently till 3 years of age, and post that a bit less frequently, maybe 3 to 6 monthly or 6 to 12 monthly in the post-adolescent age group. For the reassessment, if etiological assessment could not be done at the diagnosis, or if you are not sure whether it's a permanent or it's a transient condition, very low LT4 is required, then reassessment should be done, but after 3 years of age. And because we need to stop LT4, levothyroxine for 6 to 8 weeks, and that we can't do before 3 years of age. This is the thyroid profile, T4, FT4, and TSH age-wise range. While treating, we try to maintain T4 and FT4 in the upper half of the normal range and TSH in the lower half of the normal range. And again, of equal importance is the education of the family. The family must be aware that any laxity on their part, on the compliance, may cause a permanent damage to their child. So the treatment should not be fluttered upon by them at any cost, and if needed, give a written document to them, and must ensure that they keep coming for the follow-up. Now for the follow-up, apart from biochemical follow-up, we have to follow for the growth, puberty, development, as well as the hearing assessment. Everything is like of equal importance. Now for checking of the permanency of CH, like reassessment, we do it after 3 years of age, as we talked. So we stop thyroxine for 4 weeks and recheck T4 and TSH. If TSH is more than 10, then imaging should be done if it was not done earlier, and then restart the treatment. If TSH is borderline or it's normal, then we have to keep the child under follow-up for some more time and make sure there should be no loss to follow-up, because you may lose a potential case of primary CH or maybe a secondary CH. So they must come for the follow-up at least for next few years. Now coming to the conclusion. So mostly the conclusions are the same, which we just talked in last 20 minutes. A treatment should be started within 2 weeks of age, a follow-up is important, and all the same things. And reassessment should be done after 3 years of age. But the most important takeaway from this talk, if I want you all of you to have, is that the newborn screening should be a must for all pediatricians as well as endocrinologists. Thank you. Acknowledgement for this module, which was created by our SPA members, Dr. Ganesh, Dr. Riyaz, and Dr. M.B. Kumar. Thank you.
Thank you, sir.
Yeah, thank you so much, sir. It was very nice, and very nice to hear it again. We have learned so much in this regard regarding congenital hypothyroidism. So moving on to our next talk, if we can have Dr. A. Maithili ma'am. She will be speaking on neonatal diabetes. So
I think we can also invite Dr. Anush, chairperson. He'll be inviting Dr. Anush, you are there?
Yeah.
Yeah.
Good evening, sir. I was there.
Yeah, please introduce our next speaker. Dr. Anush has done his DM Endo from SGPGI and presently working as assistant professor at KGMC, Lucknow.
First of all, I congratulate my seniors for organizing this first ever Hormone India conference. Topic for the session is neonatal diabetes, and the speaker is Dr. A. Maithili ma'am. She is a consultant endocrinologist from the Visakhapatnam, and a former professor of endocrinology in Andhra Medical College, Visakhapatnam. She is a visiting faculty at GEMS Medical College, Srikakulam, and founder, secretary, and Diabetic Child Society in Visakhapatnam. Presently president-elect of AP RSSDA for 2022 and 23. Over to you, ma'am.
Thank you for the kind introduction. I would like to congratulate the team of Hormone India for the wonderful conference. And I thank them for inviting me, Dr. Mayur and Dr. Harsha, for the kind invitation. So I'm asked to speak on neonatal diabetes. So this topic is getting important today. The reasons are that, number one, we are seeing more number of cases. Secondly, we have a better understanding. Thirdly, genetic testing is available. And beyond all this, it is a rewarding diagnosis because a good number of them respond to sulfonylureas. So this is rare, monogenic, it is non-autoimmune, and the diagnosis is in the first 6 months of life. However, the testing, it may be considered, the diagnosis may be considered even up to
Hello.
year of age.
Ma'am, sorry to interrupt, but your slide is not moving.
It is moving for me.
Can I share your slide?
Yeah, please. Am I audible?
Yes.
Yeah, please proceed. No, next slide. Next. So when do we suspect neonatal diabetes? This is especially in babies where there is a history of IUGR in utero or at birth. And then postnatally, there is a failure to thrive despite a good adequate intake associated with copious urine output. And most important is, has to be persistent after exclusion of other causes of neonatal hyperglycemia in the first week of life. Next. So, the diagram, this is a very important diagram which shows the beta cell and the regulation of insulin secretion in the beta cell. If you see on the right half of the diagram, you can see this is the nutrient-induced insulin secretion. So in response to glucose at the level of the beta cell taken up by the GLUT2, it is phosphorylated by the key enzyme glucokinase, and the subsequent oxidation generates ATP. So this closes the potassium, ATP sensitive potassium channel, and then opens the calcium channel leading to insulin secretion. So this is the nutrient mediated insulin secretion. So the key players here, as you see, is number one is glucokinase, and then secondly, the two important genes which regulate the potassium channel, that is the KCNG11 and the ABCC8 genes. So a genetic disorder of these genes or the genetic disorder of the glucokinase are commonly associated with neonatal diabetes. And to the left of the diagram, if you see, this is the basal insulin secretion. So the basal insulin secretion is independent of ATP. There are so many transcription factors which are associated with the basal insulin secretion that they turn on the genes that produce insulin, and a defect of all these transcription factors can be associated with neonatal diabetes. Then another important area is a genetic disorder of insulin synthesis. So the insulin gene, if it is defective, there is an insulin defective, synthesis defect, and that is associated with neonatal diabetes. Finally, there is an epigenetic disorder of the beta cell, which is also associated with neonatal diabetes. So the slide very aptly summarizes the common causes which are depicted in blue. These are the common causes of neonatal diabetes. Next slide, please. So this neonatal diabetes is classified, next slide, please. So it is classified into three different forms. Most common is the permanent, which is seen in the center. And to the right is the syndromes, which are associated with neonatal diabetes. Left is the transient neonatal diabetes. So I will just briefly speak about each of these three, the permanent, then the transient, and the syndromes in the subsequent slides. Next. So Indian data from Dr. Mohan, and this article was published in the Journal of Pediatric Endocrinology Diabetes, a very good review article. And it is shown that transient is less common in India, permanent is 60 to 70%. Syndromes are quite common in India. Next. So I will first discuss about the permanent neonatal diabetes. So this is again broadly, to simplify, it is either due to reduced beta cell function, or there is a reduced beta cell mass, or there is an increase in the beta cell destruction. So the reduction in the beta cell function, as I've already shown, is because of the two genes that are defective, which are responsible for regulating the potassium channel, and then of course the glucokinase mutation. Beta cell mass can be reduced because of a defect in these various genes. There can be an apoptosis of the beta cells genetically, and the most common one is the insulin gene mutation, followed by the gene EIF2AK3, which is the gene implicated in the Walcott-Ramosin syndrome. So next. So most common cause of neonatal diabetes is the KCNG11 and the ABCC8 mutations. So this is again the diagram which shows the ATP sensitive potassium channel. So this channel at the level of the beta cell is constituted by the sulfonylurea receptor 1 and the potassium invert rectifier 6.2. So these two combine together and they form a large heterooctameric complex, and this insulin is secreted in response to an ATP change which occurs because of glucose oxidation. So the KIR 6.2 is coded by the gene KCNG11 and the SUR1 is coded by the gene ABCC8. So the channel is normally, it is open. And next.
So when there is an activating mutation of the KCNJ11 or the ABCC8, so this prevents the closure of the potassium channel in response to increased ATP. And as I already said, this is the most common cause of permanent diabetes, and also for 25% of transient neonatal diabetes occurs because of these mutations. So the channels are present in brain, nerves, and muscles. So there could be a severe defect of these potassium channel. You would find a defect in these organs too. So that is the reason why 20% of patients with the KCNJ11 mutations, they have associated neurological problems. Next. So what is the difference between the two? So the KCNJ11 mutation is a commoner cause of neonatal diabetes when compared to the ABCC8. The ABCC8 is, in fact, the loss of function mutation of this gene is more common for congenital hyperinsulinism, which will be discussed by the other speaker. And these mutations, the other terminology that is given is, this is the neonatal diabetes which is responsive to sulfonylureas. So they present very early in life, marked hyperglycemia, ketosis, undetectable C-peptide, absence of autoimmune markers. 20%, as I said, have the neurological abnormalities, and this is what is called the Dent syndrome associated with developmental delay and epilepsy. The inheritance, it is spontaneous, it can be autosomal dominant or recessive. Once they're treated adequately, they have a very good catch-up growth and weight and height normalized by a mean of 9.3 years. So this is what is rewarding about this particular disorder. Next. So let me present a case here. So this is not my case. I have drawn it from a book. This is an 18-year-old female from rural area. She was referred for management of type 1 diabetes. She was diagnosed with diabetes at the age of 3 months and takes pre-mixed insulin 30-70 twice daily, rarely monitors glucose. She has had 5 episodes of severe hypoglycemia in the past. She's a single child, no family history of diabetes. So when evaluated now, her A1C was 8.5, GAD was negative, C-peptide negative, and a genetic testing for the KCNJ11 gene mutation was positive. Next. So, this is why I wanted to present this, to show that the delay can be so much for neonatal diabetes. And that is the case which responds to sulfonylureas. Well, this is our own case, which we saw in Visakhapatnam, maybe, around 6 or 7 years back. This is a 5-month-old child admitted for gastroenteritis with a blood glucose of 550 milligrams per deciliter. Ketones were negative. Born to non-consanguineous parents, birth weight was 2.5. There's a history of right focal seizures at the age of 1.5 months, and the child was started on anti-epileptics. History of developmental delay, and the present birth weight was 4.5 kgs. So our postgraduates made a diagnosis of probably this is Dent syndrome. However, we could not do a genetic analysis. This was some 8 or 9 years back. So again, this is another case where this responds to sulfonylureas. Next. So I just wanted to present 2 cases of the KCNJ11 gene mutations. So how do we transit these children from insulin to oral sulfonylureas? So a very good landmark paper published in New England Journal by Pearson et al. They looked at 49 children with neonatal diabetes. And then next, so what they found out was, of these 49 consecutive patients who received appropriate doses of sulfonylureas, majority of them responded to sulfonylureas. Next, 90% they were successfully discontinued insulin after receiving sulfonylureas. Their A1C levels improved from 8.1 to 6.4%, and this was sustained for 1 year. Sulfonylurea treatment increased insulin secretion, and this was more with oral insulin, and exogenous glucagon increased insulin secretion in the presence of sulfonylureas. So this was very encouraging, and following this, I think, next came the therapy of sulfonylurea, which was approved by as one of the landmark treatment for neonatal diabetes. So though insulin is given as the immediate choice for metabolic control, once the diagnosis is established, sulfonylureas are effective in a good number of patients. And the sulfonylurea chosen is glibenclamide, probably because it crosses the blood-brain barrier at a dose of 0.45 milligrams per kg per day to 1.5 milligrams per kg per day, a very higher dose when compared to what is used in the treatment of type 2 diabetes. Side effects are quite rare. Hypoglycemia and weight gain are really not common because, with these drugs in neonatal diabetes compared to adult onset type 2 diabetes. Next. So this is the commonest. Now the other insulin gene mutation can also produce permanent. It can also produce transient in a good number of patients. So when there is an insulin gene mutation, there is a misfolding of the precursors, which leads to ER stress and beta cell apoptosis. This is autosomal dominant, small for gestational age, and remember the treatment is only insulin in this particular case. This is a very strong mimicker of type 1 diabetes. Next. So very rarely we can see the glucokinase gene mutation as a neonatal diabetes. So this is the rate limiting enzyme in the glycolysis. It is expressed in beta cells and other organs. We are aware that the heterozygous loss of function mutation is MODY2. The homozygous one produces permanent neonatal diabetes, which is lethal in the first week of life if untreated. Next. Less common forms. There are still other common, rare forms of permanent diabetes which occur because of an abnormal pancreatic development. And these are all the different defects which can take place. Next. So with this, I think I completed permanent neonatal diabetes. A word about transient neonatal diabetes. It is called transient, but remember it is a remitting, relapsing type of neonatal diabetes. And then it remits, but then it recurs in later life. Again, the most common cause of transient neonatal diabetes is the chromosome 6q24 abnormalities, 68%. And the other causes of transient neonatal diabetes are the same as that of the permanent diabetes, that is the ABCC8, the KCNJ11, and very rarely HNF1 beta, which is responsible for the heterozygous mutation, is MODY5. The homozygous mutation can present as a transient neonatal diabetes. Next. So a word about the 6q24 related transient neonatal diabetes. So what happens is this is an epigenetic disorder. There is a defect in the genome imprinting. So in this particular transient diabetes, what you can see is there is an overexpression of certain genes which are responsible for inhibiting the insulin secretion. So this is the normal, the 6 chromosome. So one copy is from the father and one copy is from the mother. So these genes are normally they're silenced when there is a methylation at the level of the end in the maternal chromosome. Now, when this methylation is absent, that can produce transient neonatal diabetes. There's an overexpression of genes. And the genes, when there is a paternal overexpression, uniparental disomy of the chromosome 6, or when there is a paternal duplication, this also produces transient neonatal diabetes. Next. So we have not seen this case. The clinical features are very severe hyperglycemia in the first week. Again, insulin is required for treatment. They're quite sensitive to insulin. And if there is a remission, they need a reduction in the dose. Recurrence takes place at a later age of 14 years. And in some cases, hyperglycemia may be intermittent and seen only in time of stress. A very important extrapancreatic finding is macroclosia and umbilical hernia. Next. We have finished the other causes, and HNF1 beta, again, homozygous mutation can produce transient neonatal diabetes. The clue is the renal cyst in this particular disorder. Next. Now, syndromes which produce neonatal diabetes. So we have so many syndromes have been identified. I will not take you into the details of this, but then the most common syndrome is the Walcott-Rallison syndrome, and this is associated with skeletal anomalies, renal anomalies, and this is the commonest form. Quite a good number of cases have been reported in India, and then of course we have IPEX syndrome and the others. Next. Next slide. So we have so many syndromes. I would like to describe our own experience with one gene, that is the NKX2. Next slide. So we had a case of this particular mutation. Next slide. Next slide. So this was our case of a 6-month-old female who presented with fever, and the random blood glucose was found to be 578 milligrams. She had ketonuria acidosis. So we did an evaluation at the department, and she had a low birth weight. There was neonatal sepsis developmental delay. Her A1C was 13, GAD antibodies were negative. She had bilateral partial optic atrophy. She had normal brain evoked response auditory, and there was some MRI findings of hypoxic sequelae. The child was treated for DKA, and after stabilization, we switched her to twice daily glargine. Unfortunately, she was lost for follow-up, and a couple of months back, she succumbed. Next. So we sent the genetic analysis of this particular case to Madras Diabetes Research Foundation. Next. So what we found was, next slide, please. So we found that there was an NKX2 mutation in this particular case. Next. Again, this doesn't respond to sulfonylureas and has a bad prognosis. Well, some more syndromes of neonatal diabetes are again depicted. So the list is increasing day by day. Next. So finally, having finished the 3 types of neonatal diabetes, a word about management considerations. So in the neonate, it is very difficult to manage. You have to, with a DKA presentation, the fluid electrolyte disturbances have to be taken care of. And the physiological glucose infusion rate is around 6 to 12 milligram per kg per minute. Then for DKA, the insulin infusion rate, if you see compared to adults, it is much lower, 0.02 units or to 0.05 units per kg per hour. Now, once the child is taking oral feeds, the ideal way to manage would be an insulin pump. However, it is again not affordable for majority of our children. MDI is what we routinely use, a short-acting insulin, which is given at 0.1 to 0.15 unit per kg per dose. And if you are choosing the child is stable, you can choose a long-acting at a dose of 0.2 to 0.4 units per kg per day of Lantus insulin, or glargine insulin. Analogs are usually preferable in neonate. And what is important is the dilution has to be done at a rate of 1:10 to provide the lower required amounts. So the dilution is very easy. There is flexibility. That is why pump is very easy in managing neonatal diabetes. Next. Now, a very good algorithm has been suggested for considering sulfonylurea trial. So any neonatal diabetes below 6 months, first thing is establish euglycemia, and urgent genetic testing is what is required. Pending the results, most important is get an imaging to rule out pancreatic hypoplasia or agenesis, and also look for syndromic features. If these are absent, you can consider an empiric trial of sulfonylureas. It could be successful, or if it is unsuccessful, again, you wait for the result. Again, you can treat based on the genetic test. Next. So this is my last slide. Next. So the take-home message is very important is suspect neonatal diabetes. If someone says I've had diabetes shortly after birth and there's a strong family history of diabetes, do genetic testing in neonatal diabetes less than 6 months of age. The 4 important genes are the 6q24 abnormality, KCNJ11, ABCC8, and insulin gene mutation. Early diagnosis and treatment definitely is important. It improves the outcomes. And pathogenic variants in the KCNJ11 gene, they respond to sulfonylureas. So this is again, in short, my presentation about neonatal diabetes. And I thank all of you for listening to me. Once again, my good wishes to Hormone India for a bright future. And thank the organizers for giving me this opportunity. Thank you.
Thank you, ma'am, for giving the enlightening and the elaborative talk on both permanent and transient diabetes, neonatal diabetes. I think it is already late. I'll hand over the session to the Dr. Mayur Agarwal.
Very much, ma'am, for accepting the invitation. It was very enlightening and very detailed, I would say, and well within time. Thank you very much. As we are running late, I'll just hand over to Dr. Kanaiya. He has done his DM Endo from PGI Chandigarh, and he would be coordinating the next session. Dr. Kanaiya?
Yeah, thank you, Dr. Mayur, for the event management. So, first of all, I'd like to welcome all the chairpersons, Dr. Dinen Sahu, he is the post associate consultant in the Fortis Hospital, Delhi. Dr. Vaibhav Pathak, he is also he's endocrinologist in the managing the Department of Endocrinology in the Medanta Hospital, Lucknow. And I welcome Dr. Yashasvi also as he's a consultant endocrinologist in the Jaipur. So I welcome all the chairpersons for managing the session. So I hand over the session to the Dr. Chairpersons, Dr. Vaibhav Pathak.
Yeah, thank you, Dr. Kanaya, for the introduction and for this opportunity. And let me not waste time, as I was saying that we are running late. So it is my privilege and honor to introduce Dr. Anuradha Kajalkar ma'am. Ma'am does not need any introduction in field of pediatric endocrinology. We as a students are very eager to listen ma'am during the DM days as well. So without wasting much time, and these are the ma'am's credentials. She is the deputy director at Jahangir Medical Institute, Pune, and she has multiple papers in pediatric endocrinology, which would take a lot of time to for me to go into the details. So warm welcome to you, ma'am, and over to you, ma'am, for the session, ma'am.
Thank you so much for the kind introduction, and I will now start my PowerPoint presentation. I would first like to thank the organizers and especially Dr. Agarwal for having me here today. And I am also extremely grateful that it has been recognized that Dexa interpretation in children is different and difficult, as I will show you as we go along. So my outline would be, I'll talk a little bit about the Dexa, which is dual energy X-ray absorptiometry, which we use which is the gold standard for measuring bone density, the parameters that we assess in children, why we measure bone density in children, why is children's Dexa interpreted differently, a few case studies, and a summary. So I'll just tell you a couple of things about the Dexa. So it is called a dual energy X-ray absorptiometry. So there are two X-ray sources, one high energy and one low energy, and the attenuation is actually picked up, and that is how the bone density is decided. The reason I included this slide is just to tell you that the radiation is very, very minimal. So there is no risk of doing Dexa in a child. You get much less radiation on a Dexa than you would when you're outside on the road. Another thing I'd like to point out that Dexa machines are not like X-rays or biochemical tests where you can compare one with the other, where you can compare the results just one with the other. So you need to consider, so the most common makes that are found in India is this one is a hologic machine and this one is our own GE Luna Ridexa. So you need to consider the make of the machine, you need to consider the X-ray source, and you need to consider the reference data. Most of these have different background data. So the Z-scores or T-scores that will be computed will actually be different. So the difference that you might find in two reports from two machines of the same patient may not be because there is something different in the patient. It may just be because of the machine. Now, moving on to Dexa scans in children. For diagnosis of osteoporosis in children, Dexa scans need to be performed on a machine with pediatric software. Many times I get sent random scans to analyze, and you can't analyze the scan because it has not been done on a children's, there is no children's software on the machine on which it has been done. Like for other parameters in children, you need to use Z-scores. I'll come to that again. A few things that we do not use in children is T-scores, which you commonly see in an adult Dexa scan, are not seen in children, not used in children. The reason is that T-score is comparison with a healthy adult who is from 21 to 30 years of age. Since children are much younger than 21, obviously you can't use a T-score. You can't use a peripheral Dexa in children, the little ones that are often available at orthopedic surgeons. And you cannot use the word osteopenia. Osteopenia is not used in children. I'll come to that as I go a bit further. Now, what are the parameters that we normally assess in children? So, of course, the lumbar spine, as we all know, it has a lot of trabecular bone. So it is metabolically very active. Also, particularly in secondary osteoporosis, asymptomatic fractures are quite common at the lumbar spine. And when you're giving bone active agents, this is a good site to monitor. We also, of course, do dual femur scans. Now, the dual femur scans are done in children over 10 years of age, because under 10 years, positioning the child is very hard and interpreting the DEXA scan is difficult. One scan that we do in children, which we do not very much do in adults for bone density, is a total body scan. Now you can see one skeleton-like structure on this side. Children get quite excited seeing that. And the other one is this one. So when you do a total body, you get a total body bone density and you get a total body composition. Now, the reason why we do this scan is that apart from seeing fracture sites, in children, you're also interested to know how much bone a child has put in. I'll come to that a little bit later again. Now, another scan which has recently been introduced is a vertebral fracture assessment. I must admit that it is something that we really like doing. So the VFA actually will give you an assessment of the whole spine, starting at the cervical spine, going down to the sacrum. Of course, we never see fractures of the sacrum unless it's a road traffic accident or something. And here we are able to tell, particularly in cases of secondary osteoporosis, if there is some vertebra which is affected. Here, as you can see, the L2 is affected. Normally, you should see them as rectangles. So why do you measure bone density in children? I remember when I started work in bone in children in around 2000 or some 1 or 2, I was told osteoporosis doesn't happen in children. Why am I studying it? So, on an X-ray to find out that there is osteoporosis, at least 30% of the bone has to be lost. Second thing is, together with, the increasing medical arsenal of medications, secondary osteoporosis has become quite common. Asymptomatic vertebral fractures are quite common in secondary osteoporosis, and you won't believe happen in around 30% of children. And if you want to follow up with bone active agents, you have to actually do a DEXA scan. That's the only way you can see it. This is the slide that I referred to earlier, that the reason why we are interested in a total body scan in children is to see, you can see that this is how the bone growth and the bone loss occurs. To make sure that you have good bone as you grow older, you need to put away as much as you can when you're actually growing. It's exactly like growth. So where height is affected, bone is affected. So that is why we also do a total body scan to look at bone accrual. So what are the childhood conditions in which we look at osteoporosis? So primary bone disorders where bone fragility is seen, primary osteoporosis. So disorders of connective tissue, the commonest primary bone disorder that we report on is osteogenesis imperfecta, and very rarely severe forms of Ehlers-Danlos loss. Then very rarely also idiopathic juvenile osteoporosis. What we see much more commonly is secondary osteoporosis. And this is really something that I would like to stress in my talk today. In all chronic conditions in children, or many chronic conditions in children, there is actually a loss of bone, though it is not something that is considered before a fracture occurs. So in chronic illnesses like malignancies, rheumatological disorders, all disorders of anorexia nervosa, cystic fibrosis, neuromuscular disorders, cerebral palsy, endocrine disorders, then, medications such as glucocorticoids is the one that we see most commonly. Then there is methotrexate, etc., and in inborn errors of metabolism. So secondary osteoporosis is much more common than we think. And we in many studies have looked at osteoporosis in chronic conditions in children, such as in diabetes, then in growth hormone deficiency, in thalassemias, in certain syndromes such as the Robinson type B, which we recently reported, and in Turner's syndrome. So in all these conditions, there is actually a bone loss. And the reasons are, one is malnutrition. Children who are chronically sick don't tend to eat as well. There is poor sun exposure. We all know how common vitamin D deficiency is. Chronically sick children are less likely to play. Physical activity is very, very critical for bone to be built up during childhood. Loss of growth and delayed puberty. In girls, estrogens, and in boys, testosterone during puberty are the ones which will ramp up the deposition of bone, and the effect of the disease is self and medication. So these are the reasons why secondary osteoporosis is common in chronic pediatric disorders. So how do you diagnose osteoporosis on Dexa in children? So unlike in adults, where you can actually look at the T-score and say this person has osteoporosis, you can't do it in children. The diagnosis of osteoporosis in children and adolescents cannot be made on the basis of densitometric criteria alone. So you need to have a clinically significant fracture. So if there is a vertebral fracture, and even if the bone mineral density is not low, and it is an asymptomatic, atraumatic, or low trauma fracture, you can label it as osteoporosis. In the absence of a vertebral compression fracture, a bone mineral density of less than -2 Z-score plus a clinically significant fracture. So what that means is under 10 years of age, 2 fractures, and under 19 years of age, 3 fractures to call a child as having osteoporosis. Then why can't we just classify children? Why is children's data difficult to interpret? That is because children grow. So we pediatricians are always, dealing with different issues because children grow, and children go into puberty at different times, which means that bone density increases at different times. So if there is a 13-year-old boy who is in very early puberty versus another 13-year-old boy who's almost come to the end of his puberty, the second one will have much higher bone density. But that doesn't mean the first one has osteoporosis. Not at all. He just has to put away more bone. He's still waiting. So data need to be compared to pediatric reference data that provide age, gender, and height-specific Z-scores. So it doesn't end there. Unfortunately, according to different machines, once again, according to the type of the machine, according to the make of the machine, the Z-scores change. So this was a paper that we wrote actually way back, I think it was in 2010, when we had our earlier Dexa scanner. But we find that the results of our current scanner are actually totally different. And so now we are reinventing the wheel. So reference data is one of our pet peeves, and that is one of the reasons why it is quite difficult to actually interpret Dexa in children. The other reason, as I said, is size adjustment. So what happens is the Dexa, though it is called as bone density, if you carefully look at the Dexa report, you will find that it says gram per centimeter square. So centimeter square is not actually density. It is just area. So it gives you what is called as the areal bone density. So what it means is that a smaller child is reported to have lower bone density than a taller child. So it's not really true that a short child always has low bone density, but unfortunately, that's how the Dexa reads it. So what do we do about it? So we use various calculations to actually calculate bone mineral apparent density, which is bone density adjusted for size. So I won't go into details, but for lumbar spine, we use a particular formula. For the femur, we use a particular formula. Another method that we use is something called is a method that was introduced first by a scientist called Dr. Christian Molgaard. And this is really something that I use all the time. So you look at bones to see whether they are short bones, thin bones, or light bones. So if a child is short, then we actually classify the child as having short bones. If a child's bone area, so the bones are thin for the height, then we call them thin bones. And if there is less bone mineral content for the total bone area, we call them light bones. So, I think even if I can just impress that, size adjustment has to be done, that is enough here. So if you look at a Dexa scan and you look at, the end of the Dexa scan, if you look at the report, you can actually see that you can At the end, you can see, you can diagnose short bones, low bone density, and thin bones. Also, there is one more parameter which will tell you whether there is amount of bone for the muscle is adequate or not. So this is another very important parameter. So the thing is, though we all always look at bones, muscle is a very, very important consideration. So those children, I mean, especially like today, you know, so many children have turned into couch potatoes. Sedentary lifestyle is so common now. So if a child doesn't actually put power or force on his bones, then if the bones are not stimulated, they actually do not get mineralized, and the stimulation of the bones is done by the muscles. So strong muscles will give you strong bones. So, I mean, I cannot emphasize that strongly enough. So this is critical for actually differentiating primary muscle from primary bone disorders. So as you can imagine, in Duchenne's muscular dystrophy, the bones are weak, but it is up to us to decide whether the muscles are weak or the bones are weak. So I'll quickly take you through a few case studies. So this is an adolescent boy who presented with severe pain when a friend fell on him. He's about 12.5 years old. X-ray spine showed a fracture. So child had past history of leg fracture without any trauma at the age of 1. 2 fractures of radius following trauma at 3 and 9 years. Mom had multiple fractures during childhood. Aunt and cousins also had fractures. So actually the diagnosis is staring us in the eye. But just to take you through the Dexa interpretations. So 12.5-year-old boy, minus 2.6 Z-score, anything minus 2, meaning he's short. His adjusted spinal bone density is minus 2.03, which means it is low. If you look at femoral density, it is minus 3.9, so it is quite low. Are bones short for age? Yes. Are bones narrow for height? No, because this is not under minus 2. And are bones under-mineralized? Yes, this is under minus 2. Is there enough bone for muscle? No, this is minus 3.3. So this child had primary osteoporosis, was diagnosed as osteogenesis imperfecta, and then was treated with bone-active agents. A 4-year-old girl presented. So these are all cases who have come to us with a history of fracture of forearm with a minor trauma. On examination, she was short, height was 77.8. You can see she's really, really tiny, minus 5.2. Z-score is minus 5.2. Referred to our center for a Dexa scan to rule out osteoporosis. Because she was such a little person, only 4 years old, we did not do the femur. The spinal BMAD, or the adjusted bone density, was minus 2.5. Her bones were short. She was a short child. Not particularly narrow bones, though almost getting there, under-mineralized bones, and there wasn't enough bone for muscle. But with only 1 fracture, we can't categorize this child as having osteoporosis. So no, she doesn't have osteoporosis. Being an endocrine center, we did her bone age, which was only 1.6 years. I'll just remind you, she was a 4-year-old. Her peak stimulated growth hormone was 0.9. IGF-1 was 36 nanogram per ml, which was really, really low. Diagnosed to have growth hormone deficiency, and she had no further fractures. So this child was actually picked up by a Dexa technician. She called me and said, "Madam, she has growth hormone deficiency. Do you want me to do a Dexa scan?" Children with thalassemia, a child with thalassemia came with backache, and we did a VFA, and we found that L2 was actually affected, and we have published a case series on over 250 children where we found, I think, almost 10% had fractures of the spine. So that is why I keep referring to secondary osteoporosis. So this is what is there in this child. We see many cases of cerebral palsy, and children come to us, and actually children come with fractures. But one of the problems with children with cerebral palsy and doing their Dexa is that you can't position the child properly, and the Dexa is very, very position dependent. This was another child who came with steroid-induced osteoporosis, and post-treatment did much better. So what are the limitations of a Dexa scan? So doing scans or diagnosing bone density or weak bones in very young children is very difficult. Often we have very young babies who are sent to us, and it is very difficult to, they have so much little chub that it is very difficult to understand what the bones are like in very small babies. Also, under 2 years, there's practically no reference data. So whoever says that can we send a baby less than 2 years old, we generally say no. Size adjustment is a specialist is required for interpretation, though it's not that difficult. Measurements need to be repeated, preferably on the same machine. On a Dexa, you cannot differentiate between trabecular and cortical bone score. Those of you who deal with adult bones will know of the trabecular bone score, which has now been brought up by GE Lunar, but it doesn't work very well in children. We've done a study on that and published, but it doesn't work. And presence of contractures and other conditions where the patient cannot be positioned. Sometimes children cry so much, it is very difficult to do a Dexa scan. And of course, our pet peeve, lack of reference data. So we have actually started using a machine called a PQCT, a peripheral quantitative computed tomography machine, which actually differentiates between the cortical and the trabecular bone. And it has been giving us lots of very interesting results in chronic disease states. It also talks a lot about the muscle density, about the quality of the muscle, the fat infiltration of the muscle, and we are really enjoying working with the PQCT. So to summarize, Dexa is the gold standard for measuring bone density. Reports given by different machines are different. T-scores are not used in children. We use Z-scores and the ISCD guidelines. Diagnosis of osteoporosis cannot be made in a child with a significant fracture. You may just be looking at a child who's still not gone into puberty, who's still waiting to mineralize. While interpreting Dexa in children, age, height, gender, pubertal status, and ethnicity need to be considered. Indian children's bones are different than Western children's bones. While evaluating a child with osteoporosis, it is critical to differentiate the primary from the secondary osteoporosis, because in secondary osteoporosis, apart from dealing with the secondary osteoporosis, you have to treat the primary condition. Many chronic childhood disorders affect bones, so please keep secondary osteoporosis in mind when you are looking at a chronic childhood disorder. Asymptomatic vertebral fractures are under-recognized, and a high index of suspicion is necessary to actually diagnose a vertebral fracture. This is our bone and muscle facility at Pune. This is our GE Lunar Dexa. This is our PQCT. And this is a machine called a jumping mechanography, which we use to measure objective muscle function. And we have a similar setup at our rural center in Ranjangaon, where we are doing rural health studies. And these are some of our publications in the area of bone in the last few years. And thank you.
Thank you, ma'am. Thank you, ma'am, for that wonderful session, ma'am. And as you have highlighted the point that especially the children who are suffering from chronic diseases like thalassemia, who are on long-term glucocorticoids, the bone health needs to be taken care of, and that has to be emphasized that we have to always take care of their bone health apart from taking care of the primary disease. So thank you, ma'am. Thank you for that wonderful session. It's always a pleasure to listen, ma'am.
Thank you. Thank you.
I hand over to Dr. Kanaya for further.
Dr. Weber, you have to introduce only Dr. Brada, sir.
Okay. Thank you. So now next topic for discussion is the Rickets, and it's my privilege and honor to introduce the teachers of teacher. And sir needs no introduction to anybody in the endocrine fraternity in India. Sir is presently the president-elect of Endocrine Society of India, and sir is presently heading the Department of Endocrinology at PGI Chandigarh. Sir has done numerous work in bone health, especially the parathyroid, and sir would be taking us through and giving us teaching regarding the Rickets. So I welcome and I offer warm regards to you, sir. All stage is yours for further, sir. Thank you, sir.
Just to add till sir is sharing, the chapter Rickets in the latest edition of Williams is written by sir.
Sir.
We welcome you, sir.
Thank you.
Sir, unmute yourself, sir.
I'm unmute here. Can you hear me?
Yes,
Hello.
sir.
Yes, sir.
Okay. Yeah.
Thank you, Team Hormone India, Dr. Vaibhav, Dr. Mayur and the team, and Dr. Kanaya and Dr. Tony Joseph for this opportunity to speak on a very, very common topic, which is of interest for all of us. So let me share my screen. Is my screen visible now?
Not yet, sir. Not yet.
Not yet, sir.
Now?
No, not yet, sir.
Just a minute. Let me. Now it is visible?
No, sir, still we cannot see it. Tech team, can you share the slides?
Okay, I can send the slide. Hello. Thank you. Sorry for this delay. And thank you, Team Hormone India, for this opportunity to talk on an important topic, that is the rickets. The rickets is a term came from meaning that there is a ricken or to twist. And another term which is, say, comparatively adult is called osteomalacia. So long back this term was described, and first time is described in the dogs actually and the reptiles. And we have recently listened a wonderful talk from Dr. Javalkar ma'am, and the next which is unable to differentiate from osteoporosis and osteomalacia. So remember this one thing is that.
So your voice is not coming. Yeah.
Not coming?
Yeah, it's
audible, but not clearly. I think the mic, there's some problem. You need to be closer to the mic, sir.
Okay, now?
It was coming before, sir. Now it's not.
Hello.
It's like poorly audible, sir. It was coming initially for a few minutes. Yeah.
Okay, let me continue. I think slides are visible now.
Yes, slides are visible, sir. You can be little louder, so probably it will come.
So,
yes, sir, thank you.
Specific bone disorder of the growing skeleton, and that mainly affects the children and adolescents before their epiphyseal fusion. So defect and delayed mineralization of growth plates in the bones, which ultimately leads to the subnormal linear growth and the characteristic skeletal deformities. The rickets is mainly caused by nutritional deficiencies, especially in our country, and there are many other disorders those can cause the rickets. So what is the pathogenesis of the nutritional rickets? So we all know that these two important factors, those are playing a role in the rickets. That is, one is vitamin D deficiency and another is dietary calcium deficiency. Though many people does not recognize that dietary calcium deficiency per se can cause the rickets of the osteomalacia, but it is very well documented. So we all know that vitamin D deficiency convert in the skin under the UV light in the UV light range of 290 nanometer to 310 nanometer, and that convert into the 25 hydroxylation, and subsequently there is 1 alpha hydroxylation takes place in the kidney, and the 25 takes place in the liver. And then subsequently, if there is a vitamin D deficiency there, because of the vitamin D deficiency, there is inadequate intestinal calcium absorption. And because of this inadequate intestinal calcium absorption, there is decrease in the serum calcium level, and that low serum calcium level with the low vitamin D leads to the serum rise in the serum PTH, and which will ultimately lead to the low serum phosphate. And we all know that serum phosphate plays a very major role in the chondrocyte apoptosis. So if there is chondrocyte apoptosis does not take place, in that case there is delayed and chondral calcification, and that actually results in the rickets and the osteomalacia. Similar thing can happen with the inadequate dietary calcium, and that can cause, or there may be some reason because of the decreased serum 125 dihydroxy vitamin D, that can also result in rickets and osteomalacia. So the rickets and osteomalacia can be caused by dietary calcium deficiency or vitamin D deficiency or some of the genetic causes. Those are responsible for the conversion of the vitamin D to the active vitamin D. So here is the growth plate of the rickets in the patient, a normal growth plate, and which has actually 5 zones. That is called germinal zone, and then subsequently there is proliferative zone, then hypertrophic zone, and finally the zone of calcification, and finally the zone of ossification. So you can see the growth plate here in the red, and that will ultimately looks like that in a normal individual. So what we need for a mineralization, we need 4 things. That is, one is calcium, another is phosphorus, and third is alkaline phosphatase, vitamin D, and PTH. But sometimes, but because of some abnormality in the collagen, that can sometimes present as a rickets or the osteomalacia, though it is not very common, but that can sometimes cause. And the example is fibrogenesis imperfecta osseum, or that is called the FIO. And what infrastructure we need in addition to the raw material for the rickets for the bone mineralization. The infrastructure required is the osteoblast cells, those are bone forming cells, osteoclast cells, those are bone resorpting cells, and the osteocyte, indeed, that will take care or we control the osteoblast and osteoclast, and finally the collagen. These are 4 important components of the mineralization are there. Now coming to the spectrum of the cases of the etiology of the rickets or the osteomalacia. So in broadly we can divide into 4 groups. One is the calcipenic rickets, that is because of vitamin D deficiency or the nutritional rickets, or that is because of vitamin D receptor 1 deficiency, that is 1-alpha hydroxylase deficiency, or vitamin D dependent rickets type 2, that is because of the what you call vitamin D resistant rickets. The phosphopenic rickets, that may be sporadic, that may be familial, and the tumor-induced osteomalacia, though it is not very common in the young age. Then other category is the renal tubular acidosis. It may be proximal, it may be distal, or the mixed. And then the rare causes of the rickets or osteomalacia, that comes with the hypophosphatasia, as I mentioned, the fibrogenesis imperfecta osseum, but the main problem is in the collagen. And then is another example of this rickets in the osteomalacia, that is called axial osteomalacia. Though I'm not covering in the detail osteomalacia, I'm just talking about the rickets only. So these are the symptoms of the rickets. The skeletal manifestations, well-known skeletal manifestation rickets are skeletal deformities. These deformities depends on what is the patient is developed the symptoms. Like when the patient is started crawling, meaning by that initial features of deformity in the upper limb. And the another feature is bone pain, and the rickets are an important cause of short stature. Sometimes patients with the rickets can have the fractures and some of the dental abnormalities. Those are much more common in the hypophosphatic osteomalacia as compared to the vitamin D deficiency rickets. And these are the various extraskeletal manifestations. Those are in form of hypotonia, proximal muscle weakness that can lead to the abdominal muscle weakness, can present in form of the protrusion abdomen, the abnormal gait, and then sometimes the calcium deficiency is very severe. Patient can have the tetany or the seizure or the reversible cardiomyopathy. So these are the various skeletal manifestation and extraskeletal manifestation of the rickets osteomalacia. These are the various signs, and that is again depends on the that is present overall body. That may be in the skull. There can be a craniotabes, frontal bossing, delayed closure of the anterior or posterior fontanelle, the dentition, that is delayed eruption of the teeth, dental enamel hypoplasia, then extremities, well known, that is probably the most common signs, that is genu valgum or the genu varum. And some of the severe patients, they can have the windswept deformity. In one lower limb, there is genu valgum, and other there is genu varum. In the thorax, you can look for the rickety rosary or the Harrison sulcus. Spine, the patient can have kyphosis, scoliosis, or the lumbar lordosis. And the neuromuscular, as I mentioned, patients have port belly in form of hypotonia or the delayed motor milestones. And they can have the symptoms of the hypocalcemia in form of positive Vostek and the Toje signs. So the Rickets patient actually having the lot of symptoms and signs that depend on the severity and the etiology, and that will sometimes help to differentiate what is the etiology of the Rickets. Now, coming to the approach to the Rickets, I think this slide is a little busy, but you can differentiate, or the first investigation can be alkaline phosphatase. If the alkaline phosphatase is low, then the diagnosis is the hypophosphatasia, which is very rare, but it is important to look for this disease because the treatment is totally different for this condition as compared to others. And then you can see the calcipenic rickets or the phosphopenic rickets. In the calcipenic rickets, the vitamin D may be low, or the 25-hydroxyvitamin D is low, or the 25-hydroxyvitamin D is normal. If it is low, then there is a possibility of vitamin D deficiency or vitamin D dependent rickets type 1B. Or if the 25-hydroxyvitamin D is normal, still patient is having features of rickets of the low calcium, the low phosphate, then we have to look for the 125-dihydroxyvitamin D. If the dihydroxy 125 D is low, active vitamin D is low, then there is a possibility of vitamin D dependent rickets type 1A. If it is normal or high, in this case, there is a possibility of calcium deficiency. Or if it is high, then the diagnosis is vitamin D dependent rickets type 2, or we call it is a resistant rickets also. And if the calcium profile is normal, that is very, very important many times. And these are the actually falls in the category of the skeletal dysplasias. If the phosphate rickets there, most important feature is low phosphate, but always it should be analyzed in presence of the normal vitamin D. And in that case, you can look for the TMP-GFR. If the TMP-GFR is low, then there is, you have to look for the amino acid urea, or the, you can call the bicarbonate level or urinary glucose estimation. So if it is, these are high, then there is a possibility of renal tubular acidosis. If these are normal, then we have to go for either it is vitamin D dependent rickets type 2, or we have to look for the FGF23 level. FGF23 level is high, then it is the XLH, while it is low, and then there is a possibility of the HHR, that is hereditary hypophosphatase with hypercalciuria. And if it is high phosphate, then there is various low TMP-GFR is high, then we have to look for the dietary phosphate deficiency, which is actually very rare in the clinical setting. So this is the approach to rickets, but you can plan this approach to rickets in form of the looking at the low phosphate also. Now the recently people are talking the phosphate is the major culprit for causing the rickets, whether it is vitamin D deficiency or whether it is a primary phosphate deficiency. So this is the typical radiological findings, and nicely seen in this radiograph that it is cupping, there is spraying, and the splaying is there, and the growth plate is enlarged. Now I'll take you a few interesting cases quickly. A 19-year-old boy who presented with lower limb pain and the deformity. So you can observe here, then difficulty in walking from last 2 years. The past history, at 8 years, he developed the jaundice. At 14 years, he has a bilateral knee pain. And at 17 years, he has a fragility fracture of the right femur. You can see here. And at 18 years, bilateral cataract and underwent the cataract surgery. So this is basic history of the patient. He was short stature, and he also had a scoliosis, and the various other findings suggestive of rickets were present in this 17-year-old boy. Coming to the investigations, so you can see that creatinine was elevated, though ALT and AST were normal, phosphate was low, vitamin D was normal, alkaline phosphatase for this age, it is border mildly elevated, and the urine pH was 7, and the TMP-GFR was very low, and the BBD shows the normal anion gap metabolic acidosis, and urine analysis shows the presence of the glucose in the urine or the sugar in the urine. So that is now, I'm sure the diagnosis is almost clear that we are treating the patient who is having hypophosphatemia, who is having the creatinine, elevated creatinine, and the low TMP-GFR. So it's further investigated and found to have the Coulson liver echo texture, and the serum ceruloplasmin level was normal, of course, And the liver biopsy suggested to be chronic hepatitis. And this patient underwent the copper content estimation, and it was high in this patient. And so the diagnosis made was the Wilson's disease. But the Wilson disease leads to the what we call type 1 or the type 2 or the type 2 RTA, that is having the features of the glycosuria and proteinuria. So this patient is now coming to the treatment. Treatment is for the primary treatment for the disease, that is now zinc is the treatment for that, or you have to supplement initial time so that the mineralization can take place. Another patient, this is the 12-year-old boy, and you can see severe deformities are there in the upper limb, chest, as well as the lower limb. And here is the biochemical profiles. You can see the calcium was normal, phosphate was low, alkaline phosphate is sky high, and the PTH was suppressed, that is 2.5 picogram per ml, and the calcitriol level was 36 picogram per ml, that was the inappropriately low. The fibroblast growth factor FGF23 was normal, and urinary calcium was very high. So you can see that patient is having two important features. One is low phosphate, low TNP-GFR, and the high urinary calcium. So the diagnosis is the HHRH. So here is the X-ray of the patient. There's gross deformity. All the bones are severely deformed, as well as having the multiple fractures also. So this patient actually having the diagnosis of the HHRH, and it was the mutation proven, and the patient was homozygous, while the both parents were having the heterozygous disease. And obviously treatment here is just phosphate supplementation, not the active vitamin D is not required in these patients. Now coming to another case, the 16-year-old boy, past history of fragility fracture in right leg 2 months back, and he was under the plaster cast for the immobilization, and somehow fracture did not heal. And he also had a 3 to 4 centimeter right-sided neck swelling. He had right leg shortened and internally rotated. He has kyphosis, fractus carinatum, rickety rosary, Harrison sulcus, and wrist and ankle widening was there. So here is the picture of the patient, and you can see that large mass is there in this neck. So initially this patient was thought to have the some thyroid malignancy actually, and he admitted, but his profile was like this. Calcium was 15.6 milligram per deciliter. PTH was very high, and vitamin D deficiency was also there, but he had a bilateral renal stone disease and the pancreatic calcification as well. So here is the picture, and the patient had a parathyroid adenoma, successfully operated. So PHPT presenting as Rickets osteomalacia. Coming to the another case, that is similar patient with the primary hyperpara presenting with the OFC and the features of the Rickets and osteomalacia, with the treatment subsequently shown a very good improvement after the successful parathyroidectomy. Another patient, 7-year-old boy, he presented knock knee at the 1 and 5 years of the age, and the poor height gain since 1 year of age, and diagnosed with Rickets 3 years age, but no response to calcium and vitamin D. He had also had an episode of GTCS, and started on the phenytoin, which he received for almost 6 months. So after stopping, here is the clinical profile of the patient: bilateral genuvalgum, he was short as well as wrist widening, and having other features of the Rickets osteomalacia. Here is the biochemical profile. So patient had low calcium, alkaline phosphatase was high, and even after off phenytoin, it was like that. And the PTH was high, though vitamin D level was normal in this patient. So you can see the low calcium and the normal vitamin D with the high PTH. So here is the X-ray of this patient. You can see these subtle signs of the Rickets are there in the knee joint, and this more florid signs of the Rickets in the wrist area. So in this patient, the features of Rickets and hypocalcemia, normal 25 hydroxy vitamin D, also inappropriately normal 125 dihydroxy vitamin D. So the diagnosis considered the vitamin D dependent Rickets 1A. The patient was treated with the 125 active vitamin D and showed a very nice improvement. also is subjected for the clinical exome sequencing, and that shows the TRPV4 heterozygous mutation, which was actually a variant of uncertain significance. So we are still not sure that is it really contributing or something else is there, but the clinical diagnosis was the VDDR1A because of the patient responded very well to the 125 dihydroxy vitamin D. Last patient, the 5-year-old boy, poor height and weight gain, and he had features of the rickets and the history of frequent falls for the last 2 years, and he's significantly short, and the intermalleolar distance was high, having other features of rickets and osteomalacia in form of genu valgum, rickety rosary, pot belly, kyphoscoliosis. And here is the investigation. So you can see the most of the investigations are normal, including the calcium, phosphate, magnesium, and the PTH was 33, vitamin D was 43, and the thyroid profile was normal. And you can see the VBG is also normal, but the TMP-GFR was on the lower side. Sorry, the TMP-GFR is also within the normal limit, that is in the millimole, so it is the normal. So here is the picture of the patient skeletal survey. You can say this epiphysis is small, and there is platyspondyle is there. So in this particular patient, we have seen the complete metabolic bone profile was normal, and having the features suggestive of the rickets in form of the delayed bone age, in form of the small epiphysis, and the cupping and fraying are there. Similar finding in the knee joint also. So the diagnosis is actually spondylo-epimetaphyseal dysplasia. So the message I want to give here is that if the calcium profile or the metabolic bone profile is absolutely normal, we should look for some bone dysplasias. So Rickets mimic, and the treatment is here is that just calcium and vitamin D routine supplementation, and now recently growth hormone therapy is approved for the treatment of this. So I end my talk by saying here that Rickets is a disorder of growing skeleton characterized by impaired mineralization growth plate, and this varied manifestations are there, multiple causes and etiologies are there, but still in our country, neutral rickets is most common, and genetic causes to be considered, and always keep in mind about the bone dysplasia. Thank you very much for your patience hearing. Thank you.
Thank you so much, sir, for your wonderful talk and presenting the cases with different diagnoses, and they are the mimickers of the rickets. So we have been enlightened by your thought and your concepts. Thank you so much, sir. And also thank you, the Khandarkar ma'am, for the wonderful presentation. So with that, I over to the Hormone India team, Dr. Shekhar, for the next session. Thank you, sir. Thank you.
Thank you. Yeah.
Yeah, let me introduce. Dr. Shekhar has done his DM endocrinology from Shere Kashmir, and he is presently working at Hormone India Center, Rajmundry at Andhra Pradesh. Over to you, Dr. Shekhar.
And Dr. Manoj Gedam sir, and Dr. Karthik sir. Now over to Dr. T2 Omen sir to introduce our speaker, Dr. Vijay Sardev.
First of all, thanks to the Hormone India team, and especially Dr. Tony for inviting me to chair this session. So the first speaker for this session on pubertal disorders is Dr. Vijay Sardev. He needs no introduction. He's a very well-known figure in the world of Indian endocrinology. He's a professor and head of Department of Endocrinology at Vaidehi Institute of Medical Science, Bangalore. He has multiple publications, and he is a reputed and very eloquent speaker. So without much delay, and we are running a bit late also, I think. So I'll hand over the session to Dr. Vijay Sardev to elaborate upon his topic.
Thank you so much, Dr. Titu. At the outset, I would like to thank Hormone India for this opportunity. So I will be briefly speaking on approach to a patient with delayed puberty. In fact, like it's a very common condition which we all encounter in our endocrine practice. So I'm going to make it a very simple and case-based approach. So to start with the case one, we have a 12-year-old boy presented with weight gain for the last 6 years, and he also complained of small genitalia and also concern for absent secondary sexual characters. So his height and weight were normal, though weight was on a little upper side, and he was taken to a pediatrician who did gonadotropins and testosterone. The FSH is 1.2, LH is 0.13. Serum total testosterone is 10 nanogram per deciliter. In fact, when compared to the adult reference ranges, they were all sounding very low. So what is the diagnosis of this child? Is it an hypogonadism? Is it a disorder of sex development? Is it an isolated micropenis or a normal genitalia? In fact, the perception for many of the pediatricians is that it could be a possible hypogonadism. But when we examine the child thoroughly, after pressing the pubic pad of fat, the stretch penile length was pretty okay for the age. It was 4.5 centimeter. And the testicular volume was 2 cc bilateral. In fact, which is very reassuring, because someone who have a testicular volume of 2 cc, that means they have undergone or gone through the mini puberty, during which the testicular volume changes from 1 cc to 2 cc. If the same child would have come to me with a testicular volume of only 1 cc, then I would have been definitely been looking at the possible congenital hypogonadotropic hypogonadism as a diagnosis, but 2 cc is really reassuring. He had absent pubic hair, that's a pubic hair stage 1, but are we really concerned about that? Because his stage is prepubertal, right? So in a 12-year boy, even if he's not having any secondary sexual characters, so I don't worry about it, because we call it as pathological not to have secondary sexual characters only by 14 years of age in boys. And again, then especially in obese children, the buried penis commonly mimics micropenis, which is often a concern with which the parents bring their children to us. And that's the reason why micropenis definition should never be based on the inspection, but it should be based on the measurement of stretch penile length. So how do we do that? It's measured using a non-stretchable tape, and from measurement is taken typically from the pubic ramus to the tip of the gland, after stretching the penis to the point of increased resistance. If at all there is an excess foreskin, definitely don't forget to exclude it from the measurement. And the ruler should be pressed down against the ramus to completely depress the suprapubic pad of fat. Even the testicular volume should be objectively measured, typically using a Predis archidometer. Of course, it's very, very important that all of us are very well versed with the Tanner staging for both boys and girls whenever we are dealing with pubertal disorders. So moving on to the case 2. So we have a 17-year-old boy who presented with poor progression of secondary sexual characters. That means he had entered puberty in time, but like is not going through a process of complete puberty. He is relatively taller, though he is not taller for the reference population, but he is on the upper side of the reference population, and weight is normal. So look at his follicle length, it's around 10 centimeter, and the pubic hair stage is stage 4, which are pretty good. But the testicular volume is 4 cc bilateral, and unlike the normal soft consistency of the testes, they are firm in consistency in this patient. He also had bilateral gynecomastia. So what are we dealing with here? Is it a Kalman syndrome? Is it a Klinefelter? Is it just normal that we can just ignore, or it's a craniopharyngioma? Right. So as I told earlier, this child had a disproportionate virilization, but a smaller testes. That is typically happens in Klinefelter syndrome patients, because they do enter puberty usually at the normal time, but they don't complete puberty. That's also a characteristic of Klinefelter syndrome. So whenever we have these kind of scenarios, especially with the gynecomastia, our first DD would be a Klinefelter. So how do we go ahead with these patients? Do a gonadotropins, typically the FSH, which was elevated here, again, which is favoring a diagnosis of Klinefelter because there's a hypergonadotropic hypogonadism. How do we confirm the diagnosis? Do a karyotype, which was 47 XXY, which makes a diagnosis of Klinefelter syndrome. So whenever we have a boy who presents to us with delayed puberty, the very first thing we need to do is that look for gonadotropins. If gonadotropins are elevated, the next thing is to do is a karyotype. If it's 47 XXY, that's a Klinefelter. If it's a 46XY, it could be any other cause of primary gonadal failure. For example, it could be an orchitis, could be a surgical orchiectomy, and so on. Very rarely, even 46XX could be a possible karyotype, where we have to make a diagnosis of a possible 46XX testicular DST. If it's a delayed puberty in a girl, again, the first test is actually the retropens, and followed by, if elevated, do a karyotype. If it's karyotype is 45XO, it's a Turner. If it's 47XXX, then we know it's a XXX syndrome. If it's a 46XY, again, though it sounds surprising, but we also need to understand that several 46XY disorder of sex development can be read as girls and may present as delayed puberty in a girl. So the common causes are complete insensitivity, complete gonadal degenesis, and 17-alpha hydroxylase deficiency. In fact, many more are there to be added to this list. If it's a 46XX, then obviously it's a XX gonadal degenesis or other causes of gonadal failure in a 46XX. So, for example, it could be a FOXL2 mutation, or it could be a galactosemia or a Fragile X syndrome. So moving on to the case 3, here we have a 16-year-old girl who presented with a poor height gain, and she also had absent secondary sexual characters. Height was 134, that means she was short, but she was normally weighing for the reference population. Her born age was delayed. It was 11 years for 16 years of chronological age. And she underwent a growth hormone stimulation test in an outside setting where the peak growth hormone after clonidine stimulation was 1.2 nanogram per ml. The evaluation for puberty revealed a low FSH, low LH, and a low estradiol. So she was further evaluated with other anti-pituitary hormones. The T4 was normal with a normal TSH. ATM cortisol was normal. Even they went ahead with an MRA pituitary as there was a possible growth hormone deficiency and gonadotropin deficiency, but the MRA pituitary was normal, and she was made a diagnosis of concomitant growth hormone and gonadotropin deficiency and referred to us for growth hormone therapy. But are we going to agree with this, or do you have any different thoughts? Is it an isolated growth hormone deficiency or a combined pituitary growth hormone deficiency, or it is a Turner syndrome or a systemic illness? In fact, we got shocked when we examined the patient because she had a massive hepatomegaly, which was easily missed in the examination. And when we did a further evaluation, she had an elevated triglycerides with uric acid. Both were going in favor of glycogen storage disorder type 1, which was also confirmed on a liver biopsy. But surprisingly, again, she did not have any clinical or subclinical hypoglycemia despite having a GST for 16 years. So it really taught us that how systemic disorders can masquerade the several endocrine disorders, especially the growth hormone deficiency as well as gonadotropin deficiency. So what do we learn from this case is that if at all, if we have a delayed puberty with a low or inappropriately normal gonadotropins, the very first thing we should do is to rule out systemic causes, because they do cause something called as a functional hypogonadotropic hypogonadism. The very next thing is to look for a primary hypothyroidism by measuring an TSH. If it's elevated, we know it's a primary hypothyroidism, though really it can present with a precocious puberty. A common effect of hypothyroidism on puberty is actually delayed puberty. Moving on to the case 4, again, another 17-year-old boy who presented with weight gain for the last 3 years and poor secondary sexual characters. He's short and not with normal weight. He has inocoid proportions with USLS ratio of 0.84 and arm span height ratio of 7.4. He also had gynecomastia. SPL was around 4 centimeter with G2 stage of genital development, but the pubic hair is stage 1. He had 2 cc of testicular volume and soft, probably saying against Klinefelter. But is it a normal pivotal development for age? Is it a hyper-hypo, or it's an isolated hypo-hypo, or a combined pituitary hormone deficiency? Very unlikely to be normal because this child is a 17-year-old boy. At least by now, he should have started with a testicular enlargement. It's not the case. As I told earlier, hyper-hypo is unlikely because his testicular consistency is good and there is no disproportionate virilization. And combined pituitary hormone deficiency is also unlikely because he's not very short. So obviously, more likely we are dealing with congenital hypogonadotropic hypogonadism. Evaluation revealed a relatively delayed bone age with of around 12 years. Growth hormone stimulation test again revealed a low peak GH of 1.1. FSH was low, LH was low, testo was low. So again, there was something suggestive of both growth hormone as well as gonadotropin deficiency. And prolactin was slightly elevated, cortisol was low, free T4 was low. So there was a deficiency of all the anti-pituitary hormones. So when we did an evaluation, it turned out to be a case of craniopharyngioma with a combined pituitary hormone deficiency. So very, very important that when after ruling out the systemic illness and primary hypothyroidism, in any patient who is coming with delayed puberty with a low or inappropriately normal gonadotropins, it's also very important to rule out the pituitary hypothalamic pathologies, which could be a prolactinoma, which could be a craniopharyngioma, or any other etiologies. Moving on to the next case, we have a 14.5-year-old boy who presented with poor secondary sexual characters with an SPL of 4.5 centimeter with a P1 stage of pubic hair, testicular volume being 2 cc bilateral, again soft. So he's again slightly short with a normal weight and is proportionate, though is short. And again, bone age is slightly delayed. Gonadotropins are low, testosterone is low. The systemic evaluation is normal. Again, the growth hormone stimulation test revealed a low peak GH. Prolactin is normal, cortisol is normal, and free T4 is normal with a normal TSH. So what are we dealing with here? Is it an hypogonadotropic hypogonadism, or it's a hyper-hypo, or it's a normal pubertal development, or a constitutional delay in growth and puberty? So if we look back and ask for a history in a family with his father or really even the mother had any delayed onset of puberty, but they could complete the puberty over time, that could be a very good clue which could be there and in fact was present in this child. And also there's a testicular volume of 2 cc, which is a little assuring that definitely he did not have a severe congenital hypogonadotropic hypogonadism. So most likely diagnosed as a constitutional delay in growth and puberty. So that's also been supported by the absence of other hormonal deficiencies like cortisol or thyroid. But why does this child had a growth hormone deficiency? It's very, very important in patients suspected CDGP. Whenever you're evaluating for a growth hormone deficiency, they should be primed with testosterone at least 3 to 7 days prior, because the absence of the sex steroid priming may lead to a false diagnosis of growth hormone deficiency in children with CDGP. In fact, how do we make a diagnosis? There are several tests which are there to differentiate between CDGP and CHH, but the gold standard is just a wait and watch policy. In fact, like if the patient is also suffering from some psychological issues regarding the short stature or the delayed puberty, they could also be primed with a short course of testosterone, which is around 100 mg once a month for 3 to 4 months. In fact, that was done in this particular child. When we followed up the child 6 months later, there was a quick height gain, and also there's an increase in the testicular volume from 2 cc to 6 cc, which are very reassuring that this child was actually a case of constitutional delay in growth and puberty. So after ruling out all the pathological causes, we need to consider constitutional delay in growth and puberty in a delayed puberty child. Always look for the features which may be concurring, like mild short stature with an height age equal to bone age, and also look for an observation whether the child picks up with the testosterone priming. If none of these, obviously we are finally making a diagnosis of idiopathic hypogonadotropic hypogonadism. But there are some clues which you could actually pick up in the beginning. If someone has an altered taste sensation, or a cleft lip or a cleft palate, or a testicular volume of 1 cc, in fact, all these features would suggest the diagnosis of hypogonadotropic hypogonadism, which is congenital even from the beginning. So to summarize quickly, delayed puberty should be considered only in boys who are aged more than 14 and girls aged more than 13. Buried penis is common in obese children, which often leads to evaluation of hypogonadism, which all of us should be aware, especially the pediatricians, and interpret sex hormone and gonadotropin levels with age and sex-specific reference ranges. Elevated FSH suggests a hyper-hypo, which should be closely, if it present, karyotyping is the next investigation of choice. In any delayed puberty child who comes to us with a low or inappropriately normal gonadotropins, first thing is to rule out systemic illnesses. Primary hypothyroidism, hypopituitarism, hyperprolactinemia could be other causes of delayed puberty, which should be ruled out before making a diagnosis of CDGP. CDGP is the most common cause of delayed puberty and is a diagnosis of exclusion. Trial of therapy with testosterone kickstart puberty, and idiopathic hypo is a closed DD for CDGP, but wait and watch policy is the best way to differentiate this condition from hypo. Thank you so much for the patient hearing.
That was an excellent presentation, Dr. Vijay. Are we taking questions now?
No, sir.
No, sir. We are already running late, and we've also, just to introduce, now we have live Dr. Somnath Raghuvanshi. He is an observer for the MCI credit points. He has done his DM Endo from Calcutta Medical College, and he is presently practicing as an endocrinologist at Bhopal. I welcome you, sir. Kindly unmute, sir. Okay. Over to you, Shekhar. You can introduce the next chairperson.
Thank you, Mayur, for your nice introduction.
Okay. May I now request Dr. Manoj, sir, to introduce the next speaker, Dr. Mohan, sir.
Hello, am I audible?
Yes, you're audible.
Yeah. So first of all, thank you very much, team Hormone India, for giving me this opportunity to chair this session of pubertal development. So our next speaker is, can I have the slides, please? So the next speaker is Dr. Mohan T. Shenoy. Sir is a senior consultant endocrinologist at Trivandrum. He is a joint secretary of Indian Medical Association Trivandrum till 2021. Is a joint secretary Indian Academy of Pediatrics, and he's also social media coordinator wellness endocrinology. He's presently working in the Department of Endocrinology at the Sri Gokulam Medical College. And also he has present affiliated to Department of Endocrinology at GG Hospital and Hospital Trivandrum. He has major achievement in the form of he has received a gold medal in first year Kerala University in 2003, and he has awarded special appreciation award for endocrinology awareness in 2021, and he's also the scientific secretary of Pediocon in 2022. So to deliver his talk, I would like to hand over the session to Dr. Mohan T. Shenoy, sir. Over to you, sir.
Thank you, Dr. Manoj. Am I audible?
Yes, sir, you are audible, sir.
Okay, I'll just share my screen. Thank you. I think I cannot share right now.
Yes, sir. Now you can share. Yes.
Just checking with the RX events. Is my screen visible now?
Yes, sir, it's visible. Yes.
Okay, thank you very much. Thank you, Dr. Tony Joseph, for inviting me. Thank you, Mayur, and thank you, Hormone India. Excellent conference. So I will just deal with the scientific topic, which is Turner syndrome and how to induce puberty in this condition. We already got through the approach of delayed puberty. So I will just rush through how we conceptualize this topic. February is the month where Turner syndrome awareness globally is kind on, and this is a symbol for the crimson ribbon. It's a symbol of Turner syndrome awareness, highlighting that this condition needs to have a registry itself, and India is also going through these things. So then a case capsule, how many challenges, how can you face the challenges, how to induce the puberty optimally, and how to counsel the patients on follow-up. So Dr. Vijay Sarathi dealt with approach to puberty. Puberty is rather a continuum, and there is a physiological process which occurs. And the teenage time is a crude terminology from 13 years to 19 years, whereas puberty is a technical term used for the physical and endocrine changes in this period. Adolescent is again a profound psychological change which encountered during this time. As this graphic you can see here, adolescent period is just like a barren land. There is an unclaimed territory where the physician, the pediatrician, the gynecologist all delve into. And of course, endocrinology stands as one of the major person who can help the transition period also. You can see the physiology of puberty. Before I go into Turner syndrome, remember that these all many hormones regulate the type of puberty which goes through. There is a neuroendocrine control which was established in 1900s. As time went on, various other channels were discovered and treatment was also uncovered. And we can see that GPR54 kisspeptin genes are described for this gatekeeper of puberty. So this is a scientist, Henry Turner, who described the Oklahoma physician who described the condition 1938. So the puberty, which usually takes off like a rocket, is actually delayed, and the females exclusively affected in the teenage period, and they can be diagnosed early if some clues are identified. So growth velocity is one of the easier tools, as Dr. Ganesh Javalikar has alluded to you, that growth charts are to be used in every clinic, in every pediatrician and every endocrinology clinic. So definitely area of suspicion is to be taken into mind when velocity is not happening. There is a Turner syndrome specific chart which captures the high velocity also. Let us go through a case capsule. A 15-year-old girl from Kolkata. This case was donated to me by Dr. Sunitra Mandal, one of our great experts in endocrine awareness. So this girl presented at 14 years of age with primary amenorrhea, and there was a minimal progression of secondary sexual characters, and some clinical clues are also shown here, which I will just ascribe to you. So Tanner staging was done. So the breast was just developed and pubic hair just developed, and there was no other axillary hair. So there was spontaneous thelarchy 6 months back. That is the age of 13.5 years. This girl came to Dr. Sunitra at the age of 14 years. At the time, diagnosis was very clear to them, and they were concerned about the puberty aspect. But as an endocrinologist, we know that we should also address the height aspect. She was only around 135 centimeter when she came at the age of 14 years, and there was grossly inadequate, the corresponding less than third centile for that chart. There was cubitus valgus, brachymetatarsalgia, and you can see the low posterior hairline. There was also cardiac evaluation done, which revealed a bicuspid aortic valve, primary hypothyroidism, which was treated. So which was adequately managed initially with recombinant growth hormone, because we know that we have to initiate estrogen only when we have get an adequate height, because estrogen can cause the fusion of the epiphyseal end, and which is why we should ideally start growth hormone before giving estrogen therapy. So the early diagnosis is important, and one of the best measures is the karyotyping. So this karyotype, which was seen 45XO, as well as another different type of karyotype was also seen in that case. So this is a typical case scenario which we can go through, and this is the description: the short stature, a delayed puberty, typical facial features of ptosis, hypothyroidism, micrognathia. We all know this in genetics, but we should remember that there are other conditions, systemic issues which can occur. That is the cardiovascular, genitourinary, and other things. Thyroiditis and web neck hearing loss are other things which go along with it. So definitely the foundation of the talk is establishing a good diagnosis. And this is done by a framework of history, physical examination, and growth charts. Of course, bone age is very important to be captured, salient labs, and finally the advanced imaging and genetic studies. Definitely the timely referral to the pediatric endocrinologist or the endocrinologist definitely merited when you have a case of Turner syndrome. This Sunitra Mandal group definitely had also described a karyotype phenotype correlation in Turner syndrome at a single center in Eastern India. So you can see that there is a good variation in the karyotype. The changes, ring chromosome can be there, isochromosome can be there. So in India, definitely the delayed presentation is very common, and the mean age is around 14.8 years. Primary amenorrhea is the most common feature, and height definitely has to be addressed in each case of Turner syndrome. And the reason why this occurs is there is an epigenetic abnormality coupled with the abnormal gene expression, and this ultimately leads to other systemic issues also. Then regarding puberty in Turner syndrome, the lack of two completely normal X chromosome leads to accelerated follicle loss. Because of the without viable follicles, this ovary doesn't produce adequate estrogen and progesterone, and there is a lack of spontaneous breast development. So approximately 10% of girls have spontaneous development. The majority is definitely not having that. So this spontaneous puberty development is seen more among the mosaic Turner than which is in our case. So majority of Turner syndrome will require induction with estrogen therapy, and 2 to 5% of them definitely have even menarche prior to ovarian failure. So which is the reason why premature ovarian failure is one of the reasons where we have to definitely address in these conditions. The same author group also published a journal publication regarding heterogeneity of karyotype. This is a cohort of patient 136. It's a high number, and we can see that a large number of person, 42% are 45 XO, and there are also some isochromosome, mosaic chromosome, and even rare complex chromosome types have been described. So what are the indicators of natural puberty onset? There is a normal range of FSH and AMH are the reasons where we can identify. So when we know that around the age of 10 years age, the follicles are not properly going into that range, so they go into the menopausal range, and AMH can be undetectable, and pelvic ultrasound may show no evidence of ovaries, that is streak ovary-like appearance, and an immature uterus. So like infantile uterus, they always come in. So these are the candidates which require puberty induction and a timely manner and maintenance therapy with estrogen progesterone combination. So the guidelines for my talk has been taken from the Cincinnati meeting, International Turner Syndrome, done in 2016. And this publication is a very large volume which describes the Turner Syndrome clinical practice guidelines. So considerations for optimum puberty are to provide an age-appropriate telarchy or breast growth, a near normal pubertal progression and menarche, adequate uterine volume for future fertility with artificial reproductive techniques, giving a proper height outcomes responsive to GH therapy. The three other things which are very important are the psychosocial, the bone health, and the metabolic parameters, which definitely are very important for the endocrinology perspective. What is the logic for the timing of growth hormone or the other therapies? We should definitely give them a good benefit regarding the body composition and metabolic profile. We should give them an adequate uterine size, which can be near adult, should avoid the cylindrical or the other uteruses, and psychosocial development has to be ensured just like the peers. And the delayed initiation of the estrogen is done only when you have to give a proper health height utility for these individuals. Coming to the practice guidelines, they recommend that estrogen therapy should start at around 11 to 12 years of age, increasing to the adult dosing around the 2 to years time. They advocate the chance by systemic route, and transdermal is what preference. We know India transdermal route is not available and not affordable in majority, and definitely we should add progesterone once the breakthrough bleeding occurs or after 2 years of estrogen therapy. This is what the guidelines tells you, and this is the pubertal sequence which occurs in the female. This is the breast bud appearing, the menarche occurs around 2 to 3 years after that, the pubic hair parallelly occurring, the height spurt occurs in the mid-range. So we can see that around 12 years to 13 years is the peak time when the bone acquisition also occurs. This is the time where estrogen therapy definitely has to be occurring in the peak time. So the age of initiation has to be kept around this period to maximize the growth potential. Low dose will be required because the proper breast shape, the uterine size and the volume can be ensured. And menarche, once is attained, progesterone is added. And that is the reason why we should do in a synchrony. The aim is to give a benefit on the endogenous estrogen levels, to give healthy fat distribution and bone mineralization, while minimizing the risk of the estrogen-like complications like gynecological cancers and the thrombogenic complications. In the past, we have had very limited choices like equine estrogen, pregnant marine uterus like Premarin, and the highly potent synthetic ones like ethinyl estradiol. Fortunately, last many years, we are also having estradiol valrate, which is also very useful for our population. The principle of induction is similar to produce effects like normal puberty. Start at a low dose of 1/4 to 1/8 of the adult dose and increase very slowly among the months to years, and to reach the maximum full dose around 2 to 4 years. I will tell about the dose. But initial period should be a very dominant estrogenic effect without interference from progesterone, because once progesterone effect occurs, the estrogen effect does not properly get into. And we should definitely discourage the use of combined OCPs in this regard. The disadvantage of fast induction is that there is a poor breast shape, uterus development, and a poor bone mass development. So unopposed estrogen exposure is required, and we have other therapies like oxandrolone, which have been used when we are using concomitant growth hormone therapy, which is not available used in India. But definitely, they should be discontinued prior to estrogen treatment, and progesterone should definitely delayed until the breast development is satisfactory. So progesterone is necessary to suppress the estrogen's proliferatory effect, and definitely it is only used after 2 years of unopposed estrogen treatment. We should avoid chronic exposure to estrogen also, because without monitoring the properly, it can lead to endometrial hyperplasia and risk for hemorrhage and neoplasias. This is the sequence which the Cincinnati textbook has described. Measure LH FSH annually starting at the age of 11 years of age. Observe for the spontaneous puberty. If it is not occurring, definitely we should high FSH short estrogen therapy. Increase the dose every 6 monthly, observing the breast and the bone age till the adult dose is reached around the 2 to 3 years. I will describe the types and dose in the next slide. So in this slide, you can see the European journal publication as well as the Indian publication, the availability of the drugs. Oral estradiol valrate is 1 mg equivalent, and you can see 17-beta estradiol is also available in some parts. Ethanol estradiol, the one which is definitely used also very predominantly 10 micrograms. The conjugated ones are not popular. Only for the priming purpose they are used in the growth hormone therapy type. That is only purpose we use them. Transdermal route is developed as a patch. It contains 0.75 milligram equivalent. Also, gel is also available. So these are the ways in which the initiation dose is described and adult dose is taken into. So I can urge you to just take a look into this in the future presentation. So the use of estradiol linaloral tablet is 10 microgram or 50 microgram tablet. This is the route by we use the European journal. I was hearing the talk by Dr. Rakesh Katkavat sir, Rajesh Katkavat. He had told the AIMS Delhi by using this same regimen of using half tablet every alternate and finally going into the adult dose by around 2 years of. This is a classic description in this table. So transdermal estradiol is the more physiological route. It avoids the first pass metabolism and comparatively is very useful. And this is the publication which shows you that compared to the oral therapy, there is a good adequate effect on the lipids, liver enzymes, and it's actually very good on the BMD as well. So the estrogen therapy is done, then we should definitely add progesterone therapy. The choice definitely is progesterone. Availability is the oral micronized progesterone, 200 milligram taken in the last 10 to 12 days of the monthly cycle or the last 20 to 30 days of the tri-monthly cycle. The more androgenic ones like medroxyprogesterone or norethindrone and definitely are the ones which may inhibit the optimal breast and uterine development. And definitely, as any hormones we know, require an annual examination of pelvis and regular breast examination. When they go into adolescence, a pap smear is also mandated. So cyclic therapy is done every month for 10 days. And based on this, we can definitely find a less incidence when we give in the proper timely manner. How to monitor them? Clinical is the best one. Biochemical tools are not recommended because they are not useful. Suppression of FSH is not adequate requirement. When you attain a TANA for breast, definitely takes around 2.25 years and similar to that with spontaneous puberty time. So oxandrolone, just a word on it. This is not used, but definitely it can be used in some very rare conditions. But the guidelines say that only used from the age of 10 years or older and maintenance is also required. So only used in the very short Turner syndrome child until the estrogen therapy is initiated. So clinical guidelines have shown that puberty induction by these methods have provided adequate effect and they provide very good results on the long-term basis. So developing into mature adult size is in a mature majority of 80% of cases by using a timely optimal induction. And just like normal girls, the Turner syndrome girls in this study provided a very good eye opener to this girl. So what happened to our young girl, the 15-year-old girl, the mosaic chromosome? So we can see that FSH levels were also high. The ultrasound pelvis showing atrophic ovaries, started on estradiol valrate 0.5 milligram daily, slowly increased till adult dose, and recombinant DHA was introduced initially and then discontinued later on as it showed a non-fused epiphysis. And finally, we can see adult the height was achieved at 141 centimeters. The breakthrough bleeding was achieved after 1.7 years by adding medroxyprogesterone later on. So the observations of these studies shows that we should definitely try to induce at the age appropriate, which is why timely referral is the one which is mandated, and monitor the growth and metabolic profile as well as the psychosocial and the bone health. The Lancet publication regarding the cancer incidence was showing that only the gonadoblastoma and brain cancers were increased and breast cancer was definitely on the lower side when we give a proper timely therapy with monitoring. So reproductive options, because we know people are curious about this, assisted reproduction tools for donor use sites with IVF has been successful, and 2% of Turner syndrome can even have a spontaneous pregnancies. High risk of maternal complications like aortic dissection and rupture can be described, which is the reason why cardiovascular MRI should be done before we mandate this. Another case of missed opportunity had come when the 16-year-old girl came with 138 centimeters with poor height, no sexual characters, and increased carrying angle. And what to do with this child other than just sympathizing with the parents, because we cannot give the proper therapy. Of course, we can give only for the bone health we can give. So initiation of growth hormone is also done ideally early, and when we have an early failure chances, and we can give a near adult height by giving timely Turner syndrome therapy with high dose of growth hormone. So adult care is done by mandating with a team approach and gynecological evaluation, cardiological follow-up, metabolic transition, psychological approach, definitely beyond the scope of this topic, but definitely Turner syndrome child definitely merits a great team effort. This is the chart which gives you a summary of the ovarian hormone replacement therapy in Turner syndrome, and it should be continued up to near the menopausal age as the population standards. Indian scenario, there are several hindrances to this. As I had told you, delayed presentation, the majority don't receive growth hormone in the pre-pubertal age, transdermal estradiol not available, but if it available, cost factor. Even the oral estradiol variant is also costly, and many girls still receive oral OCPs for puberty induction, which is the one not to be used definitely. So when I just check this slide, we can see that so many conditions of delayed puberty are there. Endocrine causes are very much minimal, but when we point out to delayed puberty and short stature, Turner syndrome child is definitely one of the high in the list. So the role of endocrine optimization, metabolic, reproductive, social, and also psychosocial and sexual therapy, sexual optimization is also required, which is the reason why we should reach out to the Turner Syndrome Foundation and other societies to collaborate regarding this. So I also welcome you to the endocrine awareness, which is an initiative by the ESI, and also to my main help from the Dr. Sanjay Kalrat and Dr. Sunetra Mondal. You can always reach out to me on my email and on my Twitter handle. Thank you, the audience, and thank you, team, for this opportunity.
Thank you very much, Dr. Mohan sir, for that very brief and very informative talk from your side. I think we must have most of our doubt must have been cleared by now. I hand over the session to the Hormone India team for further deliberations.
Thank you, sir. Now I would request next chairperson, Dr. Karthik sir, to introduce our next speaker, Dr. Anurag sir.
Thank you, Hormone India team. It's glad to be here, and thank you, Tony, for inviting me. And it's very heartening to see the team that was, that has nurtured this conference was from my alma mater, SGPG, and several of my colleagues are there sitting in the screen and coordinating. Thank you. And without much waste of time, I'd like to invite Anurag Lila sir. He requires no introduction amongst us because he's a highly academic and highly research-oriented person who has several publications. And though the slide is very simplified, he is a very best person to brief regarding the topic. Handing over to you, sir.
Hi, Karthik, am I audible?
Yes, sir. Yes, sir.
How should I share my slide? Is my slide visible?
Not yet, sir.
How can you help me to please share my slide?
Sir, first open your PowerPoint.
Yeah, it's open.
Then click share button, green color icon.
Share button.
So lower middle part of your screen, sir.
Sure. Done. Yeah. Is the slide visible?
Yes.
Yes.
Coming. Thank you. Thank you, Doctor. Yeah. So I'll start this topic which is given: a 7-year-old girl presents with sexual precocity. So at the Department of KEM, we have been working in pediatric endocrine. So I'll talk about our experience, what we have come across in managing such cases. This is a typical case of a girl child coming at 7 years of age with breast budding, the bone age advancement, the uterine size enlargement, the MRI showing a small hematoma. This is a classical case of central precocious puberty because of a small hypothalamic hematoma. But the question comes, should we be treating this 7-year-old child? Because the conventional teaching is below 6 years and above 6 years. So the cutoff of 6 comes there when it comes to height benefit. So I'll be discussing that part. And the second part is it a slowly progressive or actually a progressive precocious puberty which benefits in the terms of height need to be addressed? So these are the two major questions which I would like to address. So what we understand that this has been a well-established and studied science. It goes way back to 1946 when this girl with precocity got pregnant at 5 years, 8 months of age, and it becomes a news for the world. And we can understand when it comes to, so not only the psychology of a child, but the psychology of the parent is more disturbed when it comes to precocity. And the final stature of a child is always compromised by 10 to 15 centimeter, depending on the onset of the puberty and the age at which it starts and how it progresses. Conventionally, from the data, what we understand that the mean age of onset of a breast bud is 11.2 years. If we add minus 2.5 SD, it comes out to be 8.45 years if you go by the exact numbers. But Americans said that it was a British data and our kids have a precocity a little early. So the conventional cutoff of 8 comes from the rounding of the figure from 8.45 to 8 years. So we define precocity at an age onset of thelarche anytime below 8 years of age is taken as the onset of puberty, and this definition has been there for many years now. One thing which is very important that the gonadarchy, that is pubarchy, which is dependent on the adrenarchy and the estrogen exposures are two parallel process, because if there is estrogen in a pre-adrenarch child would not translate into pubarchy, and that distinction should also be kept into mind while clinically examining a patient. Conventionally, that way back when the LH assays were available, people have differentiated it into a central precocious puberty and a gonadotropin independent precocity, where the basal LH would be low, more so during the day, but the distinction will be more during the night time when you do a night levels of LH levels. But more so, they were using conventional assays, and the difference was more stark when it was a GNRS stimulated test, and you can get a clear difference between a central and a peripheral precocity. Again, if you understand the etiology wise, it's there are n number of etiology, and we find it very fascinating to look at the causes, but they have been well established, like hypothyroidism, McCune, the adult tumors and the ovarian tumors, and they were described before 1950s. What is most interesting is the article which comes from the Novak. He was a gynecologist who described that these are constitutional precocious puberty and don't go behind adrenals and ovaries in every cases, because there were no imaging modality in that era, and people were going for adrenal surgeries and ovarian surgeries to look for a cause which could be precocious puberty. Just a pattern to understand how easy the life is today as compared to when it would have been way back and where people were thinking, and it took a lot of time for Novak to explain people that it's mainly constitutional. The second more important differentiation, which becomes a little difficult to understand, these terms called premature thelarche, slowly progressive central precocious puberty, and a progressive kind of a puberty or a central precocious puberty. So these terms are interchangeable, but what we understand that when it happens in the first 4 years of age, we can define it as a premature thelarche, whereas because the first sign is thelarche, So any puberty which starts will have a thelarchy, and you can call it a premature thelarchy at any stage. But when it comes to a normal onset of puberty in an early form, it could have two patterns. It could be slowly progressive or a progressive. Why we have to differentiate the two? Because the treatment will differ in the two categories. So it is very important for us to categorize these two categories. And what we understand from the science way back, if you look at the LH and FSH patterns in the progressive CPP, the LH dominant response would be there as compared to the FSH. If you look at the premature thelarchy, mainly in the kids below 4 years of age, you will get the response is the A and the B, which is a premature thelarchy, which is largely FSH response, whereas you have an equal response in a slowly progressive puberty. It was further defined well because the SC limits, if you see, are going very high. With the new ultra-sensitive assay, this group defined it. A category B is a slowly progressive and a category C is a progressive. And the difference between the two is the level of the LH rise on the leuprolide. Hence, the classical cutoff of 5 was given from this category, from this study which we use on a newer LH assays. So if you have a stimulated LH more than 5 is more in favor of a progressive puberty, whereas otherwise it is still a slowly progressive puberty, which is just driven by FSH and it is not progressed to that stage. What we understand and what we learned as a student was any basal LH more than 0.3 or a peak LH more than 5 or a 24-hour estrogen value more than 184 defines a progressive puberty. Again, in endocrine, we don't have black and white and there would be a gray zone. Other way around to define it, in this large number of patients, this new study, which have 133 patients with a slowly progressive variant, though they call it a premature thelar, and a precocity because the age is 7.3 in both the groups. And if you define with a LH of more than 5 a central precocious puberty, there may be a gray zone in the LH. So as per this study, what we understand now, if LH is less than 0.1, you don't need a stimulation. If LH is more than 1, you don't need a stimulation, but a gray zone of LH is not a cutoff of 0.3. It is between 0.1 to 1. It's a gray zone where a stimulation test will discriminate the two variants, where the variant is defined based on a LH value more than 5. So now coming back to our case, the basal LH was 0.65, basal FSH is 4.12, and post-leuprolide LH is 40. So this is suggestive of a progressive central precocious puberty. And this basal FSH also gives a clue because basal FSH usually in a gonadotropin independent puberty, especially because of ovarian cyst, if there is an autonomous estrogen secretion, will be suppressed. In those cases, FSH and LH both are suppressed. So this is a case of progressive central precocious puberty. The bone age is advanced. We look at a predicted adult height, which is lesser, and the MPH is at the 25th centile in this case. The next question, should a USG be ordered? Again, as an endocrinologist, I look at my endocrine numbers and use other tests as a corroborative evidence. This is one study which I like to look at when it comes for the size of the uterine length, which has been defined as per the stage of the puberty. There is a huge overlap. If you look at as the pubertal stage goes up, the uterine length goes up from 2.9 centimeters to 3.7 to 4.8. And so uterine length is one parameter which is useful on a sonogram. And this meta-analysis also suggests a uterine length of more than 3.2 would suggest a precocious puberty which is progressive as compared to a slowly progressive or a premature thelar category. So USG was done in our patient. It turned out to be the uterine length was 4 centimeters. So it's again corroborative in our case. Should we do an MRI? So if we read many papers, they say that MRI in a girl child beyond 6 years should not be done. Again, it is controversial, but when we apply it to a patient, what we understand, and so this cohort of 770 girls, when they studied the central precocious puberty, what they found below 6 years, the yield is 7%, but above 6 years, the yield is 3.2%. So this number should be there at the background. So sometimes we do a test to rule out a problem. So we don't want to miss any of these problems in our girl child, and we can order a MRI if it is doable and feasible and the child is supportive enough. We will definitely go ahead in that case. So in our case, this MRI was done and they could identify a small hypothalamic hamartoma. So the next question the parents were asking, is there any genetic reason for it and should we go for a genetic test? In this case, we didn't order a genetic test. I'll come back to the reason why. But lately what we have understand is this. Initially, there were some case reports of KIS1R and the KIS1, but there were very few case reports. But what is more interesting is there are many families of MKRN3 where the loss of function leads to the early puberty, and it is a gene which is transmitted with a paternal expression. So father is transmitting the variant to the kids, and you can understand an N number of patients have been described, and it's not uncommon. And it is followed by another loss of function gene called DLK1. So genetics can be done, but in our case, since we had an MRI abnormality, in these cases, genetics are not required. As suggested by this, if we think there is a central precocious puberty, as in a sporadic case, an MRI brain does not show a lesion, you can go for genetic testing. So in our case, genetic testing was not required, but yes, this test can be done and you can get a MKRN3 variant in a cohort of early puberty in a patient like ours. So the most important questions, why should we diagnose and how should we help them? Will a GnRH agonist treatment help in the final height of this girl child? She's already 7 years of age when they have presented to you. So the conventional teaching again says a cutoff of 6. Below 6 years, if you start, there's a benefit in the height, and above 6 years, there's no height benefit. And plus, we should understand if there is a diagnosis of premature thelarchy or a slowly progressive puberty, there is no benefit in the height. So we're not questioning that. In a case like ours, where there is a progressive CPP, whether beyond 6 years of age, will there be any benefit in the height is a question we are trying to understand. Though we understand the treatment is very simple and it's not very costly these days, so it can be easily done. So feasible, but should it be done is a question. If we go back to the previous study of 1994, which gives a cutoff of 6 years, if we understand the kids who were treated below 6 years of age, there was definite improvement in the height outcomes as compared to the controls. But beyond 6 years, there was no benefit with the GnRH analog treatment in their cohort. But what we understand that the cohort which was below 6 years was actually below 5 years of age, and the cohort which was above 6 years was actually about 8 years of age. So what happens to the kids between 5 to 8 years of age is not, just to make the matter simple, the 6-year cutoff was floated after the study. But you look into the numbers, exactly what happens to the kids who comes between 5 to 8 years of age. And most of our kids with precocity will come at this juncture. So should we be treating them or not treating them is a question. This is a very elegant paper from French group from Raja Bronner, who have suggested that the more is the bone age, more advanced is the bone age, more benefit you will get with the GnRH analog, which is contradictory to the conventional layman thinking what we may have in this thing. And the same results were extrapolated in this large study group, where the kids have come at 6 years of age, 7 years of age, 8 years of age. Treatment for the kids who have come after 8 years of age, there was no benefit whether you treat them or you don't treat them. There's definite benefit for the kids who comes below 6 years of age, and the final height SDS is more than the target height SDS in that case, and that is equally surprising because they'll not lose height, they'll gain some height after your treatment, and much more than the target height even. Between the cohort of 6.4 to 8.3 years, what was understood, all these cases were treated. The treatment benefit was maximum to the cohort which had a more advanced bone age as against the less advanced bone age. So between this age group, The gray zone, there is a more the bone age is advanced, the treatment outcome will have a better height outcome if you have a more but advanced bone age. So in our case, the bone age was for a 7-year-old kid, it was 10 years of age. She was started on a GnRH agonist treatment with a leuprolide 3-monthly depot. You can start with 11.25 or 22.5 depending on the weight of the kid, or escalate it later. And what you can see on the follow-up, what you can understand is the child is growing, the centiles, the bone age advancement is halted, and what we can predict, initial predicted height was much less, and what we can predict is the current predicted height is much better than the initial predicted height. So definitely we think overall we'll be able to give a benefit of 5 to 7 centimeters to this child by treating her in time for her precocity. To summarize, so what I would say, puberty in a girl child at below 8 years of age, as seen by THELAR, need a detailed clinical evaluation, and there must be some etiology, but most probably it is an early activation of the HPG axis, which is constitutional in a girl child. Once we have understood there is a THELAR, there is an activation, we should be able to differentiate a slowly progressive variant from a progressive variant. And what helps is a basal LH and a simple leuprolide stimulation test with 20 microgram per kg, and doing a test after 1 hour if you're doing only LH, or if you're taking LH and FSH at 3 hours, you can do a one single sample. Basal FSH also helps to rule out peripheral causes. If it is suppressed, it can be a simple ovarian cyst. We can go ahead with the MRI brain, and in case MRI brain is negative, genetics can be ordered. In a case of CPP, sonogram, look at the uterine length and use it as an adjuvant investigations. For an endocrinologist, I always suggest look at the endocrine numbers for the diagnosis, and other investigation are adjuvant. GnRH treatment analog, yes. The younger the age, more the bone age advancement, lesser the predicted adult height, better will be the final height outcome, and the final height outcome would be better than even the target height. But in an age group of 6 to 8 years of age, those who have a higher bone age advancement should be offered treatment. But when it comes to psychology, psychological support for the parents or the kids, then there is no questions, and you can start the treatment based on that. But all these things should be understood before dispensing GnRH analogs. Though they are very safe, rarely we have encountered allergic reactions at times. Long-term outcomes are also safe in that regard, though some concerns about obesity and other things. So we should be counseling them for managing weight. Concerns about bone health, so they should be on adequate calcium and vitamin D. Post GnRH analog, when you do a depot, post depot LH can also be used to guide us about the adequate suppression in these cases. We tend to stop our treatment at a bone age of 12 to 12.5, because continuing beyond that bone age will not have advantage in the final height, and they can have a normal puberty later on, normal fertility with a long-term data, which is quite safe. I thank the organizers for inviting me for this talk, and I would say thank you, and thank you for the patience listening. Thank you.
Thank you, sir. So Dr. Others will be taking the next session. Yes, Dr. Others, please go ahead.
Yeah, let me introduce Dr.
Hi, good evening, everyone.
Yeah, Dr. Adarsh has done his MD Endo from SGPGI, and he is presently working as a consultant at Manipal Hospital and handling the Hormone India Bengaluru Center. Over to you, Dr. Adarsh.
Thank you, Mayur. I welcome all on the 5th session, day 1 of the 3-day Hormone India conference. So next session will be on disorders of sex differentiation and gender. We have 3 speakers and 3 chairmen. chairpersons who will be chairing the session. I would welcome and introduce Dr. Vishnu Vasudevan, who will be chairing the first session. He's a consultant endocrinologist in Kerala. I would request Dr. Vishnu Vasudevan to kindly take over the session by introducing the first speaker.
So thank you, Dr. Adarsh. Good evening, all. It was a wonderful event, and I thank the Hormone India team for inviting me for this grand conference. And I congratulate the team for organizing such a great conference. I'm happy to see many familiar faces. Dr. Siddharth is my junior, and many of them are my colleagues and juniors, and many seniors also, definitely. It's my pleasure to introduce Dr. Lokesh Sharma. He's a pediatric endocrinologist. He's consultant at Medanta, Lucknow. He has published international national papers. He has co-authored book chapters, and he has represented India in the APPA's Fellow School 2019 Manila. Over to Dr. Lokesh Sharma for his first talk on approach to ambiguous genitalia.
Thank you, Dr. Vishnu. I'll just start my screen. Is it visible?
Yes, it's visible.
Oh, okay. Thank you, Dr. Vishnu, for the kind introduction, and thank you, Team Hormone India, for inviting me. I'll speak in next 20 minutes. It's a very huge topic to describe in next 20 minutes, though I will try to do justice to this topic. So, approach to ambiguous genitalia. Ambiguous genitalia is a thing which is not uncommon in our endocrine clinics. So, coming to the terminology, intersex was the term which was being used till 2006 for the persons with atypical development of the chromosomal, gonadal, or anatomic sex. Since 2006 onwards, when a landmark publication came defining the intersex, and they had used the term disorders of the sex development. So since then, this is the most prevalent term, disorders of the sex development, because this was more scientific, and that group reclassified this entity. And that classification was based on the underlying etiology. It was not random as it was earlier. So that was more useful. And in now, like 4 or 5 years, I will say, differences of the sex development is more commonly used. Though still most common term is disorders of the sex development. But in recent papers and textbooks, they have started using, because it is less stigmatizing for the patients, and patient support groups accept that more comfortably. So differences of the sex development will be the prevalent term in coming years, I think. And the prevalence of this issue is that it is around 1:4 to 5,000 overall, but this data is Western data. In India, we do not have any formal registry to say that, but possibly it will be higher than that, because probably more consanguinity will result in most of these diseases. So we'll see in next slides. So DSD, when we call a child, he is a child of disordered sex development. When there is overt genital ambiguity, anytime when we are not able to define whether the child is a male or female at the time of birth, we will call it a DSD generally. But what are the objective criteria? When overt genital ambiguity is there in any form, like cloacal exostrophy even, we may put in DSD. Apparent female genitalia with the signs of virilization, like enlarged clitoris or posterior labral fusion is there, or in later childhood, if there is an inguinal mass, then we can say it as DSD. Apparent male genitalia with signs of undervirilization, like microphallus or hypospadias, or both of them together, or associated with the undescended testis. That condition can be called DSD. A family history of DSD, like complete endogenous insensitivity syndrome, when child has, then we should look for that. Child should not have this condition, and he may be classified as DSD without any ambiguity even. And a discordance between the genital appearance and parental karyotype, if it was done, then that will be classified under DSD. So these are the objective criteria we should use to classify a child as DSD. So what are the causes of DSD? Dimorphic gonadal development is primarily decided by the sex chromosomes, and with these sex chromosomes, several autosomal genes are also identified
to play part in this gonadal development. And after when gonads have been developed in embryo, right hormone at the right time with functioning receptor will give rise to normal internal and external genitalia, and that will result in a dimorphic sex, normal dimorphic sex. And any deviation from this issue, from this cascade, from sex chromosome to genes to right hormones, will result in the DSD. So coming briefly to these issues which we talked in last slide, gonadal development. Gonads are developed from the urogenital leaves. Around up to 7 or 8 week of embryo, it remains like a bipotential gonad, which may be converted to any of ovary or testes. So from a cascade of events, some genes are responsible, which will decide whether this gonad will turn into ovary or testes. So SRY SOX9 combination is the factor which will decide whether this gonad goes to the testis pathway. And RSP or WNT FOXL2 are the genes which are the main deciding factors which will lead this pathway towards ovary side. And it is not like that earlier we used to being taught that if a child does not become a male, he by default becomes a female. But it is not like that. It is now being proved that these are really repressive pathways. When SRY and SOX9 get activated, they will repress the RSP-WNT pathway, which is the main deciding factor for the ovarian pathway. And when FOXL2 and RSP-WNT pathway get activated, it will suppress the SRY-SOX9 pathway. So they are mutually exclusive pathways. Once this goes into this pathway, this will repress another pathway and a normal ovary develops. And any issue in this pathway will result in the DSD at gonadal level. So DSD at gonadal level, how it may present? Either absence of gonadal development, so it will result in the complete gonadal dysgenesis. It may be partial gonadal development, that will result in the partial gonadal dysgenesis. It may be total reversal, like XX testicular DSD, when Y component, mainly SRY and SOX9, are incorporated in the X chromosome. It will result in the XX testicular DSD. Or there may be components of both the gonads, novel component of both the gonads in a single gonad, then it will present as a ovotestis. Coming to the external genitalia, after gonads, when one gonad is formed, it will start secreting hormones, which will be responsible for the further development of the dimorphic sex, and it will result into the virilization in males and non-virilization in the females. Along with AMH hormone, will result in the normal external genitalia. So 3 important terms I will utter: genital tubercle. This is genital tubercle of the bipotential external genitalia. So when it is virilized, it gets good exposure of testosterone and DST later on. It will go to it will increase in size and it will become glans penis in a male child. And second thing, urethral fold. Urethral fold, this part, pink part I will say, when it gets good androgenization, it will become shaft of the penis with the penile urethra. And when it is not virilized, there is no androgen, then it will become the labia minora of a female child. And labioscrotal swellings are these blue things. When this is virilized, it will become scrotum of the future child. And when not virilized, when there is no fusion of the labioscrotal folds, they will become the labia majora of a female child. So these all events occurs between 8 to 14 weeks of age. So before 8 weeks, this is a single bipotential external genitalia, and after that, within next 5 to 6 weeks, it happens that virilization happens, and either child will become a male external genitalia child or a female external genitalia child. So this is called masculinization programming window. And when gonadal development is disturbed before this event, then that will lead to genital ambiguity because of gonadal dysgenesis. And if gonads issue with the testis happens after this event, after 14 weeks of embryonal age, then that will be called testicular vacancy syndrome. There will not be any testes, but there will not be any ambiguity even. So testosterone and the dihydrotestosterone are the main factors which will decide the anatomy of the external genitalia. So this is what they do. Testosterone is mainly responsible for the development of the internal genitalia and descent of the testes from the inguinal part to the scrotum. What are the internal genitalia part in the male? That is epididymis, vas deferens, ejaculatory duct, and seminal vesicle. While DST is mainly responsible for fusion of the labioscrotal folds, development of the penis and prostate. So this is how it happens. When 5-alpha adductor deficiency is there, DST deficiency will mainly affect external genitalia in these parts. And when androgen biosynthetic defects is there, then it will affect both the parts, because if there is no androgen, there will not be any DST also. So coming to the classification, this was given in 2006, but this is still prevalent. This is the most scientific classification and is being used widely as of now. We can divide in 3 parts: sex chromosome DSD, 46XY DSD, and 46XX DSD. Sex chromosome DSD, when karyotype is not XX or XY, it is different from that. Either addition of any sex chromosome or deletion of any sex chromosome from this karyotype. That will result in the sex chromosome DSD. Most common of them is mixed genital dysgenesis, and most common karyotype which is associated with this entity is 46X or 46XY. Others are also there which are not that much common. Otosexual DSD karyotype, most common karyotype is for otosexual DSD is 46XX. Coming to the 46XY DSD, again, as we had talked, disorders of the gonadal development may lead to this, and that we had talked already, and disorders of the androgen synthesis, that may be CAH component or without CAH also. Defects of the androgen action, that is androgen insensitivity syndromes, luteinizing hormone defects, or disorders of the anti-Mullerian hormone and anti-Mullerian hormone receptor, which will result in the persistent Mullerian duct syndrome, not actually ambiguity. Coming to the 46XX DSD, it may be possible due to gonadal development. It will result into the dysgenesis or XX testicular DSD or androgen excess due to any cause. Likely causes are CAH. That is CAH is the most common cause of DSD overall, and 21-hydroxylase deficiency makes 90% of CAH patients, affected with DSD people. So that is the most common cause overall. After that, fetal-placental aromatase deficiency or maternal luteoma, that will cause virilization during only pregnancy. It does not progress after birth. And overt genital ambiguity may occur due to structural defects, not due to hormonal causes or genes which decides gonadal development. So coming to some numbers to give us a perspective what we are dealing with. CAH is the most common cause overall for DSD. For DSD, it is like in females, it is more common than males, because males with 21-hydroxylase deficiency does not have DSD. Worldwide incidence of 46XY DSD in CAH, this is around 1:15,000. But in India, it is much more common. Gonadal dysgenesis, like mixed gonadal dysgenesis and androgen insensitivity syndromes, they are the common causes. They come after CAH. And CAH and mixed gonadal dysgenesis constitute more than 50% of the all DSDs overall. Coming to the numbers from India, these are the studies I could found in recent last 2 decades from India, which have described DSDs. So most common overall cause, CAH in most studies, except one study which had shown 5-alpha adductor deficiency. Most common in female XX DSD, CAH, no doubt regarding that. Most common cause for X5, as in global literature also, it differs from some percentage. But as a group, androgen insensitivity syndromes, 5-alpha adductase deficiency, and dysgenesis are the most common group, which give rise to XY DSD. We will, my following speaker will talk in detail about that. So how do we go for evaluation of ambiguous genitalia? Aims of the evaluation: first, prevent short wasting crisis. That is the most important aim, because that is the medical emergency. After that, to provide a diagnosis and to address gender assignment, because a DSD child may not be a medical emergency in most of the cases, but it is a social emergency for a family dealing with. And to provide guide for future management plan, that may be surgery, that may be hormone replacement, that may be fertility prospects, and that may be risk of tumors. And how do we do that? By history, examination, hormonal, genetic, and radiological evaluation. To do that, we will require a multidisciplinary team that will include a pediatric endocrinologist or endocrinologist who will be in the center of this team, with urologist, psychologist, geneticist, radiologist, neonatologist, and a social worker will make this multidisciplinary team. So coming to the clues from history. If there is any history of consanguinity, then we should think of disorders which are inheritable, like CH is most common out of them, and pyruvate deficiency as are other issues. Unexplained infant death, especially to rule out salt-wasting crisis, that CH in previous children may be misdiagnosed and children died without any treatment. Family history of infertility and gynecomastia, that may come in milder form of any DSDs. Family history of either amenorrheic aunts or partially village uncles. That is very important because sometimes they say no, there is no one is affected. Then we'll ask them, there is infertile females, unmarried females. They will tell yes. Then we should ask and to examine them because they may be XY undervillaged males also. The relation during pregnancy, that will give clue for placental and aromatic deficiency. Early renal failure, gonadal dysgenesis we should think of, and progesterone treatment. Prolonged progesterone treatment during pregnancy may give rise to antenatal virilization. So coming to clinical examination, description of the genitalia, it is very important initially to document medico-legally also and to plan or treatment in future also. So first thing to palpate gonads. Where are the gonads? Whether they are there, if they are there, where they are. So both sides of gonads should be palpated and documented. Then location of the urethral opening, where it is at the tip of the phallus or under surface of the phallus, or whether they are single opening or two openings. Size of the phallus, this will decide the future surgery plans, and it plays a role in the gender of rearing also. Degree of the labioscrotal fusion and anogenital index. Anogenital index, what it is? It is a proportion of the ratio, proportion of the distance between anus and posterior forecheek and anus and clitoris, base of the phallus in males. So it is around 0.5 in the females and 1 in the males. As a girl child who is virilized goes from 0.5 towards 1, it shows the extent of the virilization happened during embryo phase. So it is a good indicator how much virilization occurred during fetal phase. So signs of insufficiency also during examination we should see for hyperpigmentation. In children we see at genitalia, nipples, umbilicus and mucosa. Poor weight gain, shock and hypoglycemia are other features which may child present in. These are the other clinical parameters to look for virilization or undervirilization in a male or female child. External muscularization score is used in the apparently XY children who are undervirilized. It has 4 criteria. Scrotal fusion and micropenis has either 0 or 3 scores. Opening of the urethral meatus depending on the what degree of hypospadia is there has 0, 1, 2 and 3 scores, and descent of the gonads will give score of 1.5 for each gonad, will convert into the 12 total score of 12. So any child who has score of less than 10 will be undervirilized. Similarly for apparently XX females, to assess objective virilization, we will see Prader staging. So earlier there will be only clitoromegaly, then there will be posterior fusion. In stage 3 there will be posterior fusion, so there will be only 1 opening, not 2 opening on the perineum. And stage 5 will be like a male, normal male. So coming to approach now, when a newborn comes with a genital ambiguity, then first we'll palpate gonads. Ideally speaking, there should be fish available in the center who are dealing with the DST. But still in most of the centers in India, we do not have fish facility which can give results in the hours, whether there is Y component or not. So we will take a proxy of palpable gonads for that. If there are bilateral palpable gonads, then it is more or less we are dealing with the child who has XY-DHD with palpable gonads, or rarely when formal karyotypes comes, if it comes XX, then we will think that he may have XX testicular DHD also. If child does not have bilaterally palpable gonads, so we will see whether he has unilateral palpable gonads and unilateral non-palpable gonads. Then it is possibly a chromosomal DHD, because mixed gonadal genesis is the most frequent presentation like this. If it is not, there are no palpable gonads, child may be either virilized XX DHD or undervirilized XY DHD, both conditions. Then our priority will be to rule out CAH first. So we'll do 17-hydroxyprogesterone, ACTH, cortisol, along with USG Mullerian structures, USG4 Mullerian structures and gonads, whether we can see on the ultrasound. And if 17-hydroxyprogesterone is significantly raised, that cutoff is more than 10,000 nanogram per DL, then it is a classic CAH we are dealing with. We will start management according to that. That is a medical emergency. And if it is modestly raised, it is raised but not up to that cutoff, then probably we are dealing with other less common type of CAH. And we should ask for a BP, because 11-beta hydroxylase and 7-alpha hydroxylase deficiencies are other less common type of CAH which may present like with ambiguity. They have high BP. So that may give a clue. Then if there is normal 17-hydroxyprogesterone, ACTH and cortisol, then it is very unlikely that we are dealing with CAH. So either it is a 46XX DHD, virilized XX DHD, or it is 46XY DHD without palpable gonads. So coming to first 46XX DHD, practically speaking, when they are dealing with a child with 46XX DHD, in most cases we are able to reach to a diagnosis, because around 90% of the children will have CAH, and others will have some entities which are very well defined generally. So they may have aromatase deficiency, P450 oxidoreductase deficiency, maternal luteoma, that we will take from history and examination of the mother, exogenous use of medroxyprogesterone acetate. This is a common drug is being used for threatened abortions, and child may have virilization due to that. It will not be progressive after child is born. And anatomical defects like cloacal exostrophy may present like DHD. So these are the clues. If there is history of maternal virilization, aromatase deficiency or luteoma suspected, if there is history of progesterone injections, then for threatened abortions, we know that it is possible due to that a child virilized due to these injections. If there are bony defects like craniosynostosis, long bone defects, and synostosis of the radio-ulnar bones, then it is anti-Dexa syndrome, and it gives clue for P450 oxidoreductive deficiency. If there is low E2, high FSH, and polycystic ovaries, then probably we are dealing with aromatase deficiency. Coming to 46XY DHD, I will just rush through that. Then there is detailed talk about this topic in next session. So this session, 46XY DHD with or without palpable gonads, conditions are either it is testosterone biosynthetic defects, it may be CAH, that is 17-alpha hydroxylase deficiency, 3-beta hydroxylase deficiency, P450 oxidoreductive deficiency, P450 SCC, and STAR deficiency, or non-CAH conditions like 17-beta hydroxylase 3 deficiency and 5-alpha hydroxylase deficiency, or androgen action defect, AIS spectrum, LH receptor defect, AMH or AMH receptor defect, or gonadal dysgenesis. So some clues to these diagnoses: we will do hormonal workup, that is LH-FSH, testo dihydrotestosterone, and testo-androstenedione ratio. That has to be done either in mini puberty, that is around 2 weeks to 3 or 4 months of life, or during puberty, or in between. If you want to do, then we should do HCG stimulated test. It does not have any value after mini puberty without stimulation. So we will have to do HCG stimulation test for that. And along with that, AMH and USG pelvis for intense genitalia will give clue towards diagnosis. So if testosterone is normal or supranormal, then 2 diagnoses will be there. Either it is 5-alpha hydroxylase deficiency or a androgen insensitivity syndrome. So for that, we can do a testosterone DHT ratio and sequencing for the gene of 5-alpha hydroxylase. If it is low testosterone with normal AMH, then and there are no Mullerian structures on the ultrasound, then probably we are dealing with biosynthetic defects of the testosterone. There is low testosterone with high LH, then probably we are dealing with the LH receptor defect. Low testosterone, low AMH, and if there is Mullerian structures, it is very likely that we are dealing with gonadal dysgenesis. So laparoscopy and biopsy of the gonads will give the diagnosis. This analysis is the diagnosis of histopathological examination, not a clinical diagnosis. You can suspect from the scenario with the evaluation, but it is a diagnosis of histopathology. Coming to the role of genetic tools for diagnosis, FISH or quantitative fluorescent PCR should be available. If not, formal karyotype. Then, if it is abnormal karyotype, it is chromosomal DSD, like 46XY mosaic.
Excuse me, Logesh sir.
Yes.
Sir, we have maximum 1 minute left for that speak.
Okay. Actually, I am not able to see clock here.
Okay.
Okay. So it is chromosomal DSD. If it is not, if we have normal karyotype of 46XY or XX, then we should go for CGH array, specifically if we have other defects. If it is also, if it shows something, well and good. If it does not, then we should go for targeted gene or gene panel sequencing or exome sequencing, depending on our facility. So these are classical presentations of mixed gonad dysgenesis. It will be asymmetric gonads. One side gonad is there, one side is not. And this is CAH, highly pigmented child which is not growing with genital ambiguity. This is a case of CAH. Late presentation of DSD, these are also possible when child comes late, either recognized late or when a female child has inguinal hernia or has delayed or incomplete progression of puberty, realization in a female, breast development in a male, primary amenorrhea, or occasionally cyclical hematuria gives a clue in a male that he may have DSD. Gender assignment is very important. So factors which decides are degree of masculinization and size of phallus, like surgical expertise, risk of tumor, and need of hormone replacement in the future will decide whether which gender should be assigned. So take-home message from this will be ambiguous genitalia is not uncommon in our clinics. Medical emergency should be taken care of first. Social emergencies will come next, and held on, like it is like we becomes a guardian for a patient when we have once dealt with the patient. They will need lifelong care for their evaluation, gender assignment, surgery, hormone replacement, and management of the fertility and risk of tumors in future. And medical aspects are very important in these cases, should be taken care of very well. Thank you.
So thank Lokesh sir for his excellent talk. It's a very difficult topic and a very vast topic, as he already mentioned. And he has definitely done justice to the topic. I declare the session closed and hand it over to the next chairperson, that is Dr. Siddharth. Thank you.
All right. So first of all, thank you Team Hormone India for inviting me to chair this session. And a very good evening to all my colleagues, members of Brethren, and all my seniors, Vishnu sir. So diagnosing DSD has always sort of bamboozled the clinician, physician, and endocrinologist alike for centuries now. And we have come a long way from the time when Free-Martin calf, pathophysiology of Free-Martin calf used to puzzle us. How far we have come. To shed more light on this, we have Dr. Praveen sir with us. Praveen sir's name needs no introduction. He's a clinical professor, Department of Endocrinology at Amrita Institute of Medical Science. And he has multiple publications to his name, including the recent publication on the genetic variants on the aromatase enzymes. Without wasting further time, I would like to invite Dr. Praveen sir for his presentation. Over to you, sir.
Good evening, everyone. Hope I am audible.
Yes.
Yeah.
I would like to share my slides. Is it visible?
Yes.
Yeah, I hope I am audible too. So I would like to begin by thanking Dr. Tony, Dr. Mayur, and other members of the Hormone India for this opportunity. And thanks to Dr. Siddharth for the kind words of introduction. And I must also thank Dr. Logesh for simplifying my task by at least 50%. So I'll be skipping at least 20% of my slides because of his wonderful session. So I'm supposed to sort of discuss the diagnostic challenges in 46XY DSD, and we will do it in a structured fashion. And I will try to do some case scenarios, 4 to 5 time permits. So this is something Dr. Logesh already alluded to, the steps of sex differentiation. And I wouldn't want to repeat the whole thing. The only thing to remember is that there are these non-gonadal transcription factors, which often escape our attention and which have a huge role to play in the development of mostly external genitalia and some minor role in the development of internal, which some people would try to classify as malformative DST. Timelines, factors involved, again, I wouldn't want to go into the details. All of us are aware of the importance of the 13 weeks, male sex differentiation, paracrine effects of the gonadal peptides, the various factors involved in the testicular descent, etc., etc. And so the question comes, what goes wrong in 46XY DST? So basically, if you look from far, the factory looks good, the karyotype looks good, X, Y, everything is in place. But if we go closer, we find that things are not that right because of the various steps involved. Some of the transcription factors in the post-SRY or even SRY may be defective. So then you have disorders of gonadal testis development. It may be just a functional defect. So it may be just an enzyme being knocked off or receptor DSD. As you all know, 46XY over testicular DST is a distinctly rare entity. And then you have the other so-called miscellaneous group. Many of them are malformative DST. And of course, there are others, distinct ones like cryptorchidism to grade defect, INSL3 defect, etc., etc. So let's move a bit closer and have a good view of what goes wrong. So these are the steps, overview of the steps. There may be problems with development. There may be problems with the classical pathway of testosterone synthesis. We should not forget the importance of these have been described, but this is something which should keep in mind. And then there are this androgen action, gonadal peptides problems, and malformity defects. So let's look at them one by one. So this is about developmental issues, and we already heard Dr. Logesh talking about it. And I wouldn't dare to go into all the transcription factor descriptions. We all know about the importance of SRY, SOX9. There are other SOXs as well, RSPO1, WNT4, WT1, etc., etc. Then we have this classical pathway defect, and it's important to remember the starting points, which sometimes we forget. Starts off from 17-dehydrocholesterol, and at the receptor point of view, it starts off from the LH. So we can have LH receptor defects presenting with GST, which all of us are aware of. And then we have the delta-5 pathways, metabolites, delta-4 pathway metabolites, ending with pi-alpha reductase and androgen receptor. So this is the classical pathway. And of course, there is an overlap with adrenal steroid synthesis. So many of these defects are associated with adrenal insufficiency. Non-classical or the backdoor pathway. So most of it is about direct synthesis of DHT from 17-hydroxyprogesterone without the intermediate testosterone step. So 17-hydroxyprogesterone by the action of various aldoketo reductases or 3-alpha reductases, the other name for that, leads to production of dihydrotestosterone. So this is important in fetal life. So how do patients with 46XY present? So most part, the presentation is very simple. It's undervirilized male with fully descended or partly descended gonads, and if there is a adrenal synthetic pathway involved, there might be adrenal insufficiency as well. Or it might be a severe degree of undervirilization, female appearance with an inguinal mass, peripubertal virilization, delayed puberty, apparent female child presenting with gonadal tumor. These are some of the very important presentations, but it can be still subtler, like isolated hyposphedias, cloacal or complex anomalies, persistent Mullerian duct, or it may be a part of a syndrome, as we saw earlier, which do not have a direct connection with testicular development. Ascock syndrome would be a classical example when you can have genital abnormalities without much of gonadal defects. So let's go into some case scenarios now. Before that, so it's important to take a good history and do a good physical examination. And of course, there might be clues from history, for example, premature ovarian failure, female infertility, which may pertain to SF1 mutations or even partial androgen insensitivity. Hypertension may be important for some of the CAHs, and hypokalemia and hyperkalemia are associated with various CAH defects. And urine protein, creatinine, etc. are important in conditions like WT1 mutations. We already had this detailed description of scoring of external genitalia, so I'll skip that. So just before we delve into the case scenarios, let's just have a broad perspective of what we are going to do. So one of the first steps is, of course, to rule out adrenal insufficiency. Patients who have adrenal insufficiency may not have the classical pigmentation and other manifestations, especially with conditions like sandrine alpha hydroxylase deficiency. So basically, if you want to simplify things, we can have this broad sort of 5 groups. There are these conditions with gonadal dysgenesis, in which testosterone and or precursors may be low and FSH may be elevated. But it's important to realize that when the defect is very severe, because of the severe testosterone deficiency, the LH and FSH may not be very much elevated, just like what is described in complete androgen insensitivity. So that might occur. LH receptor mutations usually associated with higher LH than can start from right at the start of the pathway to down to the synthesis of testosterone, 17-beta-HST3, where you have abnormal testosterone androstenedione ratios, and androgen insensitivity syndrome, and this 5-alpha reductase. And I think all of us are now aware of the fact that the ratios are not very much reliable. Still, a ratio testosterone by DHT more than 10 is something just been found very useful. But the final word is with genetic testing. All right, so this is a crowded slide. I've been a bit lazy. So just to focus on multiple cases with the same diagnosis. So you have this child, or you have this baby with micropenis, subcoronal hypospadias, XY-DST, very low testosterone. FSH is not sky high or not very impressive. It's just around 5. Normal cortisol response, low AMH. And of course, we thought of the possibility of, because of the low AMH and inhibin was not available in this child, AMH was low. We thought of the possibility of some sort of a dysgenetic syndrome, and the baby was proven to have SF1 mutation. Another female-looking child presenting peripubertal virilization, at least 2 to 3 of patients presented in the last 2 years. Same syndromic diagnosis, SF1 mutation. None of them had adrenal insufficiency. So this is something which is coming up in a big way, and it's very common these days, once we think about it, we know that it's all around us. A lot of so I think the equations are changing now. We used to think that partial and so various steps of adrenal and gonadal development, adrenal in development, and myriad of manifestations: complete gonadal dysgenesis, partial gonadal dysgenesis, primary ovarian insufficiency as part of the manifestations of S1 mutation. This is another baby who presented as a neonate with respiratory distress for guessing the diagnosis. So this is a WT1 mutation. The urine protein was positive. So depending on the time of presentation and the coexisting tumors. So I wouldn't want to spend a lot of time. So prominent ones being GATA defects, cardiac defects, MAP kinase defects, etc., etc. So this is another case scenario, just to put things into clinical perspective. Apparent thing. So what would be the differentials for the situation? So obviously this is going to have a lot of differentials. So we can think of a mirage or image syndromes. So in this patient, the 17-hydroxyprednisolone was sky high. So the diagnosis: undervirilized male, underwent multiple operations and survived these operations. Small testes, very low, progesterone was elevated. So this is classical 17-alpha hydroxylase deficiency. He had survived at least 2 surgeries under general anesthesia without any problems, probably because of this mineral coach. Had presented with cryptorchidism, normal male-looking genitalia, and trouble started when people did an ultrasound and they detected something similar to uterus, and then all hell broke loose. And the laparoscopy detected deep inguinal ring, gonads, fallopian tube and right. Yes, it's a type 2 PMDS. Presenting with retained Mullerian things other than karyotype, fission QT, PCR. Nowadays, it's very important to have a group on the genetics and sequencing and panels. The problem with these tests is that the copy number variants are missed by times. We require the assistance from SNPs or CGH arrays to make the diagnosis. So I think that's the end of the talk. I don't have many great take-home points for this patient hearing of this session.
Thank you, sir, for this fantastic case-based presentation of these complex syndromes. And as you said, we definitely enjoyed all the cases. For next session, I would like to invite next chairperson, Dr. Sanjeev Jaiswal. He's a consultant endocrinologist at Care Hospital, Raipur.
Dr. Sanjeev, are you there?
Sanjeev?
Yes.
Hello.
Yeah, please introduce.
So we all know that gender assignment is a difficult task in many times when we have some patient of DSD, they have severe gender dysphoria. So managing such patient is very difficult quite some time. So, and it is, ma'am is a senior endocrinologist practicing at Bangalore. She has done her DM endocrinology from SGPGI, Lucknow. And she has a professional interest in thyroid disorders, gender dysphoria, and she has many national and international publications in stone journals. So I'd like to call upon Dr. Pramila Kala, ma'am, to.
Good evening, everyone. At the outset, I would like to thank Dr. Mayur for inviting me for this talk. The topic of my talk is demystifying gender concepts. So I'll be talking about the basics of the gender concepts and a little bit about the treatment of gender incongruence. Now, when we talk about Indian society, most of our people are actually aware of 2 genders. That is, one is male and one is female. We know that our country has recognized a 3rd gender, that is the transgender, but still it's the female gender. Now, though we say that our country, the people are still not aware, but if you see our society or our culture, The non-binary gender expression, people have played important roles for many more years before it has gone to the Western societies. So we know that there are a lot of concepts and a lot of terminologies which are being used. One terminology which is very common is like hijra. Now we know that hijras, they normally were supposed to perform the ritual roles. They were supposed to give blessings and to the newborn. But actually these hijras are either the male who were castrated, or there were few who were born with intersex variations and they were added into their community. They are known with different names in different societies or in different states of India. If you see, like, some of the transgender communities prefer to call themselves kinnaras, they are a symbol of beauty. Some of them would like to call them hijras. So we have different terminologies which are being used in different states. But when we come to the scientific part of it, we need to understand that this is the gender unicorn. So we have one concept of gender identity, where the person identifies as female or woman or a girl or a male or a man or a boy or the other gender. Then there is a gender expression. That means how that person expresses himself or herself. That is a feminine gender or a masculine gender or others. Then there is another thing which is a sex assigned at birth, whether the child is assigned as a female sex or a male sex or any other or the intersex. Then there is one more concept, that to whom the person is physically attracted to, whether they are attracted to women, whether they are attracted to men, or whether they are attracted to the other gender. Then there is also a concept of to whom they are emotionally attracted to, whether to women or to men or to other genders or to both. So a lot of science has been studied about it, or a lot of concepts are now clear about it. And that is why the International Endocrine Society has the guidelines for gender incongruent persons, and we have the typical guidelines about how to go about it. Now, if you see just the basic terminologies, so let us first have a basic concept of the terminologies. One is the biological sex, or the biological male or the female. Now, what it refers to, these basically means like physical aspects of maleness and femaleness. Like if person is XY chromosome may have female appearing genitalia. So this may not be in line with each other. Or the term biological sex and biological male or female are imprecise, and that's why we have to avoid. So sometimes we say biological male. Biological male means if suppose somebody has XY, but they may have a female appearing genitalia. So there is confusion in that term. So that's why these type of terminologies are not to be used. When we say cisgender, this doesn't mean that patient is transgender. This means that patient is not transgender. This means a normal person. Means those who are non-transgender. That is what is called a cisgender. Then we have another terminology, which is the gender dysphoria, which we say that this is a distress which is experienced if the gender identity and the designated gender are non-congruent. So this is what we call as a gender dysphoria. Now we know that now we also have the term of gender incongruence, which I'll be talking about. Now, gender expression is another terminology, and this refers to the external manifestation of gender, like what is the name of the person, pronouns, what we are using, he or she, or clothing, how they are wearing, what haircut they are keeping, how's the behavior, voice, or body characteristics, how their mannerisms are. And most of the times you will see that the transgender people will try to align this with their gender identity rather than with their designated gender at birth. So if there's a transgender female, she will try to behave like a female. If it's a transgender male, he'll try to behave like a male. So that is how is the gender expression. So what is gender identity? Identity is an individual's felt sense of their identity, being a masculine or a feminine or a combination of none of these. Expression is how an individual behaves or interacts with others, dresses, or displays their gender identity to others. Gender norms. Now, there are some gender norms by the society. How an individual will behave and express their gender. Like both male and female are supposed to behave in some particular way in the society. So if they are born as female, they are supposed to stereotypically behave like a feminine way. Born as a male is supposed to behave like in a masculine way. So these are the gender norms which are decided by the society. There's another very important terminology, which is gender fluid or non-binary. This describes individuals who neither identify themselves as male or female. Because a lot of clients will come to us and they'll say, I am non-binary or I am gender fluid. So this means they fluctuate between the two poles, or they are on a continuum and they feel parts of each to identify as a third unnamed gender, but they are neither trying to tell that they are males, neither they say they are females. Agender means they don't identify themselves as any gender. So they say that terminology is less used by our clients, but mostly they will say we are non-binary or gender fluid. So basically, gender, there is a terminology of gender identity or expression, then there is gender identity disorder, and there is gender incongruence. So when we talk about the gender identity, this is one's internal, deeply held sense of gender. So like for some people, their gender identity does not fit neatly into that what they actually feel like. So gender expression, which is another set of the thing that how they express themselves, gender identity is actually not visible to others. So like they may have a gender identity of a man or a woman or a boy or a girl, but their identity, it does not fit neatly in one of those two choices. But if you talk about gender identity disorder, we know that when we used to use the term gender identity disorder, then we were using the term gender dysphoria, but now we use the term gender incongruence. So finally, now what we use for most of our clients is the gender incongruence. Now, because this encompasses most of the things. So we say this is an umbrella term, which is used when the gender identity or the gender expression differs from what is typically associated with the gender, which is a designated gender. Gender incongruence is definitely the proposed name of the gender identity related diagnosis, and all patients who have incongruence may not have dysphoria. They may have incongruence, so they may not be feel what their assigned gender is, or they may not be feeling like that, but they may have dysphoria, they may be feeling uncomfortable, they may not be feeling uncomfortable. So then we have the term of gender reassignment therapy, gender reassignment surgery. These are the terms used when we give them therapy to help them change to the gender they are comfortable with. This is also called as gender confirming or gender affirming treatment. Gender reassignment surgery means when we are doing the surgeries for the surgical change in the patient's genitalia. So that we call it as a gender confirming or the gender affirming surgeries. Gender role. Now, gender role means behavior, attitude, and personality trait that the society designates. So like I told you, they may expect a lady to behave particularly in a feminine way. They may expect a man to behave in a masculine way. So this is what the society says, that this is a typical societal role of a man and woman. And if it is something different from them, the society may sometimes not agree to that gender role. So these are the basic terminologies. I've discussed most of it. Like some agender people say they have no gender. Bisexual means that sexual orientation that describes a person who is emotionally and sexually attracted to people of their own gender and people of other genders as well. And then we have the cisgender, means that what is the gender identity and the assigned sex at birth correspond. That is, patient is not a transgender. And gay person is a sexual orientation that describes a person who is emotionally and sexually attracted to people of their own gender. It can be used regardless of the gender identity, but most commonly it is used to describe men. Then gender identity is a person's internal sense of being a man or a woman or neither or another gender. That is identity. That is internal sense. It is not external. You cannot judge it from outside. How the person feels internally. Non-conforming means expressing a gender that differs from a given society norm for male or females. And then we have the queer. Queer means is an umbrella term which is used by some people who think of their sexual orientation or gender identity as outside of societal norms. Some people view the term as more fluid and inclusive than traditional categories for sexual orientation and gender identity. So that is a queer group. Due to his history as a derogatory term, it is not embraced or used by all members of the LGBT community. So some of the clients themselves use it, but most of the time they'll avoid using it. And when we talk about transgender, it actually means a person whose gender identity and the assigned sex at birth do not correspond. So it is used as an umbrella term to include gender identities outside of the male and the female. That is what we use it, the word transgender. Pangender means a person whose gender identity comprises of many genders. So they have the gender identity, which is like, they may be like male, female, transgender, all sorts. Pansexual means a sexual orientation that describes a person who is emotionally and sexually attracted to people regardless of the gender. So these are the basic terminologies. There are lots of terminologies, but if we understand this is going to help us to understand the treatment of our patients. So there are another two terminologies which are very important. What is the trans man or the transgender man? That is the female to male. So a transgender person whose gender identity is male, but the patient is actually born as a genetic female. That is a transgender male. A trans woman or a transgender female is a transgender whose gender identity is female, but she was born like as a male. So though she was born as a male, but she identifies herself as a female. So that is a transgender female. So we know that when we talk about gender dysphoria, or now we use the terminology gender incongruence, but all incongruence patients may not have dysphoria. People have tried to study this. This was a very interesting data where they tried to see the third order concepts. So they were trying to see the distress due to the dissonance or of the assigned and the experienced gender. So they were trying to see body dysphoria. Patients may have gender distress. They may have conflict of body and gender. They may have confusion. They may have denial and suppression. So sometimes they have denial of their transgender identity. They don't want to come out in the open because of many reasons. The society may not accept it. The family may not accept it. And many patients who come to us have body dysphoria. They don't want a body hair like in a male to female. They may not like the beard. They may not like the hair, body hair. So they may want to remove them. Or if it is a female to male, they may be not comfortable with their periods. So it is like patients may not have been comfortable with the thing which they are having. And there's a conflict of body and gender and they are confused. What's happening? Then there is another entity called as interface of assigned gender, gender identity and society. So this is distress due to misgendering, and inability to pass or blend would likely be associated with general disappointment, like feeling sad, or for some even suicidal ideations are there. A lot of patients who tell us that when we were not treated before that, we had actually gone to commit suicide. So these are the types of things they tell us. So that's why it's known also that they may have more of suicidal ideations, more of suicides. And even after treatment, it has been seen that the suicide rate is higher in transgenders. Then there may be a mismatch between the gender identity and the societal expectations. Conflict is always there. This is a very common problem. Then there is negative social consequences of gender identity, like isolation. They may say, oh, he's a transgender, this or she is a transgender. We will not be friends with this person. People don't want to give them houses. One of my transgender clients was asked to vacate overnight the house because she was a transgender. So these are the things people do have in their minds, and these are the problems they face. Internal processing of rejection and transphobia. So they fear rejection, sadness. They'll fear how the people will feel. Like in the college, the friends may stop talking to them. Parents may tell their children not to talk to them. There is hypervigilance for transphobia and internalized transphobia. This is one's own body might become persecutory. And for some transgender individuals who feel themselves constantly looked by others. So they feel that the people are watching them only, they are thinking about them because they are undergoing this change, they are being looked at. So all these things are there. So how to approach, how to help our clients the best? So we have a diagnostic criteria for gender dysphoria in adolescents and adults. We have a marked incongruence in one's experienced and the expressed gender, which has to be done by the psychiatrist, and the natal gender for at least 6 months in duration with at least 2 of the following. That is a marked incongruence between the expressed or the experienced gender and the primary or the secondary sexual characters. And also we know that they should have a strong desire to get rid of one's primary or secondary sexual characters because of the incongruence. And they want to have the secondary sexual characters of the other gender. So, which we have to see that they are not having any other personality disorder, they are not having any other psychiatric disorder, which may be looking like this. That is why a psychiatrist is important to see that they are not having any other reason for this, but it is primarily a gender dysphoria only. It's not that the patient is having some other personality disorder and they are just imagining that. Then we also have diagnostic criteria for gender dysphoria in children. But in our country at the moment for children, there are no specific guidelines. So most of us, like I don't treat kids or children below 18 years. I only treat them up after 18 years because as of now, we don't have the clear-cut guidelines for treatment of children with gender dysphoria. But in case we have to treat a child, only thing we can do is with the parental consent and the assent from the child is to give puberty blockers. That's the only thing which is there. But at the moment, most of us are treating adults who are more than the age of 18. But when we talk about children, we also know that children may not be persisters. So many of the children who have gender dysphoria in childhood may actually grow up and may not have gender dysphoria later. That is why we don't have to do any sort of irreversible treatment in them. If the children are to be treated, they are only to be given puberty blockers. Because the thing is that in case they grow up and they don't persist with the gender dysphoria, we are not supposed to do any of the treatment which is irreversible for them. So when we talk about children, it's a strong desire to be of the other gender, preference for wearing the clothes of the opposite gender, to playmates of the other gender, to strong preference for cross-gender roles, for toys, and a strong dislike of the one's own sexual anatomy and the physical characteristics that don't match with the patient's gender at the moment, but they want it for the experienced gender. So children must meet 6 of the criteria in addition to having distress or impaired functioning lasting for at least 6 months. So it's a very strict criteria. Now, whenever we talk about the goals of hormonal therapy, now we have basically what we are trying to do. If we are trying to do, suppose, trans males. So if we had trans males, means it is from female to male. So what we have to do is we have to reduce the female hormone level and we have to give the external hormones of the designated gender. So we have to reduce the endogenous sex hormone levels and reduce the secondary sex characters of the individual's designated gender. And so basically what we are doing is we are giving the sex hormones which are consistent with the individual's preferred gender identity. That is what we call as the cross-sex hormones. And we have to use the principle of hormone replacement, which we use for hypogonadal patients. So we are actually trying to bring their levels to the normal level of a male. So if we are having a trans male, means we are going from female to male. So what we are trying to do is we are going to build up their testosterone levels to the level of a normal male, and we are going to reduce their female hormone level to the level of a normal male, which should be low only. And very important is the medical provider should be knowledgeable, but that's not the only criteria. The other caregivers should also be knowledgeable. They should know how to talk to the patient, how to make them understand. They should not be looked upon as somebody who has come to your OPD who is something to be looked down, or you just have to make them sit separately. That should never be done. And we should also see the mental health concerns. So in between, like once we have a psychiatry reference done and we have made a diagnosis that there is nothing else which is causing the incongruence, it's just gender incongruence, even then in between, it's always a wise thing to have a psychiatry opinion if you're feeling that your client is getting some mental health issues, because hormonal therapy per se can also aggravate the mental issues, and they may be going through a lot of distress because of the family being not supportive, and many reasons might be there. So we also have to have people around you who know how to talk to them and take care of them. So we need to have a very, very strict criteria for hormone therapy, and the persons, like I said, we treat more than 18 years. They should be able to consent for treatment. Consent is very, very important. Patient has to sign a consent. We have to talk about their fertility options for future, because we know that patients need to be very clear that their fertility will be compromised. So they might not want to go for ovum banking in a female to male, that is trans male, or for sperm banking in a male to female, that is trans female. So we need to talk to them at the beginning of the starting of therapy about that very clearly. And we have to tell them what is going to happen to their body, what are the changes which are going to happen, and it is going to take time. We are going to go slow, and we are going to monitor them for any side effects which are recommended as per the guidelines. So we know that we have like a lot of other ways to see. There is one of this gender dysphoria scores, where we have the different response categories. For a female to male version it is, and this is for male to female version. So these type of scores are used for adolescents, where they try to see whether it is actually gender dysphoria or it is not. But in our country, unfortunately, the scenario is a little bit different. This is our data from our center, where we have this we published last year. We took around 43 female to male and 46 male to female. And what we have seen is they have come to us only after the age of 25 to 26, when they have become self-sufficient to earn. And if they are deserted by their families, they don't have problems to support themselves. Most of them have not been able to go further with their education because of multiple factors. One major reason being that they were not very much supported by their peer group. Most of them were doing good jobs, because whatever clientele we have are from companies and from tech companies also. So they are doing good jobs, but many of them have left education before 12th standard. And the family support system was also abysmally poor. That is a very, very unfortunate thing. But in my personal experience, I have seen in the past 14 years, ever since I've been working with transgender population, I have seen that the family support has been increasingly improving. And now more and more parents are coming with their children to help them. So that is a very good change which is happening in our country, because parents are getting educated, they are getting the information, and they are actually trying to help their kids. And many of my transgender clients are now staying with their parents, which is a very good thing, because that helps for their mental health as well. So the different things in our country are they present at later age. Most of the time when kids are brought to us, the parents don't want us to do any therapy. They just want us to make them not undergo the transition later. And as I told, that children can be persisters, or they may not have dysphoria after adulthood. So we don't have to give any irreversible treatment to them ever till they reach the age of 18 and are ready to give the consent. There is lack of information still in our country, and many of our clients do go to quacks for surgery. Follow-up is very difficult. It's intermittent. They don't come for hormone therapy even after taking the hormone therapy for some time. They default, or they do surgeries. They get orchidectomy done. They get the hysterectomies done. They get the oophorectomies done, but they don't come for follow-up, and they come with poor bone health. Many of them are not educated, but few of them are good. They are working in tech companies. Few of them are doctors as well, and they're doing pretty well in their career. Family support, as I told you, it's changing. The scenario is changing. Now, many of my clients have a good family support system. This is one of our own society guidelines. We have come up with a consensus statement on medical management of adult gender incongruent individuals who were seeking gender reaffirmation as female. And now we are going to soon come up with the male for the males as well. So initial evaluation should include a detailed personal and family medical history. We should see for any past history, any disease, any cardiovascular illness, liver problems, or any thrombotic disease, because all these are very, very important. Not to forget substance abuse and psychiatric illnesses and fertility desire, which is the most important thing, which I told you should be always discussed at every visit till they go for the surgery. Because if they do the surgeries after the sex reassignment surgery, then they won't be able to go for this. And later on, they should not regret. Medications, we should always know, because what happens many a time, they may not tell you, and they might be taking off-label medication. They may be taking overdose of the medication to see fast effects. So we should always ask that question. Examination, we have to examine our patient. We have to see that there is nothing else, because many a times there may be some DSDs who may be labeled as gender incongruence, but they may not be gender incongruent. So a karyotype is recommended. We have to do a genital examination. We are supposed to see with their permission for sure, because all these things are very important. Otherwise, sometimes there may be other DSDs which we may be thinking as gender incongruence, but they may be some other reason. So all these things are very important before we start giving them any therapy. So these are the physical effects which happens in female to male. When they transit from female to male, they get a deepening of the voice, clitoral enlargement happens, they have facial hair growth, their period stops after 5-6 shots of the testosterone injections, their breast tissue atrophies, and they have a decreased percentage of body fat compared to muscle mass. And when we have a male to female transition, we see that there may be some amount of breast growth. Sometimes they may not be very comfortable with that, and they may want to go for implants later. They will have decreased erectile function. This has to be told, because many a times, many of the male to female may not want this side effect. And this has to be told, because this is going to happen when we give them estrogens and give them testosterone reducing blockers, or testosterone like leuprolide and all, to reduce the testosterone levels. They'll have decreased testicular size, they'll have increased body fat compared to the muscle mass. So the take home is, first thing is diagnosis. Don't think that everybody who's walking into a clinic is a gender incongruence. Take a psychiatric opinion, examine your patients, do all the blood tests, because sometimes you may have DSDs who may be walking to a clinic as gender incongruence. I had a patient with Klinefelters who came as gender incongruence. So there may be lots of surprises, and we have to treat the basic pathology first, and then see whether they still persist with the gender incongruence, because then that becomes a separate diagnosis in itself. Understanding the issues is very important. We have to see what the patient has come to you. Sometimes they come to us and they say that they don't want therapy. They have just come to ask and inquire, and they want to know what can be done. And they want to know that, can I live like that? I don't want to take any hormones. I don't want to do any surgery. I just want to cross-dress. So that's fair enough. We don't have to start hormones for everyone. But if the patient has already done oophorectomy, hysterectomy, or they have done orchidectomy and they are devoid of hormones, then we have to give them mostly cross-sex for many of their cardiovascular, metabolic, and bone health. Social and family support is paramount. So social support is important. Support from your clinic staff is very important. And the way we talk to them is very, very important. And we have to see to it that the family supports them. I always make it a point to call the family members and talk to them, even if they are not very supportive. Many times we try to explain them, tell them that there are fertility preservation options, because this is a major thing in many people's mind when their children go for it, that we can preserve their fertility, we can do the ovum banking, we can do the sperm banking. So they sometimes agree to it and the things become better for the patient. So I think with this I end, and any questions I'll be happy to answer. Thank you.
Yes, ma'am. Thank you so much, ma'am. Thank you so much for the lucid presentation, ma'am. Ma'am, I have one question, ma'am. Like, what are the legal issues associated with it, ma'am? Like, when we give hormone therapy, what are the legal issues that can happen to a doctor, ma'am? Like,
yeah, legal issue is, first of all, the diagnosis should be clear. So diagnosis is we have to rule out any other psychiatric problem. So that is why we get a psychiatrist consultation. For starting the hormone therapy, we need to have one psychiatrist consultation who qualifies it that there is no other thing and it is gender incongruence only, which is the thing. So once you confirm, the psychiatrist will do it over a period of few visits. They will not do it in one visit, because one visit if they do, that's not how it is. They'll call for few sessions. It will take around 2-3 months. And after that, they start the hormones. And after that, the other thing is also we have to see that these patients sign a consent. So what I do in my clinic, I make them sign a consent, which we have made for these patients, and we tell them that this is what it is. They are doing it with their own will, because many times they don't come with their families. So we don't know how the family will come and talk to us. But these are all adults above 18, so they can sign a consent. We make them sign a consent, and we keep records of all our patients. Previously, we were telling them to get one affidavit also, to say that they are doing it with their own will, but now that is not mandatory, so we are not forcing them for that. So a consent would be a good thing, but a psychiatry reference is the must. And before starting any hormones, we should be very sure that our diagnosis is right. So a psychiatrist opinion along with our consent is the most important thing that we should have. So if we have that for medically hormone therapy, this is enough. When you want to go for surgery, then we again need a review with the psychiatrist, and one more psychiatry opinion is needed at that point of time. So then we need to do that. But we have to be very careful at every point of time, because many a times they may have, as I told you, some other DSD or something. Examination of the patient, doing the first investigations are very important. And telling them about the side effects is very, very important, because this will save us from lot of legal issues and problems in future. And fertility, never forget to talk about fertility, because sometimes I have clients who have never been told about fertility option, and they have already undergone orchidectomy, and they may then sue the doctor later, because 10 years down the lane they may plan for their own biological child. Then they may say, why you didn't tell me? Every visit we have to talk about this. Even when they are going for surgery, we have to talk about cryopreservation and those options, because this needs to be told to them again and again. Because what I have seen is, initially if you don't tell, or if you tell also, they are in a hurry to start hormones, and after 5 years they will say, oh, you should have told me. That time they don't realize. So we should tell it at every visit.
Thank you so much, ma'am. Ma'am, one more question. When we use HRT, hormone replacement therapy, for such patients, the dose of the drugs are the same as what we use for normal, or it is higher than the usual?
No, the estrogen, we normally use for male to female, we use estradiol valerate. So we start off with a dose of 1 mg, and then we slowly increase up to 6 to 8 mg. And we want to target the normal female range. When we have female to male, we give testosterone injections only, and we have to target the male normal range, but we go slow over a period of 3 months. So we start with 100, go to 200, and then increase to 250 till we reach the male target level. That is what we do. And the dose of estradiol valerate is much higher. What we use like 6 to 8. Most of my clients are okay with 6 mg, and their levels are maintained. And when we are using testosterone along with that, we also have to see that we have to follow for the side effects. And also same thing for the estrogens, because we know that there may be a lot of problems with the lipids, with the glucose values, with the hemoglobin, with the hematocrit, with testosterone. So all that has to be monitored every 3 months. Anytime you see a rise, we have to hold on at that dose or maybe reduce the dose. So we have patients who have come to us after the age of 40. So in those patients, first time if I'm starting, I start very low dose and I don't escalate the dose much much in them, because I treat them as per they would have been of their other, like if I have to make it of male to female, I'll keep the female level as she would be at age of 40. So like that I keep. I don't give them 6 mg and all at that age. But younger population, yes, we go higher and maintain in the female normal for a male to female. For female to male, we maintain the testosterone in the male normal range.
Ma'am, what about leuprolide?
We use a lot of leuprolide. We use leuprolide in the male to female, where we use leuprolide to bring down the testosterone levels, and we use leuprolide. I start with 3.75 mg once a month, and then we go on to 11.25 mg once in 3 months. And we continue using them till they go for orchidectomy. Some of them don't afford leuprolide, so we use spironolactone, and we escalate the dose with the monitoring of potassium. For most of the female to male, they don't need it, because what happens the moment we start giving higher dose of testosterone, their periods will stop, and they normally don't want to take leuprolide or other things along with that. Some of them who continue to menstruate, we also can use a lesser costly therapy like Depo-Provera to stop the periods. So that we use.
Right, ma'am. Thank you so much. Thank you so much.
Yeah.
Ma'am, just a quick question, like if some people are wanting early surgery, so even they are willing, we should not go for that.
Never. Before 1 year of, or at least 1 year of hormone therapy, I actually insist little bit more than that only, because see, surgery is irreversible. They are always in a hurry. Never ever go with the patient's hurry. Always see that what are the guidelines. Let us be legally safe about it. So we never go with the patient's thing. We go with the therapy. That is, we give 1 year of hormonal therapy. After that only, with a new fresh psychiatrist consultation, they can go ahead with surgery.
And other, like they also want some plastic surgery, for some facial.
That they can do. For that, we don't need 1 year. It is only for the genital surgery we need 1 year of hormone therapy. That is up to them, but they have to sign a consent with the surgeon.
But after hormonal therapy, I think a lot of facial features also improve, especially the fat.
Absolutely. Yeah. So what I tell my patients, don't go for any breast surgeries or any facial or fat surgeries till 1 year. You see the effect first and then decide. That is what I tell my clients, because many times they want to go for surgery within a month, within 2 months. I tell them never do that. Wait for some time, let the effect show up. Let us see how the fat distribution changes. Let us see how much of the breast growth happens in a male to female. I tell them wait even for breast implants and then see, because what happens, they are in a hurry for everything, and that is not correct. They end up wasting more money and not getting the results. So I always actually counsel them, but there is no guideline that they cannot go before that. They can go if they want to for cosmetic surgeries, but for genital surgery or the sex reassignment surgery, minimum 1 year of hormone therapy is required and a repeat psychiatric consultation before they can go for surgery. So we need 2 psychiatric consultations for that.
One more thing, like more practical questions, like when they change their gender, their Aadhaar card, all those identity cards.
Everything is possible. Yes, they get a Aadhaar card. And the government has the guidelines for that. We have to write that they are on hormone therapy, and the psychiatrist consultation is attached. They have to give a letter, and it is done. It is possible. It is done.
Like when we are starting, that time only we can proceed with that also. Like
we can proceed. Yes, if the patient wants, we can proceed that time, or after the therapy when they want, we do that, and it is possible. Some formalities are there. We have to give letters. Endocrinologist has to give letters. Psychiatrist has to give letter. But it is possible, and it is done for most of my patients. Actually, one of my transgender client is the first transgender in Karnataka to get a driving license as a transgender. Okay. So they are getting it. Yeah.
You can share those these forms and documents.
Ma'am, are there any Indian government guideline for it?
See, Indian government as such guidelines are not there. We have guidelines from our endocrine society, but this is approved therapy, means it is allowed. It's not that we are doing anything against the law. This is all approved. We are allowed to do this as per the guidelines. But as I told you, below the age of 18, we don't have any clear-cut guidelines at the moment. So that thing is something which is a gray zone for us at the moment. So if at all we have to do, we can only give puberty blockers, but we have to be very, very legally careful with that, because they may not be persisters. So that is why nothing irreversible should be done. If at all, you can give puberty blockers, and once they reach the age of puberty or adulthood, 16 to 18, and they decide not to go for it, you can as well stop it and they can progress with normal puberty. And that is what the international guidelines also say. For children, we are only supposed to use puberty blockers. And once they are in like some countries, it is 16 years, then they can decide for cross-sex hormones, not before that.
Thank you, ma'am.
Thank you so much for enlightening us.
It was nice. Yeah, an interactive discussion. I'll send those forms. We have
one question I have.
Yes, ma'am. Thank you, ma'am. Thank you so much.
It's a really tough area and difficult.
This is Lokesh. I have
In
one
this
question.
area, we cannot practice just by reading sort of thing.
Mayur, Lokesh wants
Yes.
Lokesh has a question.
Yeah, please speak.
So are you routinely offering cryopreservation for the patients who are undergoing?
I have told you in my data, I'm offering, but many of my clients are not affordable at all. Now I'm forcing them to go for sperm banking as well as ovum banking. I have talked to our infertility center, and they are giving them a good lesser cost to do that. And I am actually forcing them to do it because later on, 5 years down the lane, 8 years down the lane, they will not be the same what they are today. And that time they may decide that, oh, I want to have my own biological child. Then the problem starts. So actually I'm making them go there and do it. I tell them, do it. If you don't want later, don't use it. If you want, you can use it. So actually I'm doing it. Cryopreservation, not many of my clients have done, very few. They can't afford. Many of them don't want to go for it. Initially, they say, we don't want. The first response will be, we don't want. But I always counsel them. I make it a point to counsel them 10 times. And every visit I tell this, because 5 years down the lane, I know they will not think the same way. I know that. So I have clients who have been following for 10 years now, and I know how their thinking pattern has changed. So we have to tell them. I have talked to my infertility center who are good enough to give a concessional rate for them. So we have packages for them for 3 years and all that. So they get a good rate. So many of them do now, because as I told you, their affordability is becoming better. So I have clients who are affording it and who are ready to do it now.
That infertility center is in your
one more question. Last question. So each visit, how do you document all these things? You counsel so much, like at every visit about all these aspects. Like in a busy OPD, how do you have any performance like where?
We tell them to do the test. So that always written in the prescription and given to them. Records, it is written that they have been asked to do these tests. We always write that the fertility options were discussed. That is always documented. And when we start the hormone therapy, we take a consent form where we tell all this, that patient has been told about all the side effects and the fertility aspects, and they are aware of it, and they have taken an informed decision after knowing all these facts. And they have been asked to come for regular follow-up, which they are supposed to come. So because in case they don't come up, I had one client who landed up with a posterior circulation stroke because I wrote some dose of testosterone, and they never came to me for 2 years. And they took some very, very high dose. Like every week he was taking some 250 mg of testosterone, which was without our information, not that we were involved in it. And the client was also smoking. So I actually see that they don't have these addictions as well. And that client actually landed up with a stroke. So that is why we have to be very cautious. We always write less and the correct therapy. But sometimes you may have patients who may not come back. But then it is not your fault. Then the patient has decided, because I have clients whom I write 1 mg of estradiol valerate to start with, they start taking 6 mg on their own. So that all can be
that patient. I have seen him couple of times. He like kind of shuffles between Manipal and Mesra.
All of us know him.
I have such 7-8 patients.
Another question, ma'am. I have another question.
What they do, ma'am? Like they follow internet. They have some groups, and
Absolutely.
And they ask them like what all they have done.
Yes.
So, for example, if you write just Liprolide, they will also add testosterone, spironolactones, all the possible.
And one of my patients was taking Diane with Proginova, with Liprolide. What can you do? So you have not advised. So then it is not your fault. See, we have to give them the right advice, tell them the right set of investigations. Rest of it, if it is time, and you always write the duration. I always write the duration. I write follow-up in 3 months. Duration, please issue medicines for 3 months. I always write it because sometimes they may overuse and not come back for follow-up.
But we need to document this because they are misusing some drugs, and they can put blame on us.
Absolutely. We have to be very careful for this.
Thank you for enlightening us, ma'am, so much. And we still have one session to go.
Okay. I'm so sorry. Okay.
No, the session was very interesting. I believe this was the only session which has the maximum discussion.
Okay. Thank you, Dr. Mayur, and thanks everyone. I really enjoyed it. Yeah.
So moving on to next session, the team, can you just play the a recorded session we had skipped in between? The introduction slide, please. Can we have introduction slide for Dr. Anurag sir? Dr. Anurag Vajpayee from Kanpur. His session was scheduled at 5:20. Yeah. So let me have the privilege to introduce, though sir could not come live. He has sent a recorded session for us. So he's Dr. Anurag Vajpayee is a consultant endocrinologist. He has done his MBBS, MD, and FRACP. He is presently working with Regency Hospital at Kanpur. He has various achievements and awards, and most of us would have heard him because he is very active in online, and he has his own courses with Grow, and he has his own a big fraternity for the pediatric endocrinologists. So with this, we can start the session. This would be a recorded session, so we won't have discussion after these questions. Yeah, please.
Good evening, everybody. And today I'm really thankful to the entire team of Hormone India for inviting me for this wonderful program to connect with people across the country and in fact the globe, covering on a very, very important topic of neonatal hypoglycemia. And we all know that hypoglycemia is a common condition. Most of it is a transitional scenario in which not much evaluation is required. Largely, we talk about the management of hypoglycemia, but in certain scenarios, it can become complicated, which I'll highlight through these two cases, which makes it really relevant in terms of the appropriate evaluation and management of these conditions. So we have this 6-day-old girl with hypoglycemia who had a birth weight which was normal. Ketones were negative. So there was a non-ketotic hypoglycemia. The reducing substances were negative in this scenario, and there was a confusion because insulin was detectable. Growth hormone levels and cortisol levels were also low for that particular timing as far as hypoglycemia is concerned. Now, when we talk about critical samples, we all know that we have to use specific cutoffs. So we expect the growth hormone to be above 10 and cortisol to be above 550 during hypoglycemia, and we also expect insulin to be undetectable. So what is this case really? Is it hyperinsulinism because insulin is detectable, or is this a multiple pituitary hormone deficiency wherein we have got an inappropriately low level of growth hormone and cortisol for the level of hypoglycemia? And that is something which is very, very relevant from that perspective. The child was diagnosed as multiple pituitary hormone deficiency, but when we looked at the other parameters like ketones being negative, we thought that this is unlikely to be a pituitary problem, and we thought of hyperinsulinism. And then we conducted a glucagon response and gave glucagon, which resulted in an increase in glucose levels, suggesting this was hyperinsulinism rather than a multiple pituitary hormone deficiency. So while we are evaluating individuals for neonatal hypoglycemia, we need to consider the holistic clinical picture and use tools which may cause more definitive diagnosis in certain scenarios. So neonatal hypoglycemia is common. Approximately 1 in 40 children will have it. Most of this is physiological in the first 48 hours of life when there is transition happening, but there can be a significant pathology, of which hyperinsulinism and multiple pituitary hormone deficiencies are the most important causes from a chronic perspective. So we'll dwell a bit on that regards. This, unfortunately, is often missed with significant consequences in that regards. So over the next 15 or 20 minutes or so, I'll talk a bit about the pathophysiology of neonatal hypoglycemia, its causes, evaluation, and particularly about how to assess, approach, and manage these cases. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of resources related to pediatric endocrinology, including a number of courses, which include fellowship and diploma courses, both hybrid, online, and offline mode. We have got publications which provide a summary of all these courses, along with the mobile application which provides instantaneous guidance and point-of-care assessment and management of complicated pediatric endocrine disorders. So to start off, we all know that the fetus is entirely dependent on glucose as far as energy needs is concerned, and this glucose entirely comes from the mother through a passive gradient using the GLUT transporter. So 80% of energy needs of fetus are met by the glucose, and fetus is in a state in which it is wanting to build the overall body, having an anabolic phase. To ensure this, there is two very important mechanisms. One, insulin cannot cross the placenta, and this is important because if it crosses, it will have a devastating impact in situations where there is a maternal increase in insulin level, let's say, because of insulin resistance. The second important thing to remember is that during pregnancy, so as to extract the maximum amount of glucose from the mother, the placenta produces the hormone known as HPL, human placental lactogen, which induces insulin resistance, raising the glucose levels in the mother, and this provides a greater amount of glucose to enter the fetal circulation. So fetus has got a lot of glucose. When you have excess of metabolite, when you don't have to use it, you will store it. So this stimulates insulin secretion and inhibits glucagon. And it is this increased insulin to glucagon ratio in the fetal period which really causes fetal growth along with glycogen deposition. Now, most of this glycogen deposition happens in the last trimester. So preterm babies would have a higher chance of hypoglycemia because they have less glycogen stored, so to begin with. Now, as soon as the birth happened, there is a watershed area. You are continuously getting supply from the mother and this is cut. So you have to depend upon all the resources the fetus had accumulated over the last 9 months or so. So in this scenario, there will be, of course, a dip to begin with. And the first response to happen is the secretion of counter-regulatory hormone epinephrine, which will cause decrease in insulin, and this will also cause increased level of glucagon, resulting in production of glucose, largely through glycogenolysis, gluconeogenesis, and very limited aspect of lipolysis, particularly in the first day of life. So in the first day of life, hypoketosis is a norm. So while we say ketone is a very, very important investigation as far as workup of hypoglycemia, we should remember that in the first day of life, ketone levels may actually be low throughout the time, and we don't need to worry or get concerned about that in that perspective. Now, as discussed, there is always a dip which happens around 2 hours of life as far as glucose levels, and then they stabilize by 48 hours. So what I'm trying to say is that in the first 48 hours, it is very likely that there may be a hypoglycemia which may happen because of a maladaptation. This will be particularly likely if somebody is preterm with reduced store, somebody who is SGA, somebody who has a lot of perinatal stress. But beyond 48 hours, the entire mechanism of glucose regulation, including the 4 counter-regulatory hormones, glycogenolysis, gluconeogenesis, and lipolysis are established. So after 48 hours of life, we can say that this neonate from a physiological perspective has nearly become an adult and should be able to sustain at least 6 hours of fasting, which should not cause hypoglycemia. So any problem in the first 48 hours may be transitional. Beyond that, we have to think of pathology. Now, this dip is much higher in preterm infants, and this is something which we all are aware that there are more risk of hypoglycemia from that perspective. So when we talk about glucose metabolism, we talk about 3 major organs: liver, which is a major store of glycogen, kidneys, which produce a lot of glucose through the alternate sources through gluconeogenesis, and of course, the fatty tissue, which produces ketone, which is an alternate source of energy in that perspective. Now, the major hormones which regulate, of course, there is one hypoglycemic hormone, insulin, which causes reduction in glycogenolysis, gluconeogenesis, and lipolysis. And there are 4 counter-regulatory hormones, glucagon, cortisol, epinephrine, and growth hormone, which contribute differentially with regards to increased lipolysis, glycogenolysis, gluconeogenesis, and inhibition of glycogen synthesis. And all these processes contribute to increased glucose levels. So the physiological evolution clearly is in the form of one scenario wherein the hormone that causes hypoglycemia is only single. There are 4 counter-regulatory hormones. Hence, deficiency of one of those counter-regulatory mechanisms is not expected to cause hypoglycemia. You need to have a combination of at least 2 hormones. That is why only when you have multiple pituitary hormone deficiency will you have hypoglycemia. So from an endocrine perspective, hypoglycemia can happen if you have excess of hypoglycemic hormone, that is insulin, or deficiency of hyperglycemic hormones, namely growth hormone and cortisol. Epinephrine and glucagon deficiency do not occur in a primary scenario. They are largely manifestation of long-standing type 1 diabetes, where there is a hypoglycemic unawareness which happens in that perspective. The typical presentation, however, if you talk about hyperinsulinism, would be one in which body is needing a lot of glucose. So you need to have a high glucose infusion rate, typically about 12 milligram per kg per minute. And because the ketone production is inhibited, you will have non-ketotic hypoglycemia. On the other hand, deficiency of the endocrine system will result in ketotic hypoglycemia. And if there is a combined defect, you will also have hyponatremia, which is common. Glycogen storage disease typically do not present in the neonatal period. They will present with delayed onset ketotic hypoglycemia with significant hepatomegaly, while fructose bisphosphonate defects are extremely unlikely. Multiple pituitary hormone deficiency will cause hypoglycemia along with micropenis, midline defects along with cholestasis, and fatty acid oxidation defects will cause episodic hypoketotic hypoglycemia. This brings us to the central point that the most important investigation in a child who presents to you with hypoglycemia is the ketone levels. If a child is hypoglycemic, he should be ketotic. If the ketones are absent, we are dealing with either hyperinsulinism or fatty acid oxidation defect in that perspective. So neonatal hypoglycemia can be classified into decreased production, where if you just give the routine physiological replacement of 6 milligram per kg per minute, you're fine in terms of response, or increased utilization where the glucose requirements become a bit more. Decreased production can be because of a substrate defect like prematurity or small for gestational age, or because of a metabolic defect like endocrine deficiencies, which are multiple pituitary hormone deficiency associated with features like micropenis, cleft lip, cleft palate, neonatal cholestasis, or metabolic defects which present with hypoketotic in the form of galactosemia, which has cataract as an important association. Increased utilization can be because of increased need because of sepsis or cardiac failure or hyperinsulinism, which is the most common chronic form or persistent form of hypoglycemia in the neonatal period. This is typically non-ketotic. It may be transient because of maternal diabetes, RH incompatibility, and intake of drugs, typically resolved by 1 to 2 weeks of life. Prolonged form typically resolving in 6 to 8 weeks of life, and this is one of the most common causes typically seen in a small for gestational age stressed infant who has hypoxia, which induces the pancreatic growth causing hypoglycemia. And finally, the persistent form, which include the genetic causes, the potassium ATP defect, along with the other metabolic parameters which are lifelong. So essentially, if we talk about chronic hypoglycemia, we're talking about hyperinsulinism. Small for gestational age, stressed baby, think more of a prolonged hyperinsulinism. Severe hyperinsulinism, which is persistent, think of a potassium ATP channel defect in that regards. Other differences, of course, easy to identify. If you have micropenis, midline defect, cholestasis, think of endocrine defect. If there is cataract, hepatomegaly, think of a possibility of a galactosemia in that regard. The most important clinical clue, of course, is how much glucose are you needing in that perspective. Now, inherent forms can be because of the defects in the on-off button of insulin secretion, which is the potassium ATP channel. This could be a mutation in the KCNJ11 or ABCC8. These typically are severe forms associated with the macrosomia, and they do not respond to diazoxide. And as we'll discuss, diazoxide responsiveness is a very, very important clue overall with regards to the diagnosis in that perspective. Now, we now identify that inheritance decides about the way a child with hyperinsulinism will behave. So if there is a paternally inherited mutation, it is more likely to have a focal form which can be removed and surgery can be done. While if it is a recessive mutation, it is usually a diffuse form in which the whole pancreas is to be removed in that perspective. So if you have a diazoxide non-responsive hyperinsulinism, get urgent genetics done, which will give you a diagnosis. If you have a paternal gene defect, it will be a focal form, while if it is a recessive form, you need to do a more comprehensive pancreatectomy in that perspective. Other defects include glucose sensing in the form of glucokinase, GDH defect, which causes hyperammonemia. So ammonia levels, if they are high, will give a clue towards this diagnosis. And you, of course, have this CAD defect in that regards. So now we have discussed about the various forms of hypoglycemia. The key questions now are, is it hypoglycemia? What is the classification, decreased production or increased utilization? And finally, what's the cause? So for hypoglycemia, we need to understand that we need to have a broad index of suspicion. Any clinical features, a child not appearing well could be a feature of hypoglycemia, but particularly if there is seizures, unexplained cardiac failure, apnea, think of hypoglycemia. Plus, we need to be cautious to identify it at the right time in infant or diabetic mother, pre and post term, large or small for gestational age, birth asphyxia or sepsis, cardiac defects and micropenia. These all infants need to have a careful evaluation of the glucose level, particularly in the first 48 hours of life, as we discussed earlier. Now, when we talk about further evaluation, so we have established hypoglycemia. Do we evaluate everybody? No. Beyond 48 hours with high glucose requirement and absence of risk factor makes it very important to evaluate from that perspective. Now, we need to remember that there are no particular cutoffs as far as hypoglycemia is concerned in newborn period, because we cannot have the typical Whipple's triad because symptomatology and response is different. So we use operational thresholds as to when should we worry about glucose levels. So glucose levels which are below 25 in the first 4 hours, between 4 to 24 hours, between below 35, 24 to 48 hours below 50, and beyond that below 60 are a cause of concern. Of course, if an infant has a low glucose level and is symptomatic, these issues do not matter. You have to evaluate. But if somebody is asymptomatic, you have to use 25 in the first 4 hours, 35 between 4 to 24 hours, 50 between the next 24 to 48 hours, and then finally below 60 in that perspective. Now, once we know that this is hypoglycemia, the question is it decreased production or increased utilization? Look for GIR. In general, if it is a production issue, you give 6 milligram per kg per minute, you would be able to maintain glucose. But if the utilization is high, the GIR will be high in that regards. Now, finally, the cause. So start with the birth weight. If a child is macrosomic, it means there is an antenatal insulin excess. It is either a diffuse potassium ATP defect or a Beckwith-Wiedemann syndrome in that regards. Low birth weight suggests prolonged hyperinsulinism because of SGA, while normal birth weight suggests rarer forms of hyperinsulinism. Transient forms can be because of maternal drugs like beta blocker and terbutaline, RH incompatibility or birth asphyxia and maternal diabetes. Prolonged forms can happen in the 2 to 6 week phase with asphyxia, particularly SGA and prematurity and cardiac illness in that regards. If there is micropenis, think of a multiple pituitary hormone deficiency or rarely adrenal hypoplasia congenita. If there is hepatomegaly, think of hyperinsulinism, Beckwith-Wiedemann syndrome, and galactosemia. If there is pigmentation, think of congenital adrenal hyperplasia or adrenal hypoplasia congenita in that regards. And of course, if there is cataract, think of galactosemia. If there is neonatal cholestasis, think of multiple pituitary hormone deficiency and galactosemia. So a careful clue to look for genital examination, eye for icterus, skin for pigmentation, and the liver examination will give you a diagnosis in most scenarios. Now, coming on to the most important part of evaluation, always look at the critical sample. So when a child has hypoglycemia, we expect the insulin levels to be undetectable, the ketone levels to be more than 2, the cortisol level to be more than 550, and growth hormone should be more than 10. This is what critical sample is. So you have to collect these samples when somebody has hypoglycemia. Now, in that scenario, if insulin is detectable, this suggests hyperinsulinism. If ketone is low, think of insulin, galactosemia, or fatty acid oxidation defect. If lactate is there, think of a rarer form of glycogenic defects, which are unlikely at this age group. High cortisol or low cortisol or low growth hormone will suggest multiple pituitary hormone deficiency. So always interpret these critical samples with regards to the timing of the sample in that scenario. Undetectable insulin. So look at other parameters of hyperinsulinism in the form of a high C-peptide, a hypoketotic state, and a glucagon response, which is the gold standard, which we showed in our first case in that scenario. Other clues could be hypokalemia and a high GIR. So don't just go for insulin levels. Even if the insulin levels are low and you have a high suspicion of hyperinsulinism, look at C-peptide, which is a more robust marker. Look at ketone in that perspective. So finally, about approach, If your ketone is low or absent, look at reducing substance. If it is positive, it is galactosemia or fructose intolerance. If it's negative, look at insulin levels. Undetectable insulin is fatty acid oxidation defect, and detectable is hyperinsulinism. If the ketone levels are high, look at lactate levels. If it's high, it's GSD1 or gluconeogenic defect. If it's normal, look for organomegaly to identify rare forms of GSD, and finally go for cortisol and growth hormone. So ketone is the most important investigation. Absent ketone, absent reducing substance, go for insulin in that scenario, and you will identify that. We'll quickly run through a few cases to finalize this presentation. A 3-week-old boy with seizures and hypoglycemia. Ketones were present, lactate level were normal, and there is hyponatremia. So there are two defects, hyponatremia and hypoglycemia. So we look into micropenis, and this clearly suggests that this is a multiple pituitary hormone deficiency. 3-week-old boy again with failure to thrive, hypoglycemia, low glucose requirement with hepatomegaly. Now this is an important clue. So there is hepatomegaly, ketones are negative. So now we start thinking of hyperinsulinism. But before that, we have to look at other aspects. So 3-week presentation, irritability, hepatomegaly, non-ketotic, always think at the possibility of galactosemia, which was present in this scenario. 14-day-old boy with birth asphyxia in the ICU, hypoglycemia, high glucose requirement, indicating more towards hyperinsulinism, non-ketotic, detectable insulin. So this is hyperinsulinism, but remember this is a SCA who has birth asphyxia. This is a prolonged form, and you have to be careful in terms of evaluation. Probably will require diazoxide for some time. 12-day-old boy with lethargy, again hypoglycemia, which so look carefully. Dioxide. So how do you manage a child with hyperinsulinism? If it's transient or prolonged, think of dextrose and diazoxide. If it is persistent, then go for diazoxide treatment. Start from 5 milligram per kg per day, go up to 15 milligrams per kg per day. And if it's present, you continue diazoxide. Look at ammonia to identify the hyperammonemia syndrome. If there is no diazoxide response, this is an emergency. Best to get an immediate potassium ATP genetics, which if shows a recessive defects, suggests that you can give either octreotide or do a palliative surgery after you have, because there is no other option. If there is a paternal defect, or there is no defect, or there is Beckwith-Wiedemann syndrome, better to go for an imaging modality like fluorodopa PET, which if suggests a focal lesion requires surgical resection. If there is a diffuse lesion, requires palliative surgery. So management largely depends upon diazoxide responsiveness, and genetics now has changed the way we manage in that perspective. So on follow-up, on a good dose of diazoxide, no response, hypoglycemia persistent, started on glucagon, potassium ATP defect was found, and this child will require a lot of management in terms of surgery or other management. 10-day-old boy with hypoglycemia, birth weight was normal, GIR was high, non-ketotic, so this is again hyperinsulinism. Started on diazoxide, on follow-up, good response, good dose, no response. So they were found to have a paternal potassium ATP defect. So this is a likelihood of a focal form of hyperinsulinism. So here, better to get a fluorodopa PET, which can be removed. So if there's a focal lesion, you remove it, the child will be fine from that perspective. 15-day-old girl with hypoglycemia, birth weight was 3,200 grams, high GIR, non-ketotic, insulin levels slightly high. So this again is hyperinsulinism, which we're looking at, and ammonia is high. So this is the hyperinsulinism, hyperammonemia syndrome. So just to summarize, hypoglycemia is common in the neonatal period if it is persisting beyond 48 hours of age. If there is, along with that, you have got other features which suggest chronic causes you need to evaluate. If the GIR is more than 12. The most important evaluation is blood ketones, which decide about further evaluation. Ketone negative, think of hyperinsulinism, fatty acid oxidation defect. While if it is ketone positive, think of an endocrine cause versus organic acidemia in that perspective. Very importantly, when you diagnose hyperinsulinism, remember that insulin levels are not very reliable. Look at other markers, high GIR, negative ketones, along with a good glucagon response, which may give you a clue in that perspective. If you diagnose hyperinsulinism, which is prolonged or persistent, start on diazoxide. If there is no diazoxide response, then you should go ahead with a further evaluation for genetic study, which will guide whether it is a diffuse form or a permanent form. So basic evaluation, identification of hypoglycemia at the right time, evaluation for hypoglycemia causes, and management becomes important on that perspective. So at that point of time, I'd like to thank all the viewers for this patient hearing and thank Hormone India again for inviting me for this presentation. Good evening, everybody. And today I'm really...
Yeah. So with this session has ended, and sir could not be is not live, so we cannot have any discussion. So with this, we come to an end of day one of Hormone India Virtual Conference 2022, and we have discussion on neonatal disorder, on growth, bone, and DSD, puberty. Lot of genetic involvement was there, and peds endo is actually really the toughest part of endocrinology, and it is not easy for us to know all those things. Even it's not like it's much deeper than what has been discussed today. Even beyond this, peds endo is really vast topic, but certainly after this, all those talk, we have become wiser, and we need to know much more than this too. With this, I declare the end of day one, and the vote of thanks would be, I'll hand over to Dr. Tony for that.
Okay, thank you, Dr. Mayur. So today was really an exhaustive, lucid, and informative session of pediatric endocrinology. So we would like to thank all our speakers and chairpersons for accepting our invitation and for being with us and supporting us for this event. I would like to thank all the delegates. Like I understand, more than 1,000 delegates have attended this pediatric endocrine meet. So thank you all the delegates for attending our meet. I would like to thank RX Events also for hosting us, for giving the technical support. And also, last but not the least, I would like to thank each and every member of the team for supporting us in organizing this event. So thank you all. So I'll call this a day, and tomorrow we'll be coming again at 9 a.m. with diabetes. So the whole day will be dedicated to diabetes. So please do join in tomorrow. So once again, good night and thank you all.
Thank you, everyone. Thank you.